See the very different part of the vermis. Look at the shape of the. But was there was some problem?
Yes, please.
See a very bumpy cortex. Share this. Okay. Can you see my screen now?
Yes, go ahead,
Okay.
please.
Early neuronal migration. Let us try and see what early neuronal migration.
Yes, go ahead,
Okay.
please.
So okay. Now let me show you so one different case of dystroglycanopathy where you have got the severe ventricular megaly neuronal migration disorders, very small, thin absent septum pellucidum, dilated occipital encephalocele, and whatnot. Let us try and see how these. This is a case of muscle eye brain disease, like a Warburg spectrum. You can see a very bumpy cortical surfaces. You've got quite a small vermis. Just look at the very small vermis, which is quite bad. Severe vermian hypoplasia and also heterotopia, which is all visible right inside the cerebral cortex. So this is what a classical pathological confirmation by whole exome sequencing that it was a muscular dystroglycanopathy and muscle and eye brain abnormality.
Sumesh,
Now here is
someone of the core analysis, I don't know if it's your.
Mauricio, you are mute. Okay.
Yes,
Now you have
yes.
got a polymicrogyria as well as a smooth brain, and this is exactly what which is just look at autopsy specimen. Very smooth brain here. Look at the sulcation and all also different notches and abnormal microgyria. Look at this. You have got one, two, three, four, and five. So you can count one, two, three, four, and five. That's the value of ultrasound machine. It can produce exactly of the things. Now just look at the microcephaly specimen. Good cerebral cortex, thin. This is 25 eca, 25 millimeter of the cerebellum. Look at the surface of the brain, which is a space of specimen of microcephaly. Callosal anomalies. This is normal corpus callosum, absolute absent corpus callosum, partial ACC, and this is also case of partial ACC. But look at the pericallosal artery, and that is one of the important marker to identify. Normal CC, you've got a partial ACC, a small bit of pericallosal artery, same bit of pericallosal artery. This is dysgenetic. Look at the course of pericallosal artery, which is absolutely dysgenetic, and sundry appearance, which is just sundry appearance, just like incomplete absent corpus callosum. This is a case of absent septum pellucidum, and actually a case of absent septum pellucidum. You can see there is no septum pellucidum, and still you can see what happens in septopreoptic holoprosencephaly. A phonesis, two separate phonesis, but look at this. This is fused. Absent septum pellucidum. This is classic case of septopreoptic holoprosencephaly, and that's what is going to be typical thing to identify. Okay, many coronal sections which you can identify. A bit of posterior foci malformation. Let me go straight back to the posterior foci malformation. Now, this is normal vermis. See the very different part of the vermis. Look at the shape of the fastigium. Look at the choroid plexus. Look at this place. Much more wide angle, bit of inferior vermis, which is completely absent. Look at the specimen of the inferior vermin hypoplasia. One of the one of the part of vermian hypoplasia, a small little vermis. The placement of the choroid plexus is completely disorganized. Look at the vermis, which is much smaller, but the look at one of the point is isthmus. Here the isthmus is close, very close. So this is not a case of Joubert syndrome. In Joubert, this is going to be a classic case of open isthmus, and this is vermian aplasia. There is no, vermian agenesis and vermian agenesis, and the difference between vermian agenesis. This is a Blake pouches. Look at the fastigium, which is quite normal, and but I would like to point out a case of what is the difference between the normal vermis, vermian hypoplasia, vermian agenesis, and vermian aplasia. This is Joubert. No vermis which is visible at all. Two separate hemispheres which are there, and this is the Joubert syndrome. And if you cut it open, this isthmus is quite wide apart, and this is open isthmus, which Ritsukopu has come out with an open isthmus paper, which can be seen right in the first trimester. And this is Joubert. So Joubert is a complete vermian aplasia and Roman kyphelosynopsis, ultrasound, normal vermis. This is autopsy specimen of Roman kyphelosynopsis. This is 3D of Roman kyphelosynopsis. A 3D has a brilliant power of ultrasound. Cerebellar hemorrhage. This is how the cerebellar hemorrhage will appear, normal cerebellum. So the autopsies will give you a lot of insight of how to look for these things, and it will correlate clinically. So if possible, learn the autopsy, because why you want to learn on autopsy, because ultrasound is representation of anatomy on the screen, and the fetal autopsy will make you understand about the pathology rather than imagination. You see them directly on the screen, and that is the reason I will always prefer learn anatomy, learn embryology, then you can learn fetal neurosonogram. Thank you very much for patient hearing. Thank you. Over to you, Mauricio.
Okay, the next participant. And let me say something. Professor Roy Birbaum, okay, from Israel, and his lecture is going to be CNS embryology.
And fantastic images, Prashant, in your previous talk. Congratulations. I'm going to speak about a very specific chapter in brain embryology, which is the development of the midline, and I will divide my talk into the embryological part to try to go through the basic stuff and to try to simplify things as much as possible, and then we will move to the early neurosonography. So we are going to focus today on very small and early brain structures. Now, before we start, I would like to say that the information that I'm going to show you is only for educational purposes, which does not represent any official guidelines or legal standards, and you're not expected to perform these imaging and these ultrasound examination in your routine scans. This is for your to encourage you to learn more and to know more about the brain. Now, when I'm going to show you and I'm going to teach you some embryological landmarks and developmental steps, and if you are going to go deep, if you wish to learn deeper about the development of the midline, these are your tools. You should be familiar at least with these 2 textbooks and these 4 papers, and I'm going to go over, I'm going to show you developmental events which are based on data that has been published on these papers. And I think that no one can talk today about the development of the corpus callosum without knowing this fantastic pioneer and important paper from 1968 by Rakic and Yakovlev, which paved the way for us to understand how the midline structures and commiseration works. And then, of course, by Charles Ribot and Linda Richards and her group were the people who showed us the way. So these are at least the papers for you to start with. Now, in trying to simplify things, I will try to put it in a methodological way. So if you look at this illustration, this is a mid-sagittal cut. You have a left side view on a right hemibrain, and let's focus on these areas. Okay, these are the areas of interest, and I'm going to talk about a very specific time frame, which is around 10 to 14 or 10 to 13 gestational weeks, not embryonic weeks, because we are gynecologists, so it's easier for us to understand things in gestational weeks. Now, if we zoom in to this area, what we can easily see is we all identify the lumen of the third ventricle, and the reason we see the lumen is because we are cutting exactly through the mid-sagittal, through the middle of the neural tube. So the lumen here is the mid-sagittal area, and this is where the thalami and parts of the basal ganglia will develop on both sides. But along the wind line, you have the protrusion of the massa intermedia of the thalamus. Another important area for you to recognize is the Monroe, and for us on ultrasound, it's important because the Monroe is filled with fluid as opposed to the surrounder structures which are non-fluid. So the dark hypoechoic area of the Monroe is a good landmark for us. And then we should put our eyes on the anterior most wall of the third ventricle, the point where the neural tube has closed and it gives rise to the wall, the anterior wall of the third ventricle. Now, which structures we see here? If we divide this thin wall into, generally speaking, two areas, the ventral area, which is called the lamina terminalis, it's quite thin and small, and the upper, the more dorsal area, which becomes thicker and more prominent. This is an area that already hissed many years ago, called the laminar reunions, because this is the area that enables the continuation between the two hemispheres. It reunites the two hemispheres, so this is the laminar reunions, and this will become the commissural plate, which is a name coined by Rakic and Yakovlev. Now, an important commissural structure, the first commissural structures to develop in the human brain is the anterior commissure, and this is the lowest one. It comes from the area of the ganglionic eminences and from the peripheral areas of the brain, and this is at around 10 weeks already the fibers of the lamina terminalis can cross at the ventralmost part of the wall of the anterior wall of the third ventricle. Now, what happens just a few days later on, if we take this image, the area of the lamina terminalis becomes thicker, and the most important structures that we can already see between 10 to 11 gestational weeks are the fiber bundles of the fornix. These are two laterally separated fiber bundles. These are axons that connect between the hippocampal primordium, the early hippocampus, which is not where Prashant showed you yet at the temporal areas. At this stage, they are still along the midline, along the inner surface of the hemispheres, somewhere here, and with more deep ganglia, the septal nuclei, the lateral and the medial septal nuclei, and eventually it will go all the way to the mammillary body. So remember, these are axons that connect between nuclei of the hippocampal area and the septal area here, and they are crossing through the massa commissuralis at its lower part, at its ventral border here. So everything above the fornix will be now called the septum pellucidum. Now, just a few days after the fibers appear, the fornical fibers appear, around 20% of the fornical fibers will cross the midline to give rise to the second commissure of the brain, which is the hippocampal commissure. It will eventually connect between the two hippocampi in the mature brain, and this commissure can be seen crossing the midline at a little bit higher than the anterior commissure, which is at the ventral part of the laminar reunions here, the anterior lower part of the lamina reunions here. Now, once the fornices are here and the hippocampal commissure is here, all this cellular mass above or dorsal to the fornices, this is now the early septum pellucidum, and this has been termed by Charles Ribot in his papers. Now, what happens now in the next phase is a very important structure, because up until now I didn't say anything about the corpus callosum. Now, in order to give rise to the corpus callosum, there is a very important process which I will dedicate my next slide to, which is called the interhemispheric fissure remodeling. So if you're going through the interhemispheric fissure, you go to the lowest part of the interhemispheric fissure. At a certain point, you should reach a bridge, a cellular bridge, which is permissive, which allows callosal fibers to cross from one side to another. And this phenomena, which I'll explain what happens there, is very important, because if this does not occur, callosal fibers may reach the midline, but they will fail to cross, both because the bridge is missing, and then these fibers will be stuck on both sides, and this will give rise to the Probst bundle that we know from some of the callosal anomalies. Now, once the interhemispheric has undergone this remodeling and the proper cells have arrived in order to enable the permissive passage for the corpus callosum, now this area is called the massa commissuralis, and this is the important phase which allows the development of the corpus callosum. Now, another important part for you to understand that this whole cellular events and the massa commissuralis are developing up to a certain point, and this point is the border between the cortex, which develops in the inner wall of the hemispheres, and the septum pellucidum. So this is called the cortico-septal border, again a term coined by Charles Ribot, and nothing can go beyond, because beyond this point you have already the development of the cortex and the early cortical plate, but below the cortical plate, this is where the commissural fibers will develop. And the last part of these events are the pioneer callosal axons that will come down from the cingulate cortex. They will communicate with the supportive glial cells that I'm going to show you, and then they will be able to cross. So now, after the pioneer callosal fibers crossed, we come up with this configuration, which has the septum, or the primordium septum pellucidum. The lower part of the septum pellucidum is composed of two parallel fibers, which are the fornices, and a small amount of crossing fibers, which are the hippocampal commissure. And on the top of it, along the corticoseptal borders, this is the landmark where the corpus callosum cells will start, axon, not cells, axon will start to cross. And from here, everything will develop and it will change the shape, but the configuration of who is ventral to who will stay like this. And this sets the final shape of the midline structures. Now, remember that I'm always saying septum pellucidum, but I didn't say the word cavum septum pellucidum or cavum septi pellucidum because there is no cavum. This is one of the major points of my talk, to convince you that at early pregnancy you should not use the word cavum because there is no cavum at this stage. Now, I mentioned the interhemispheric remodeling. So now let me show you this very important paper by Gobius and led by Linda Richards. And Linda Richards has published a lot of important papers which taught us a lot regarding how the commissural fibers develop. And what they showed in 2016, both on animal models and also on post-mortem human fetal imaging, is that in order for the massa commissura, in order for callosal axons to cross here, and this is an axial view of the I think it was a mice brain, you can see the callosal axon starts to navigate from along the interhemispheric fissure on both sides towards this laminar union, towards the place they can join. However, at this point, they cannot do anything because they have no supportive cells. And what happens here is radial glial cells transform into multipolar astroglial under the influence of FGF8, and which influences the MAP kinase pathway. And these astroglial cells, they navigate to the midline, they intercalate into the mannings that are located deep in the interhemispheric fissure. They activate various enzymes like the MMP, for example, ethyl metalloproteasose. They disintegrate the mannings primitiva, and then they create a bridge, a permissive bridge. You can see here they intercalate into the interhemispheric fissure. They there's disintegration of the mannings primitiva here, and you have a stellar mass. This is the massa commissuralis, and only these supportive glial cells will be able to communicate with the corpus callosum and to allow axons to cross. And as I mentioned before, if this fails to happen due to some kind of a genetic aberration, for example, and the cells are not able to transfer to multipolar astroglia, or they fail to migrate over there, the axons of the corpus callosum will be able to reach this point, but they will not be able to cross, and you may come up with various degrees of callosal anomalies or callosal dysgenesis. And in some cases, in those cases, you will also have the Probst bundles, which tells you that the development of the corpus callosum is not only about the axonal pathfinding or axonal navigation. This is only one side of the formation of the corpus callosum. The other side is the evolution of the midline, and the midline being able to communicate with these cells. And today we know that many genes that are associated with callosal agenesis are not associated with abnormalities of the axons, but with abnormalities of patterning and interhemispheric remodeling. Now, Charles Ribot summarized all of these events in a very nice, very important paper, and this is one of the illustrations from this paper. So now I showed you everything on sagittal images, but if you look at the coronal image, you can see here, this is the cortical border here, goes down all the way down here, and then the cortex ends at this point, and below this point you have the two lamina that will give rise to the septum pellucidum, but there is no fluid inside. It is filled with this cellular mass, the different glial cells, the wedge cells, the indusium grisum glia, and of course the zipper glia and the neuronal sling. And all of these cells are by expressing different genes of repellent molecule and molecules that resist axonal pathfinding, and eventually this whole massa commissuralis is located above the level of the fornices, above the level of the hippocampal commissure, and the lowermost structure, the ventralmost structure is the anterior commissure, as I showed you before. Now pay attention, I did not say anything about the cavum septipellucidi at this stage. So again, at this point, avoid this structure. So once you understand this complicated configuration, you can understand why when you look at the mature midline in adults or in children, this is what you see on the MRI, and this is what you see on the specimen. You see the corpus callosum, you see the septum pellucidum in adults, and Prashant showed it beautifully on his specimens. Remember that also Prashant showed it through the septum pellucidum. You have tiny vessels. These are septal vessels, septal veins. They are present there. They are flowing inside the septum pellucidum, and below is the fornix. You can see here the fornix, which is part of the structures that give rise to the roof of the third ventricle, together with the choriplexus, together with veins, together with the pia layer. But the most important thing for you to remember is that the fornices, they come from the hippocampus, they travel anteriorly, and then they give rise to the pillars of the fornix. They go down because they need to get to meet mammillary body, for example, here, and septal nuclei, and they do that on top of the Monroe. So actually, the roof of the foramen of Monroe is created by the fornical fibers that goes down, and you can see it very nicely here, also on the MRI with the third ventricle. The massa intermedia is here. This is a small massa intermedia. This is a big massa intermedia because this is a specimen, of course. Now, actually, when you look at the mid-pregnancy brain, mid-sagittal view at 24 weeks, you see quite similar configuration. However, we do not see the fornices so nicely like the MRI, and this is due to technical reasons and the beam reflection from the fornices, which is very low, and they are part of they are stuck together with all the surrounding structures, so we cannot actually see those bundles on the mid-sagittal view. But you can see here the anterior wall of the third ventricle, the massa intermedia, the echogenic tela choroidea, which is the choroid plexus at the roof of the third ventricle. On the MRI here, it's quite thin, but on the ultrasound, it reflects a lot of beam. And then you have the corpus callosum and the rostrum on top of the septal nuclei, which are here. And we know that the anterior commissure is somewhere here, but again, we don't really see it on the ultrasound. The anterior wall of the third ventricle and the floor of the third ventricle. Below this line, everything below this line is outside the brain. These are cisterns. So that was a very quick embryological step-by-step. How does the midline develop? Now, the question is, okay, but what do we see and what do we not, or we cannot see with a high-resolution transvaginal ultrasound early in pregnancy? So let's take a look at what happens from the sonographic point of view between late first and early second trimester. So this is an image that you all see in your routine scans. 12 weeks you are performing the nuchal translucency, but this is a high-resolution transvaginal ultrasound through the anterior fontanelle. And let's go and try to teach you the pattern recognition of this structure. So the first thing you should recognize is that there's echogenic falx here, and the falx here is drawing the border between the outside area of the brain and the inner brain. So you see the falx here, and your eyes are looking what happens below the falx. So let's take away the falx, and now you should recognize the lumen of the third ventricle, which is here. Now let's take away the third ventricle. The next part for you to recognize on ultrasound, the easiest part to recognize, is the tela choroidea, which runs through the Monroe, because the anterior most part of the tela choroidea is the Monroe, because this is where the choroplexus crosses through the Monroe into the lateral ventricles, and it is always hyperechogenic on ultrasound. Now, once you recognize the tela choroidea, you should take your eyes to the events that takes place anterior to the tela choroidea. So this is your area of interest here. Now let's take this thing off, and you recognize the thin area of the lamina terminalis here, and above the lamina terminalis, as you know, again, you know that the fornices are crossing here. We do not see them, but we know that this is the place that they cross, just above the foramen of Monroe, going down to the septal area, from up to down. So this is the area of the fornices, and anterior to the area of fornices, we see the thicker cellular area, which is very nicely seen here. It has a different echogenicity from the falx, and this is the massa commissuralis, and this is where the septum pellucidum will eventually develop. Again, there is no cavum at this stage. Now, what happens just 1 week or 10 days after approaching 14 weeks? Again, we recognize the third ventricle, we recognize the tela choroidea and the hypoechoic area of the Monro, because fluid is coming through the third lateral ventricles, through the Monro into the third ventricle. And again, we put our eyes anteriorly, we take it away, and now we see the lamina terminalis, the anterior wall area. We know that the fornices are crossing here, we don't see them. We see the massa commissuralis, as I showed you before, but now, as opposed to what happened at 12 weeks, when you approach 14 weeks of gestation, you start to see this hypoechoic area here. I will take it away. You see the difference in the echogenicity. This is the corpus callosum. The very, very, very early fibers of the corpus callosum are crossing here, and when you approach 14 weeks, but this is a very, very small structure. But if you have a good insonation, usually you would see it at 14, 0, or 13 plus 6 weeks. Now, after you go over 14 weeks, towards 14 and a half weeks, again, you can see the falx very nicely, and then you can see the tela choroidea and the fluid that comes from the Monro, the choroid plexus of the roof of the third ventricle. You see the massa commissuralis, the gray cellular area, and above this area, you can clearly see the hypoechoic fibers of the corpus callosum crossing from one side to another. Now, let's take the same fetus, and now let's see the corresponding coronal images, the perpendicular plane. So this is our landmark. This is the sagittal view, and if we draw a line exactly through the laminar units in the corpus callosum, we see that there is a cellular continuity. This is one structure that connects between the two ganglionic eminences and developing basal ganglia on both sides, and this area here of the laminar units and tela and lamina terminalis. And you can always see the hypoechoic fibers of the corpus callosum crossing, and above them is the more echogenic area, which are the Mannings stuck together at the bottom part of the falx of the interhemispheric fissure. And then you cross the line just a little bit beyond that, through the Monro and through the choroid plexus. You can see the echogenic choroid plexus. This is not the echogenicity above the corpus callosum. These are Mannings, but here this is the tela choroidea crossing through the third ventricle, and below it you see fluid in the anterior third ventricle. This is the fluid that comes down from the lateral ventricles into the Monro. And a few years ago, we published this paper where we described the normal development of the corpus callosum, and you are all invited to go over this paper. Now, I showed you 3D and nice images, but let me show you how does it look on the live transvaginal scan. So we start with 12 weeks, and again, you can see here the tela choroidea, the laminar unions, and at 12 weeks, there's nothing much more to say. But again, please, there is no cavum septopellucidum. Don't say the word cavum. At 14 weeks, you start to see the corpus callosum starts to develop. You recognize the echogenic choroid plexus, tela choroidea, and the border of the third ventricle, the lamina terminalis. And at 16 weeks, it's very easy to see the corpus callosum. It's just there, this hypoechoic area. And again, I would like to remind you, I didn't say any word about the cavum septipellucidi, because already also at 16 weeks, as you can see here, this area is filled with supportive cells, the massa commissuralis. There is no cavum at this stage yet. Now, okay, so now let's reach the point. Let's go through the birth, or how does the cavum septi develop after you understand, you have also all the genetic and the developmental and the sonographic background. Again, the sagittal and the corresponding coronal image at 14 weeks, you can clearly see here that there's the massa commissuralis here, and above the massa commissuralis are the fibers of the corpus callosum. When you go to 17 weeks, in most fetuses, you can still see the cellular massa commissuralis here and here on the coronal. You see the continuation between the two ganglionic eminences, and above that you can clearly see the corpus callosum developing. Sometimes, rarely, you may start to see at 17 weeks a little bit of fluid starts to appear, but after 18 weeks you can clearly see the early appearance of fluid replacing those massa commissuralis cells, which you can see here. So you see remnants of the massa commissuralis cells. You can see the corpus callosum, but inside this area now some fluid starts to appear. You can see it here by the blue color here. And in this area, you come up with two two lamina of the septum pellucidum, and now you can call this area a cavum because there's a cavity, there's fluid that replaced the cells inside, and you come up with the cavum septi pellucidi after 18 gestational weeks. And at 19 weeks, it's more clear because you recognize corpus callosum, the two leaves of the septum pellucidum, and the fluid inside. And in many cases, you have remnants of cells also in 20 or 24 weeks. These cells were already there to begin with. So this is how the cavum septi develop. So please, before 17 weeks, try to avoid saying you saw a cavum septum pellucidum because it's just not there yet. Now, again, let me show you the transvaginal ultrasound clip. You recognize corpus callosum, telachoroidea, Monroe, and the cellular field massa commissuralis. And when you look at the fetuses at 22 weeks, sometimes you see strands or remnants, and you see this structure here. Now you can clearly see that there is a cavum septi pellucidi, and inside these small strands are just remnants of vessels that were running here. I told you before, this is a vascular area. There are septal vessels here, and sometimes the cells disappear, but you may have remnants or of atretic vessels. There's no flow in these vessels, but the strings are there, and sometimes you may have come up with leftovers of cellular tissue, and these are what you may call an obliteration of the cavum septi, but it's not an obliteration. These are cells that just failed to disappear or to be abolished. So actually, what I just told you has been described many years ago, at least by two papers. This is a paper from '82 from Singapore on rats, on animal models. You can see here that before the cavum septi appears, there is the cellular mass. These are the lateral septal nuclei, and because of some kind of cellular activity, which we're not going to go into now, the debris of these cells are being evacuated by phagocytosis, and you can already see here the remnants of the blood vessels floating here inside. These are the strands that I told you that you see on the ultrasound. So the phenomenon of evacuating and the appearance of fluid has been described many years ago. This is not something new, but it has never been described on in vivo observation in fetuses, and now we're just summarizing our data, and hope you will be able to read it soon. And this is another paper from '88 by Hankin, and he showed very nicely that the death of the subcallosal sling, again, this is part of the cellular structures that support the crossing of the corpus callosum. When the death of these cells occurs and they disappear, you can see here that this is the corpus callosum. These are remnants of these cells, and eventually they disappear. You have a cavum appearing below the genu and the body on the splenium of the corpus callosum here. And this is the parasagittal section. This is not exactly a mid-sagittal section, but a bit parasagittal section. So this phenomena has been described many years ago on animal models. Now, in order to study this area, we cannot ignore some technical aspects which I would like to highlight. First of all, everything that I showed you is transvaginal ultrasound, but even if you perform transvaginal imaging, the angle matters a lot because different angles will provide different images because of different beam reflection. So these are two examples. On the left side image, this is a insonation through the posterior fontanelle. You can see very nicely the midbrain, hindbrain structures, but our interest now is on the midline area here, the developing corpus callosum, and you can see it much less clearly than the images I showed you before. And the same goes for a very frontal insonation. You can see here that the beam is projected through the bones, the facial bones, and you, in addition to the fact that you have a lot of shadowing, this area is far away from the probe, and many of the energy of the beam is being spread around, so you cannot clearly really see what I just showed you. However, my tip for you is always look for the echogenic telachoroidea, because of the high blood content in this area, you will always see the echogenic reflections, and this should be your landmark. So once you see the echogenic telachoroidea, try to mobilize the probe and the fetus, and use this as a landmark, and then look for the surrounding structures. Now, I cannot avoid saying something about the transabdominal image, because the transabdominal imaging, even today with the high quality, high resolution new probes, is still does not have the basic ultrasound physics, the basic resolution. Let me just show you. This is a 12.5 to 12 plus 6 days fetus, and you can see here that when you're insonating through the mid-sagittal, this is the image. However, I took the same fetus during the same scan, just move to the transvaginal scan, and you can clearly see now the difference in the images. But most important thing is that please don't call this dark area here a cavum septi, because first of all, I'm showing you that there is no cavum. I hope I convinced you there is no cavum, there is no fluid at 12 weeks, so don't call this a cavum. And this hypoechoic area is because of the resolution is low and because the contrast is very high. So whenever you have reverberation or shadowing at this area even from vessels that cross there, you come up with this hypoechoic area, which might falsely give you the impression that this is a cavum septi pellucidi. Now, the problem is that many people are not performing a mid-sagittal section, but we all do axial images. These are the screening images. And when you do the 14, 15 weeks, and also if you do it with a very new machine, with the high sophisticated probes and all of these new filters, HD filters, and I will ask you, what do you see here? I think that most of you will tell me now, for sure, I see a cavum septi pellucidi, but please, I just showed you there is no cavum septi. What you see here are artifacts. This is the problem with the transabdominal probe. It will mislead you. This is not the cavum septi pellucidi, and if I want to convince you that this is not a cavum septi, what we should first do is move to the transvaginal probe. You should lower the contrast of the image so you get more gray shades, more level of gray shades, not only black and white. And we will start with the lateral approach. This is the axial view. And in order for me to make it easier, I will freeze the image, and I took some snapshots from the image to make it more clear. So if you start with the axial approach, you will always look, or you should look, for a hypoechoic horseshoe sign, the horseshoe structure. You can see it here very nicely, this hypoechoic. But this hypoechoicity is not because there is fluid, not because there is cavum, because these are the supportive cells of the massa commissuralis together with the corpus callosum that crosses. And if you want to understand it better, you should change the orientation of the probe. You should not insonate laterally, you should insonate perpendicularly through the anterior fontanelle. So this is what I did. I changed the orientation of the beam. Already when you are between axial and coronal, you can clearly see the hypoechoic horseshoe structure. But if you're insonating exactly through the anterior fontanelle and you lower the contrast of the image, you lower all the filters that gives you a high contrast image, and then you can come up with these three echogenic layers: the corpus callosum, hypoechoic, the third ventricle roof, the telachoroidea crosses through the Monroe, which is hyperechoic, and in between them, these are the massa commissuralis cells, which did not give rise to the cavum septum at this stage. So please don't call this a cavum septi pellucidi. Now, the last point which I would like to talk about, if we are talking about the early midline, is the pericallosal artery, because I know there is a lot of buzz about this issue, but please, you need to pay attention. When you look at the 17 weeks pericallosal artery, you can clearly see that there are two separated vessels, and only one of them, the one I show you here, is the one that actually crosses on top of the corpus callosum. And this is very easy for me to convince you that this is the pericallosal artery. Now, what's going on in 15 weeks? When you look at the 15 weeks, again, look at the corpus callosum, and you see there is a tiny vessel, which is the pericallosal artery, the tiny vessel that goes on top of the corpus callosum. And then you have another big vessel which is not touching the corpus callosum yet, and this is the one that sends the bifurcation, the falx arteries up there to the falx. You can see them here, but they are not coming from the true pericallosal artery. At 14 weeks, again, the same point, you recognize the corpus callosum, you see the small branch, which is the actual pericallosal artery, and above it is another branch, which is the callosomarginal artery, and this is the one that sends the bifurcation. And actually, if you look at 12 weeks, you see again, not the big artery that sends all its bifurcation, but only the small branch which touches the corpus callosum. This is the pericallosal artery. Now, to convince you and to teach you this point better, let's go to the 24 weeks and look at the pericallosal artery, what you all do in your daily scans. First of all, when you take a close look, and sometimes it's difficult to adjust the machine.
Roy, you need to finish.
Okay, sorry. So I will move on from here, and I just finished with this clinical example, and I will finish. So I'm showing you this 17 weeks image. This is an axial view. I recently saw a presentation by one of our colleagues. He showed the same case. And when I ask you, what is this? I'm sure that most of you will tell me that this is a case of absent septum pellucidum, right? Maybe it's even septo-optic dysplasia at 17 weeks. And my question is, are you sure? And the answer is no, this is not absence septum pellucidum. And in order to understand this, you need to perform a multiplanar imaging. And when you look at the multiplanar imaging, first of all, you see that there's a continuation of the cortex. So this is kind of a holoprosencephaly. And most importantly, if you compare the midline, this is the lamina, the massa commissuralis, the cells that were supposed to give rise to the corpus callosum, and they failed to undergo any patterning, and this is a straight communication between the two midlines. And in better to convince you, look at the pericallosal artery, and you see that the pericallosal artery is actually going on the anteriormost part of the brain. It's not going inside, so you don't have any patterning of the midline. And you compare the same age matched, you can see the pericallosal arteries run on top of a normal midline, which failed to occur here. So my take-home messages, and I'm sorry for taking longer, the brain midline structure developed gradually from late first trimester into the mid-second trimester. The cavum septipellucidi emerges progressively and typically becoming apparent at between 17 to 19 weeks of gestation, following after the early corpus callosal fibers have crossed. Early assessment may lead you to false diagnosis of cavum septipellucidi or other midline anomalies, like the example I showed you for the SOD, if you're not performing a detailed examination. Transabdominal ultrasound, even with the new generation probes, offer limited resolution, and especially it provides high contrast imaging.
עובד מושלם, מפה בגלל הקרבה לגזע,
the early pericallosal artery, please ensure that the correct artery is the one that's being identified before you decide and you make diagnosis based on some artery that you may think is the pericallosal artery, but actually probably it is not. And again, I apologize for extending my time, and I thank you very much for listening. Let me just stop sharing.
Okay.
Okay.
Stop sharing, and now Mauricio. Okay,
Thank you, Rui, for the amazing presentation. And for me, I need to remember you that we are going to have a discussion after these lectures. And then our next speaker is going to be Dr. Mihail Brusilov from Israel with a lecture about early screening and neurosonography guidelines and technique. Brusilov is with us. I'm going to put on the screen. Let me 1 second. Hello, Mihail. We can see you. Hello. Can you share your screen, please? Share the window. Well, okay. Take your time.
Share. Go to the presentation.
Yes, we have it. Amazing. You can put in full screen and then start. Okay.
Full screen. Good.
Now I'm full, no?
Yes, you can start.
Okay. Hello, everybody. Thank you to committee for invitation and my introduction. My part in this event, this is a present of late first and early second trimester brain scan technique and tips and tricks. It's not tricks, it's just tips. Okay, so first of all, three main parts of for good examination. It's knowledge of embryology, as you saw before the brilliant presentation of Rui. The second one, it's knowledge of anatomy, and the third one, it's your experience in the examination of the fetuses in the early pregnancy and the middle and the third part of the pregnancy. But today I will speak about the early pregnancy. What is the technology? We must know physics of ultrasound, and the second one, knowledge of your machine, features of your machine, and the technique, your technique examination, because ultrasound, it's a very operator dependent examination, and who is operators? Operators is the doctors. We are operators. What we know, must to know, the planes, as it's very resemble other imagination techniques as CT and MRI. and we need to achieve strict planes. Echogenicity, it's a very important feature in ultrasound examination and approach. As you saw before in the presentation of Roy, TVS is much more better for a brain examination and better in the early of the pregnancy because a property of the physics of machine. The first of all, the planes. The main plane always, we started with the main plane. It's a multiplanar examination. The main plane, the best imagination is plane A. You can see here in sagittal plane. We must to be close as possible to our object and with correct insonation of the ultrasound beams. The B and the C, it's reconstruction, but we can see here main planes, strict main planes of the brain. The sagittal plane with all structure, as you saw before with the lecture of Roy, the coronary plane and the axial plane. We can see here in the reconstruction with the images of C images. So, echogenicity. 15 weeks of the pregnancy, the coronary plane. You can see here anterior part, the future anterior complex, but something wrong in the lateral ventricles. You can see here choroid plexus, but it's not low echogenicity in the lateral ventricles. On the axial plane, the same. Something wrong around the choroid plexus. It's not black. Sagittal view, posterior fossa. It's not fluid around the brainstem and the vermis, and the future vermis, upper vermis. And on the axial plane, something wrong around the cerebellum. So it was case of the early bleeding in 15 weeks, but and the diagnosis was done by change of the echogenicity in this case, bleeding in 15 weeks. Technical aspect of neurosonography. In 11 weeks, it's not the same as 32 weeks, because we have in 11 weeks and in the first trimester of the pregnancy, very wide acoustic windows. And at the end of the pregnancy, acoustic windows is small. So what we have as acoustic windows in the 14, 15 weeks, the main is the anterior fontanella, coronary sutures, posterior fontanella, and lambdoid sutures. Mid-sagittal, it's the main acoustic window for us for examination, good examination of the brain. A main rule for examination to be closer as possible to our object on the correct position of the probe above the fetal skull. If our probe we will put on the side, the beams will reflection to the machine without any imagination of the brain. For the anterior part, we must to put our probe to the anterior fontanella and posterior part of the brain close to posterior fontanella. 15 weeks, our probe we will put above the anterior fontanella, but for examination of the lateral parts, my recommendation not put the probe, just change in angulation of the probe to the parasagittal planes. You saw before illustration of the anterior complex of the early pregnancy by Charles Seibot. What we can see here on the sagittal plane in the 14 weeks. Our probe close to the our object on 90 degrees of waves. What we can see in the midline, all structure of midline, corpus callosum, anterior commissural complex, again, third ventricle, chiasma recessus, midline falx, tectum, CVI, third ventricle, corpus callosum, anterior commissural complex, third ventricle, and chiasmal recessus. On the parasagittal view, with the change of angulation of the beams, what we can see in these images: skull, a subarachnoid space, arachnoid granulations, brain parenchyma, lateral ventricle with chorioid plexus, telachoidea, massa intermedia, area of ganglion eminence, and head of the caudate. Some words about the blood supply of the midline. What we can see here: callosal marginal artery and pericallosal artery close to the initial fibers of the corpus callosum. To compare, this is a case of absent of initial fibers of the corpus callosum, but pericallosal artery is there, and anterior marginal artery. Two cases for compare: normal anterior complex 14 weeks, lateral ventricles, anterior horns of lateral ventricles, interhemispheric fissure, not deep, with the stop by initial fibers of the corpus callosum. There we can see here cerebellum, primary fissure of the upper vermis, and in this case we can see wide lateral ventricles with a small, relative small chorioid plexus. Something wrong here, but it's not enough good for a decision what is wrong here. We will put the head on the 90 degrees above the probe, and we can see here dilated foramen of Monroe, prominent anterior horns of lateral ventricles, and not detected initial fibers of the corpus callosum, abnormal development of the midline with most probably early agenesis of the corpus callosum. There's the same case with illustration of the pericallosal artery with undetected fibers of the corpus callosum. Normal brain in 16 weeks, we can see here from posterior to anterior movements of the probe by a multiplanar scan. Again, normal brain, cerebellum, two hemispheres with primary fissure of the vermis, thalamize, anterior complex with initial fibers of the corpus callosum, anterior horns, two hemisphere, and interhemispheric fissure. Multiplanar scan in the 16 weeks, midline, we can see here thalami, chorioid plexus, lateral ventricle with the fluids, tissue of the brain, head of the caudate, and the midline third ventricle, corpus callosum, aqueduct, tectum. Little bit magnification, midline, corpus callosum in 16 weeks. Multiple scan from the left to the right, anterior posterior, chorioid plexus, thalami, falx, interhemispheric fissure, corpus callosum, third ventricle, ganglionic eminence, anterior horns of lateral ventricles. This is a case of the agenesis of the corpus callosum in the 16 weeks. Thalamize from anterior to posterior, deep interhemispheric fissure without fibers of the corpus callosum. And these images we can achieve just with good insonation, our probe above the midline of the brain of the fetus. It's the same from the left to the right. absent corpus callosum, and deep interhemispheric fissure. Now we will switch to posterior fossa. In the 12 weeks multiplanar scan, we can see from the left to the right, brainstem with a Z shape, 11 and 3 midbrain, huge aqueduct, future fourth ventricle, and cisterna magna and brainstem. In this step of the pregnancy, we will see a brainstem as a Z shape with mesencephalic flexura and pantine flexure. And in the 14 weeks of the pregnancy, the brainstem gonna be absolutely right, without flexures. On the sagittal plane, we can see a fourth ventricle, choroid plexus, cisterna magna, brainstem, medulla oblongata, spinal cord, and cerebellar hemispheres on the coronary plane. This is a view from the axial plane. We can see good visualization of the hemispheres of the cerebellum, but nothing about the brainstem, because the reconstruction of the C, as I said before, it's not good choice for the examination of the brainstem, because the shadow of the skull. Okay. And the case, early examination of the Roman cephalosynapses with good visualization and close to the fetal brain in the 12 weeks. Something wrong here. We can see here a huge lateral ventricle and the small, relative small chorial plexus. In the 14 weeks, it was more prominent with huge lateral ventricle and small chorial plexus and abnormal development of the cerebellum. In the 14 weeks, we can see here absent of primary fissure and absent of vallecula. It was case of the Roman cephalosynapses. To compare, on the sagittal plane, we can see here tissue mass in the case of the res in the posterior fossa, and empty space with the case of the dandy walking malformation with a lot of fluids in the posterior part. And as say Roy, it's very important to be close to the object if it's anterior component above the anterior fontanella and the posterior compartment. Posterior fontanella, it's normal development of the brain, anterior and posterior. It's normal cerebellum, anterior and posterior, posterior part of the brain, two hemispheres, primary fissure. And now in the 15 weeks, in the case of the Roman cephalosynapses, we can see here prominent lateral ventricles, anterior horn, initial fiber of the corpus callosum there and there, but in the posterior part, with the approach with the throat to the small fontanella, we can see here abnormal appearance of the cerebellum, absent of vallecula. We can see here white and black lines, but it's not upper part of the vermis, because my point there deeper than the area of the upper vermis. So it was case of Rome encephalosynapsis. Few words about technique. Always my recommendation to do it with two hands, bimanual examination, the right hand with the probe and the left hand on the abdomen of the patient for a movement of the uterus manipulation, and very important to achieve good visualization to be close and right about the brain. You can see here a parasagittal view, membranes, external axial space, extra-axial space, cortex, brain parenchyma, chorial plexus. Very important to achieve extremely parasagittal plane, because here with the cases of the malformation, we can see abnormal development of the cortex, occipital lobe, as in this case of the abnormal early sulcation with thanatophoric dysplasia. Again, extremely parasagittal plane, thanatophoric dysplasia, early sulcation of the brain. On the coronary plane, bimanual examination, intrahemispheric fissure, anterior horns, falx, ganglionic eminence. This is a case of cavitation of ganglionic eminence, the coronary plane. And this is prediction of the malformation of the cortical development. Axial plane, extra-axial space, membranes, cortex, falx, brain parenchyma with lamination, lateral ventricles with a chorial plexus. This is a case to compare early ventriculomegaly, 15 weeks, a lot of fluid around the chorial plexus, coronary plane, anterior horn, third ventricle, and early corpus callosum, fiber of the corpus callosum, coronary plane, mid-sagittal plane, early corpus callosum, CVI. An important part of the examination of the brain, this is the eyes. You can see here hyaloid artery, lateral and the posterior tunica vasculosa lentis, lot of vessels around the lens, clear lens, orbita, clear lens, orbita, normal appearance of the eyes, and to compare early cataract in the 14 weeks of the pregnancy.
Last minute, Michael.
Okay. The face, we can see here the tongue, hard palate, anterior part of the maxilla, posterior part of the maxilla, normal development of the hard palate, secondary palate. This is the initial position of the fetal face for examination of the palate. You can see here uvula, mid-sagittal plane, epiglottis, and this is the case of the cleft of the hard palate, a secondary palate only, abnormal development. Okay, posterior part, technical aspect to be close to the small fontanella from posterior part, aqueduct, tegmentum, cerebellar hemispheres, primary fissure of the vermis, mid-sagittal plane, cisterna magna, chorial plexus of the cerebellum, brainstem, medulla, transition from the medulla to the spinal cord, pons, fourth ventricle or future fourth ventricle, and to compare the till 14 weeks Z shape of the pons. And it's important part of the examination is the spine, normal position of the cord, in this step of the pregnancy is close to the sacrum, but it's normal for 14, 15 weeks. And to compare examination of the brain transabdominal. As you can see, it's not the same, and it's not enough resolution for examination of the brain. Thank you.
Stop sharing. Mauricio.
Thank you, Michael. Amazing lecture. I want to refresh to everyone that we're going to have time to do, some questions and for sure discuss about these amazing lectures. Okay, our next speaker, it's a pleasure to introduce you Dr. Elisenda Eihart, that she's from Spain, with the lecture second trimester screening, where we can reach during the screening. Elisenda, more than welcome. Please, can you share your screen? And
I'm already shared, I think.
Yes, let me. I'm gonna put on. Yes, I can see it. Let me. I'm gonna put on. Okay.
Okay.
Now you can see.
Thank
it.
you very
Go
much.
ahead.
Thank you very much, Mauricio. Thank you very much for the invitation and the participation. It's really a pleasure to be here today. Unfortunately, not in person. I really, I think I really enjoy to meet you, everybody in person. But I mean, I think that resilience is a good characteristic of all of us. So we have to adapt to the change, and I think that we will enjoy these 2 days as we have enjoyed till now these sessions. After these impressive sessions in the first trimester, now we are moving to the second trimester screening, and where we can reach. And just to start, if we separate the evaluation of the central nervous system by basic and advanced level, of course, if we are talking about the second trimester evaluation of the brain, we will focus in this basic level, but you will see that the basic level can go more further than we think. And the idea is to improve the screening using transabdominal planes and mostly axial planes, as you will see. And the most important thing is that we want to confirm normality, and if there is something, then we will do the advanced level. So our main focus during these 20 minutes will be to see how we can confirm normality using the second trimester scan, and we'll focus on that. But remember that all that I'm going to explain about the second trimester can be also used for any of the ultrasounds that you are going to do during pregnancy. So I recommend you to use all these tips for all the ultrasounds in order to improve the diagnostic of brain anomalies, because at 20 weeks normal scan do not discard that anything appears later in pregnancy. So if we start with these ISO guidelines, ISO international guidelines, recommend you to do these 3 planes, transventricular, transthalamic, and transcerebral, in order to measure these small disease structures. And this is what our international guidelines recommend and support to use for the diagnosis. But in the next slide, you will see that we can take more from this ultrasound and we can improve our diagnosis, including some other structures and some other measurements. And I will follow this checklist during all the axial evaluation. And the objective of our evaluation during axial scan, during the screening scan, is to fill all this list with the ticks to say that this is okay or is not okay, and then if it's not okay, then it's a suspicion of abnormality, and then send to the specialist to do the fetal neurosonography. But if we don't do a good examination during a screening scan, we won't be able to diagnose the pathological conditions. So let's start to fill this list. And we will start with this general assessment. We always have to start our evaluation with this general overview, with this axial sweep, to see that there is a symmetric hemispheres, the enterohemispheric line, and the shape of the head. So this is a very general evaluation, but it's giving you like general view of how this head is. And apart from doing this general overview about the shape of the head, I recommend you to do that, to evaluate specifically the cranial suture evaluation, to see both coronal and both lamboid. That is very easy, that you don't need extra or 3D or some other things. So just doing this access sweep, you can identify, and you are going to discard conditions that are associated with the closure of the sutures, such as the craniosynostosis. So just with this, like 10 or 20 seconds scan, you will confirm cranial and skin integrity, you confirm symmetry of the brain, you will have an overview of the interhemispheric space, subarachnoid space, and parenchyma. So at least you will have this first evaluation. Then after having this first evaluation, you have to move to the specific planes that are recommended in our ISO guidelines, and the first one is the transventricular plane. To obtain a good transventricular plane, you have to look for the cavum septipellucidi, anterior horns, perioccipital sulcus, and the lateral ventricle. And this is the standard plane that we need to obtain, and it's very important because in this plane we are going to measure the lateral ventricle, and for measuring the lateral ventricle we should be in the perfect plane, because if you are not in the perfect plane, you are going to have a non-appropriate measure, and you can overestimate or underestimate the lateral ventricle measurement. I think that is, I know that is like a very basic thing, but I mean, we review a lot of images from people that send patients to us, and sometimes there are mistakes in the measurement of the lateral ventricle. So remember that you have to measure at the level of the perioccipital sulci, in, and of course it should be less than 10 millimeters. But we only, and remember to increase the picture to have a very nice one, but you not only have to measure, you also have to evaluate the shape of the lateral ventricle. You have to evaluate the shape of the posterior lateral ventricle, but also the anterior one, because it's important, because it's going to help you in the diagnosis of the agenesis of corpus callosum. So it is very important not just to measure, also evaluate the shape of the lateral ventricle, because it's going to help you in the diagnosis, and also evaluate the content of the ventricle and the walls, the echogenicity of the wall, because it's going to help you maybe in the diagnosis of intraventricular hemorrhage. So please take your time to measure well, but not just measure, also evaluate the shape and the appearance of this lateral ventricle. And in addition, remember that we have two hemispheres in our brain, and we normally measure the distal one because it's the one that we see, and we measure this one, but we don't have to forget that we have an upper hemisphere, and sometimes we can have the ventriculomegaly in the upper hemisphere. So it's important to evaluate the upper hemisphere during our screening ultrasound. And there is discussion about if we need to measure or not. I mean, and we can discuss further that later. But I mean, it is possible to measure. I mean, there are some authors that have demonstrated that early in the pregnancy is very easy to measure. So you can measure, you can obtain in more than 90% in the second trimester. But the question is that maybe we have not to follow the normality that has been defined by the distal one, because the plane is not exactly the same. But at least please evaluate, because sometimes things happen in the hemisphere that is in the upper part, and you can not diagnose a condition that is happening there. Again, in this plane, we have the cavum septipellucidi. We can see here a 20 weeks scan is fully seen. This is echogenic structure surrounded by the septipellucidi, and at the beginning we can see that the interhemispheric line is not here, and it's very important to separate this structure, the cavum septipellucidi, from the structure that we can see below. That is not the cavum septipellucidi. It's very important that we can see here that the interhemispheric line is crossing this structure. It has been called like at the level of the columns of the fornix. I mean, the columns of the fornix are not these white lines, but the important thing is that this is not the cavum septipellucid, and it's very important because sometimes you can misdiagnose this as a cavum septipellucid and this is an agenesis of corpus callosum. So when you have an agenesis of corpus callosum, you don't have the cavum septipellucid, but you can have this image sometimes. So remember that you always have to see this cavum septipellucid at this level, but not just to see that the cavum septipellucid is there, because sometimes cavum septipellucid is there, but it's strange, like these ones. What happened here? This is not a square shape. This is the normal. This is not the normal cavum septipellucid. What is happening here? Is this normal? Is it abnormal? So some years ago, the group of Ravichawi proposed this cavum septipellucid ratio, that is the division between the anterior-posterior diameter with the transverse diameter, and in normal conditions is about 1.5. They show that when there is below, there is a high proportion of partial agenesis of corpus callosum, so it is a good marker to identify partial or dysgenesis of corpus callosum. The most important thing, so you can measure during your ultrasound, but the most important thing is that you need to focus, and if you don't have a cavum septipellucid that is longer than wider, that this is the rule, longer than wider, and have a strange shape, maybe it's a good case to look to go to the sagittal plane to see the corpus callosum directly. But if it's completely normal, if this longer than wider and the ratio is completely normal, probably nothing is nothing there. And I show you here a image case, a practical case in which you can see cavum septipellucid that is abnormal, is wider than longer, the other way around. The ratio is pathological, and when we go to the sagittal plane, we clearly see that there is a dysgenesis of corpus callosum. So we have diagnosed the dysgenesis of corpus callosum by transabdominal plane using the axial planes, and this is because in the axial evaluation, indeed, we can evaluate the midline structures indirectly. If we evaluate the anterior and the posterior complex, here you can see the anterior and posterior complex. I mean, all of us are familiar with the anterior complex, but maybe not with the posterior. The anterior complex is cavum septipellucid, both septi, the anterior horns, the interhemispheric fissure, and the actual corpus callosum that you can see here in the anterior part of the corpus callosum. And it's very important that the anterior complex should look like this. I mean, this is the normal anterior complex, and anything that looks different, the anterior, maybe the anterior horns that are parallel or they are abnormal, should leave our attention and then think that there is something and then explore the midline in another way. The posterior complex is this region here, and we can see in a ventricular, in a level that is a little bit up from the ventricular plane, and here we can see in a bigger, and we can see the splenium of the corpus callosum, the callosal sulci, the parieto-occipital fissure, and the interhemispheric fissure. And this is a normal posterior complex, and this how should look like. And why is it important to evaluate both in the axial plane? Because when both are normal, and this was shown by Vignal some years ago, when both are normal, this is a very good predictor from normal midline structures. So you can discard anomalies in the midline structures. And the most important thing is that you can say, maybe, I mean, we will know that anterior complex is easily seen, but posterior complex also. Indeed, both can be seen more than 95% of cases from 24 to 36 weeks. So I recommend you to evaluate both to improve the diagnosis, not of agenesis of corpus callosum, that we will focus in the anterior complex, but to discard partial agenesis or dysgenesis of corpus callosum. And in this transventricular plane, we can also evaluate cortical maturation. Since we are focusing in the 20 weeks scan, I only put the images from the grades that are expected to be found at this level. Pistorius some years ago defined this cortical development pattern, and here you can see how we can see parieto-occipital sulci at the second trimester as grade 1 or as grade 2. This is we have expected to be, and is important and is necessary that we evaluate. I mean, is required to identify parieto-occipital sulci because it's the reference to measure the lateral ventricle. So since you have to look for it to measure the ventricle, please evaluate the degree because can be helpful in the diagnosis or in the suspicion, more in diagnosis, in the suspicion of cortical malformations. So we have filled a little bit this checklist, so we will move to the next plane, the transthalamic plane. The transthalamic plane is a plane that is slightly below to the transventricular plane, and a reference that is very useful to know that you are in the plane is that you have the third ventricle that is in between the thalami. So it's very easy. So if you see the third ventricle, you are in the transthalamic plane. The reference in our guidelines is the cavum septipellucidity. Some years ago we used a little bit low, but the reference that you need to use is this one, cavum septipellucidity and the third ventricle. And in this plane is very important because we have to measure the head to diagnose micro or macrocephaly, but also we have to measure the cephalic index because it will be useful to diagnose changes in the shape of the head. So the oligocephaly and brachycephaly. But we can move further in this plane. We can measure the third ventricle. That will be useful for the diagnosis, especially if you have a lateral ventricle that is dilated, to see if the dilation is all in the lateral ventricles or is affecting the other ventricles of the central nervous system. And in addition, in this plane, I think that is very important to include the evaluation of Sylvian fissure. It is true that Sylvian fissure is a structure that is tridimensional and is a simplification, maybe just to evaluate in this plane, but because we are talking about the screening or about second trimester scan, maybe focus here in the evaluation is an important one as a screening method. So here, again, focusing in the degree of development that you have to expect when you are doing a 20 weeks or 24 weeks scan, is you have to expect to have a grade 1 or a grade 2. Here again, the grades that Pistorius defined. So here this is like just a small depression that is round, and here in the grade 2 we can start to see that this start operculization and there is an angle here. So again, it's not a diagnosis, it's a suspicion, is what we are expecting from the axial planes, to suspect if there is something abnormal or the other way around, everything is normal and the patient can follow the normal follow-up. And here I show you an abnormal image of a case with an abnormal Sylvian fissure, and I think that it's pretty clear that here the Sylvian fissure do not look like the previous images that I show you. So it's important to train your eyes in looking at normal Sylvian fissure, because when you found an abnormal one, the red flag is going to be clear for everybody. So again, we are filling this list, and indeed we have 2 ticks in the cortical development. And we move to the transcerebral plane, the last plane that we need to obtain as a standard ones. So we have the cerebellum, the cavum septipellucidity, and the posterior fossa and the skull. So these are the references for this plane. And in this plane, the first thing that we need to do is to evaluate the characteristics of the cerebellum. Not only measure, we need to measure, we will see, but the first thing is to evaluate that the cerebellum has the shape that we expect to have. This butterfly with the burmese in the middle that is more hyperechogenic, and the hemispheres that are symmetric in both sides of the burmese. So it's important to evaluate also the aspect, the appearance, and of course to measure both the transcerebral diameter and the posterior fossa for screening reasons. But here, again, we can go a little bit further and we can include evaluation of the fourth ventricle. Nina and all the group of Israel published this paper some years ago about the evaluation of the fourth ventricle and the importance of evaluating for diagnosis of Burmian and protuberance from the complex conditions that are difficult to diagnose. The fourth ventricle is very easy to be seen in the transcerebral plane, so you just need to look for it and have a good acoustic window. And the fourth ventricle also, they describe this ratio, that is the fourth ventricle ratio, that is the contrary from the cavum sepsi pellucidis, the division from the lateral diameter with the anterior posterior diameter, and in normal conditions, this is about 1. Nina always said also that maybe it's not necessary to measure, but it's important to evaluate. So if measuring implies that you are going to evaluate the fourth ventricle, please measure this ratio. But I mean, the only thing is that you need to evaluate the fourth ventricle, and it's the other way around from the cavum. Instead of it should be wider than longer. And I think that this rule is important for you, because then it's going to be it's easy for using in the screening. And here you can see, so they show very nicely that when the ratio was below 1, a lot of conditions can be, a lot of severe conditions from the posterior fossa abnormalities can be detected, such as the Joubert syndrome. Here you can see this completely abnormal fourth ventricle, rhombencephalosynapses that also have an abnormal fourth ventricle, and also an abnormal shape of the cerebellum, and the most difficult condition to diagnose, that is the pontocerebral hypoplasia, because everything looks structurally normal, but the fourth ventricle is very good and very big, and it means that the vermis, that is the posterior limit, and the pons, that is the anterior limit, they are smaller. So these are maybe the only way to diagnose a pontocerebral hypoplasia in the axial plane. So it's a good recommendation, I think. So here you can see that we have filled all the list, all the checklists that I have proposed, but we need also to evaluate the spine. And of course, we need to use the sagittal, the axial, and the coronal plane. I mean, I think that all of us need to know how to do this evaluation, this specific evaluation in the 3 planes. But we can go further in this evaluation of the spine, and we can include the conus medullaris evaluation. Conus medullaris is very easy seen in the sagittal plane. We can evaluate the level of the conus medullaris that at 20 weeks should be around L3. So here we can use the reference of the changes in the angle between sacral and lumbar. But I have a very easy tip to do it during 20 weeks scan. So if you are doing a 20 weeks scan, you can identify the lower level of the kidney, and the conus medullaris should be always over the upper limit, the lower limit of the kidney. So if you are doing a 20-week scan, it takes 2 or 3 seconds. You identify the kidney and then go and identify the conus medullaris, and this is above the lower limit of the kidney. This conus medullaris is in a normal level, you are discarding the closed spina bifida. So it's a very easy trick to use in the 20-week scan. So here you have the basic level that is recommended by our international guidelines, and what I think that is interesting to improve the diagnosis, and of course it's not mandatory, but it's a recommendation, and I think that improve the diagnosis if it's what you want to do, to include the anterior and posterior complex, the parieto-occipital sulci maturation evaluation, and also the Sylvian Fisher evaluation, the fourth ventricle, and the conus medullaris. And with this, you will increase the diagnosis of most of the conditions. But for finishing, the question is, should we add the sagittal plane in the 20-week scan? And I have
Elisenda, 2 minutes.
Yeah, I'm almost finishing. The question is, it is feasible? Yes, it is feasible. You can see here it's very easy. You can see the complete evaluation in 90% of cases. And also you can see in the 3D axial and the 3D sagittal. So, I mean, the answering to the question, it is feasible. Yes, it is feasible. The question, it is worth. And here I have my opinion. And the first thing is that there is a lot of heterogeneity in defining pathology. And remember that now we are talking about screening. And the second thing is that there are not appropriate normality curves for abdominal evaluation, but it's true that we can use the subjective evaluation that the splenium is at the level of the end of the tectum. This is true, but it's also true that we have signs for diagnosis complete agenesis and dysgenesis of corpus callosum using axial plane. So, with my fear, I think that it's not really needed to do the sagittal plane in the screening, and we can discuss further. So just I want to thank your attention, and this is my proposal for this expanded actual evaluation for improving the second trimester screening. Thank you very much for your attention.
Elisenda, thank you for your amazing presentation. We will have question sessions for sure. We can share a little bit more about this amazing approach and the new proposals for include in the evaluation of the fetal brain. Okay, Gustavo, go ahead with the introduction of Gregor. Gustavo?
Yes. Now
Go ahead with the introduction of
it's
Gregor.
Gregor. It's Gregor, sorry.
Yeah, Gregor is here. You can introduce him, please.
Okay, it's a pleasure for me to introduce Gregor Kasparian from Austria. Most of you know him. Hello, Gregor. Go ahead and good luck. Nice to see you. A lot of books there.
Good morning, everybody. I hope everything is working well now, and you can see my slides perfect. Yeah, happy to see you. Unfortunately, we cannot meet in person. Would have really been fun to see you all and to exchange in person. However, we will do the best in this situation. And as Elisenda said, our brain, or we, are made to adapt to adversity. So I will go to the presentation, and you have heard quite a bit on first trimester ultrasound today. There is a lot of data here, as you can see, throughout the years. With MRI, it's different. We do not have a lot of reference data at earlier gestational time points. This is probably a not absolutely up-to-date overview of brain reference data studies throughout the years. And you can see most of them reach down to 20 weeks. And if you look at the cases done before 20 weeks, they are very, very few. So generally, you can consider fetal MR as a technology which is mainly used after 20 weeks internationally. So usually MRI is not really a tool used a lot in some countries, even before 24 weeks. And I would like to talk a little bit about this early time points of fetal MR use in fetal brain imaging, which early, again, I would define as before 24 weeks and super early before 20 weeks. According to the ISOC guidelines, we have the clear recommendation that MRI before 18 weeks does not usually provide information. Again, this holds true till up to now. We have currently experimental use of this technology before 18 weeks. In some cases, the guidelines state that we can also obtain valuable information before 22 weeks. But generally, the best time doing fetal MR is between 26 and 32 weeks of pregnancy. This is a consensus coming from different authorities and different centers around the world. But keep in mind, there are local legislations, local, let's say, cultures in performing prenatal medicine. In my environment here, there is an absolute need to contribute phenotypic and imaging information before 24 weeks. So in our environment, we are more or less forced to provide and establish a method with added value before 24 weeks. And that's the reason why we are trying to improve in that area. I would like to go through a systematic approach here, establishing fetal MRI at before 24 weeks or even 20 weeks it requires a systematic approach. We are going to talk a little bit about MR safety because this is important here. The challenges we are actually facing. We are going to talk about the fetal brain then as a main topic. Well, fetal MRI is a safe method. We have to acknowledge this. Up to now, we now have a lot of data around. We have a lot of experience now. There is no study documenting any adverse effect by fetal MR done at 1.5 or 3 Tesla. Keep in mind that also theoretical studies of continuous scanning for 1 hour, for instance, are not really reflecting the true clinical situation. We spend about 33% of our time in acquiring imaging and depositing energy into the women, and the rest of this time of a fetal MRI examination, and that's more than 2/3 of that time, we are planning actually, and we are chasing the fetus to get proper images. The main issue is heating. We know from animal experiments that continuous exposure, and I mean continuous with hours of exposure in core temperatures above 2 degrees Celsius can lead to certain anomalies in animal models. Just to give you an overview what is happening, with ultrasound, we are also depositing energy and heat into the fetus. We are raising body temperature up to 0.7%. On MRI, using MRI in the, let's say, normal mode, normal operating mode, which is available to everybody of us on every machine. That's the typical clinical operational mode. We are raising temperatures up to 0.5%. 5 degrees, and in the first level use we might approach 1 degree Celsius, but this would be an exceptional use in certain situations. Also be aware that the most of the energy we are using in fetal MR is actually deposited in the mom. It's not reaching the fetus, and that's, I think, a very important point in the discussion of teratogenicity. So generally, there is no indication telling us to keep away from early use of fetal MR. It is, from a physical standpoint, a safe technology. However, we are facing technological challenges. When we are doing MR images of a pregnant woman at that age, like 14 plus 2 gestational weeks, we see a lot of signal and a picture coming from mom, but not from the fetus. The fetus is very, very small, and that is our main challenge. MRI has its strength in giving this good overview, giving a good tissue contrast, but not necessarily in imaging resolution, where ultrasound is clearly the technology to go. So we might get some help from modern imaging technology to investigate these emerging structures you have learned about in Roy's perfect talk again today. One of these very early, basically, structures to appear, to be established, is the corpus callosum. That's the way we see the corpus callosum at 17 plus 1 gestational weeks. Please note, again, this does not seem to be very sharp, this image. The borders are not so distinct as you might be used seeing that on ultrasound. Now we have some help with AI image reconstruction on MRI, and with that we can get a little bit sharper images even at that early time points, and we can discriminate different features such as the genome of the corpus callosum, the lamina terminalis. Here is the fornix. That's very interesting. There is a discussion always. Is the tinea fornicis the bright thing seen on ultrasound, or is it dark? That would be the MRI ultrasound correlation, what you're seeing here. And then you have the splenium of the corpus callosum back here. And I was, because I was also very new to this early imaging findings, and I was thinking, what are we seeing between the tactile plate and the genome of the corpus callosum? What's happening in between here? And in fact, this is the roof of the third ventricle. We are going to talk about that in a minute. Here is a comparison between Hochstetter's median sagittal cut of a 16 gestational weeks fetus with ultrasound and MRI. And if we are looking here, we are seeing the tectum very well on all of those methods and approaches. Here again, the fornix and the lamina terminalis, and the very small at that time point, but still discriminable, distinguishable corpus callosum. And again, in between the posterior end of the corpus callosum and the tectum, there is a space which you do not see at 20 weeks and later, because it's basically covered by the corpus callosum, by the extent of the corpus callosum, and that is actually the roof of the third ventricle. And if you go back to Hochstetter's cuts, you see that this is made out of leptomeninges, and therefore it's rather hyperechogenic on ultrasound, and here on MRI has a more or less mixed signal. Now, some of those structures we are seeing are not only emerging, they are also changing. The hippocampus is a typical feature of that. You have heard about the hippocampus today already. That's how it looked like on MRI, just the hippocampal and temporal lobe section between 17 and 26 gestational weeks, and you see that this structure is continuously flipped over, more horizontalized and positioned then in the medial aspect of the temporal lobe. You can see that on ultrasound as well. Here on these nice images, you can evaluate the hippocampus very nicely. My feeling is that it's sometimes hard to catch the hippocampus properly, also due to shadowing and depending on the technique you're having. On MRI, we are not limited by any bone shadowing or any insonation angles, and for that it's more or less easy to identify the position of the hippocampus. Then, besides changing structures, changing their position, you have transient structures. Transience is a very important concept in the fetal brain. You have here ultrasound images at 20 gestational weeks, just of the frontal lobe, and a little bit backwards already at the level of the basal ganglia. These are, I would say, very good quality ultrasound images. Of course, the machine is not tweaked to generate a distinct contrast between the different layers. However, this is what you basically get from a generally available sonography machine. In comparison to that, this is the MRI, and I'm not now saying or telling you that there is a difference or one or the other is better. I'm just emphasizing on the differences between both methods. And the differences, what you can appreciate here is that where ultrasound is more putting more emphasis at the different sonographic, let's say, the different layers in terms of leptomeningeal layers and surface of the brain, which is very bright here. The MRI contrast is more based on the water around the brain and inside the brain, and what you see is through that through this water distribution you have different distinct layers: the cortical plate, subplate, and the periventricular zone. And if you compress or suppress this water signal, it gets dark, and you are left with more of these contrasts within the brain, as you can evaluate here. This is a different impression than the one from ultrasound, and what I'm stating here is it's not a better impression, and it's a different impression, and that's what I think the whole story is about. You have an added different contrast to your ultrasound contrast, giving you more information, and usually more information is more knowledge. More knowledge means better prognosis. This is the DWI image with also this in the same case, showing you the distinct layers. And what you notice is that around the ventricles, we get a very, very bright signal here. And this signal comes from the ventricular and subventricular zones, which are the most important zones of the human brain at early gestational stages. Why? Because here is laid down what makes us human. Only humans have a very broad subventricular zone. This is this zone here, and it's basically this zone around the ventricles. In vivo, it looks like on T2 weighted images that the zone has a very dark signal, meaning high cellularity. If you suppress again the water signal from the brain with MRI, you get this bright signal around the ventricles, again indicating that there are a lot of cells, a lot of proliferation going on. So you get a nice contrast of this region. This is at 18+3, again, this dark signal around the ventricles, this subventricular and ventricular zones. At 14 gestational weeks, if you look at the brain, you can see that you can evaluate these structures as you see with these rather earlier images. However, what you're seeing here is that there is not this typical layering visible. Why? Because we are actually at these early time points at the sublate formation phase. It's basically just appearing. So it's a newly appearing transient zone at 14 weeks, and what you see is the cortical plate, and below the subplate, the superficial and deep subplate, and this is a rather thin area at this stage, and because it's thin, we are often have a hard time to see it on MRI, but with new AI technologies, image reconstruction technologies, we are already able to see these very early time points of subplate formation at around 14 gestational weeks. Another structure which is very prominent at the early time points of fetal brain scanning and therefore important is the ganglionic eminence. This is basically the thickening of the periventricular zone at the region or above the basal ganglia. This is the paper by Marlene Stümpflen, who really nicely measured the size of this structure in early and late stages of gestation, and you can see that at 19 weeks, this is really very nicely visualized here by 3D MRI and continuously decreases in size. And if you contrast that with also the size of the cortex, you can see at the time of cortical expansion and growth, at the same time, the ganglionic eminence is decreasing in size. So the ganglionic eminence contains structural, but also indirect functional information about fetal brain development at these early stages. MRI gives you a very nice contrast to delineate this structure. This is a histoimage on a sagittal. Also, of course, in the sagittal plane, you can see the ganglionic eminence. If you reconstruct this ganglionic eminence, you will see that there is something extending also in the olfactory bulbs. And this is the rostral migratory stream. This is basically this reconstruction. This structure here is a stream of migrating neurons which goes into the olfactory bulbs and is there stays there for quite some time. So migration is not over at 24 weeks. What you may have read 10 or 15 years ago, migration continues quite late. And there is one aspect here which is particularly exciting. If you look at this rostral migratory stream here again into the olfactory bulbs, from that region there is another thing which is called ARCACC. This is the arc, that's the way they call it. And these neurons there are particularly human. You will not find them in apes, you will not find them in any other animal. It's only humans who contain that, and that is a human-specific structure which is there histologically. And this is just to emphasize how important this region is and how important the delineation of this region is. We do not really see this arc on fetal MR, but maybe after improving resolution, we might. This is a hint towards the rostral migratory stream, which we can see in certain cases, particularly at 3 Tesla. Now, how does the brain abnormally look at these times? We see at 16 weeks sometimes cases with with too early gyrus formation, over-sulcation. This is a grossly abnormal brain. This is the post-mortem. This was a Curry-Jones syndrome, very rare syndrome related with preterm formation of gyri and sulci. A similar case without interestingly genetic findings, but hugely abnormal brain. With AI reconstruction, we can evaluate also this abnormal gyri here and a clearly abnormal posterior fossa and abnormal eyes. Posterior fossa development is very exciting before 24 gestational weeks. It's also exciting after, but before particularly, because before it's driven by one structure, and that is the rhombic lip. And please remember that structure. Will come across that multiple times. I think for the future, the concept of posterior fossa malformations will change a lot when we consider the rhombic lip concept more. The rhombic lip is there very early. As you see, 10 post-conceptual weeks, it's already there. And then it's continuously placed inwards into the vermis, finally sitting just on the lower lip of this fastigium. And that's where it belongs. And you can see with hematoxylin eosin stainings that there are a lot of cells in this structure. Yes, because they are contributing to the size of the cerebellum. And if you now look at the sagittal comparisons again, Hochstetter MRI and Roy's ultrasound images, you see that exactly at this lower end of the vermis, there on ultrasound is a lot of exogenicity. Of course, this is the choroid plexus, the talar choroidea there. On MRI, you do not see the choroid plexus very well, but you see this lip-like extension quite nicely. So what we are basically seeing is the talar choroidea complex, and what you're seeing here is the difference in how it looks on MRI and on ultrasound. On ultrasound, you see more this echogenicity from the choroid plexus, which we do not see on MRI. On MRI, you can evaluate this hypercellularity of the rhombic lip, which is contributing to the size of the cerebellum, and if abnormal, also to the morphology of the typical Dandy Walker phenotypes. Later at 23 weeks, and this was at 17 weeks, and now we are at 23 weeks, and at 23 weeks already the rhombic lip is internalized, or should be internalized, to the fastigium, and this is how it looks like on MRI and with AI reconstruction. Again, a dark dot because there are a lot of cells, dark D2 because there are a lot of cells which will migrate to the rest of the cerebellum. Why is this important? This is just an outlook. I will not go into the depth here, but this is a case at 16 plus 3 gestational weeks. You see upward rotated cerebellar vermis, but at the lower end, there is one thing right here. This is the rhombic lip. This is the vermian tail. So the vermian tail is nothing more than a non-inward positioned or non-well positioned rhombic lip. The other arrow here points to the position of the choroid plexus, which we on MRI have difficulties to see. And this is the post-mortem specimen. This rhombic lip or vermian tail would be sitting here. Now, often we can see these changes in cases of abnormal placenta. We have the impression that this, like this case here, is also often seen in other conditions interfering with hemodynamics and also fetal brain hemodynamics, and for that, let's say an arrest, not an entire arrest, but a delay in the normal trajectory of this rhombic lip development. This is the data on congenital heart disease cases where we often see these lips and often see cerebellar changes. Well, and with that, I hope I could give you a good overview about the different challenges and opportunities we have with fetal MR. We are still at the beginning in exploring this method before 24 gestational weeks. We learn a lot from ultrasound. We are very glad that there is already data there on larger scales. There is reference data there, but please keep in mind you cannot translate ultrasound data directly to MRI because both give you different information. And again, as I said, information is knowledge and knowledge is better medicine. And thanks for your attention.
Thank you very much, Gregor. I think that we need to go to session 2 without questions. I answered the few questions that were on the chat and the question and answers. So I think that we can go for the presentation by Daniela. Prashant, are you there?
I'm here.
So go ahead, introduce Daniela.
It's my pleasure to introduce Professor Daniela Pryor, and she's one of the pioneer worker especially for the fetal MRI and correlating especially for the fetal brain malformations. Over to you, Daniela. And she's a board member. Let me tell you, one of first board member of the Fetal Brain Society. Over to Daniela.
I tried to share my slides. Do you see some slide? No?
No, we see you only.
Now it's okay.
No, you have to share your screen on top right.
Yes, I did that. Now I share my screen and I try to share the PowerPoint file.
Open the PowerPoint file first, then share.
Go back.
I did it.
Go back to the power.
Okay, got it.
It's okay. Now it's okay.
Now it's fine. Make it full screen.
Do you see the PowerPoint file?
Yeah, we see.
Yes.
We see. Yeah, we see it. Make it full screen.
I make it full screen.
Yeah.
Now it works.
Not yet. It is not full screen. Yeah, it is not full screen. Just make it full screen. Share again. Make it full screen.
Yes. So I have to go there, and now it should be work. Now it should work.
No, it is not because you are not sharing right now.
You need to go to the PowerPoint.
Yes, I'm there.
Open the PowerPoint first.
Yes, it's open.
Go back to the PowerPoint.
Yes,
now it's okay.
Now it's okay. Now make it full screen.
Yes.
Yes.
It's okay.
No.
Yes
you are in presenter mode, so that's the reason it is showing. You have to choose window, and then you can choose it, or else stop presentation mode. Utilize regular mode.
Oh Gott, was passiert da? Muss ich es da drüben machen? Oder ich weiß das nicht. Okay. How is it now? No,
you are still in presenter mode.
No, I'm not.
Yeah, we can see both side by side slides. Or when you share, you will have window, or you can choose window. Then in that you can share it on a presenter mode.
Hast du? Ja, das mache ich die ganze Zeit.
Ist deine Apps an?
Oder?
Mauricio.
Wait.
Ayúdala.
Yes. Someone is helping her now.
Yeah. Es funktioniert nicht.
Oh, Gregor is there.
Only from sharing the screen, stop presenter mode, regular mode presentation will work.
Muy buena.
No está bien, yo anoche comí bastante. Eso es antes de la presentación. ¿Está presentando?
No pueden entrar.
Share, you can choose. Yeah, now it's okay. That's
Oh,
perfect.
now it's okay. It's okay.
Okay. Now, my topic is the contribution of preoperative fetal MRI in open neural tube defects. What is better, the MMC repair pre or postnatally? Well, in prenatal repair, as you can see clearly here, you don't need a CSF shunt that often. It is in postnatal repair, about 67% will need a shunt. In prenatal, only a quarter of cases. Also, hydromyelia may be a bigger problem in postnatal repair, but supratentorially, there are not much differences, for instance, with respect to corpus callosum anomalies. However, also Fox defects are much more frequent in postnatal repair. On the right side, you see prenatal Fox defects that look like hemispheric interdigitations. That means the gyri of the respective hemisphere are touching each other, and this might be a reason for later epilepsy. In the images below, you see a case that was surgically repaired only postnatally, and what you see that there is still, and the vermis is still in the spinal canal, and there is no reposition of the vermis, and this is a big disadvantage of postnatal repair. What else? As I already said, supratentorial changes are equally in pre and postnatal repair. For instance, subependymal heterotopia. On the right side, you see such a case in gestation week 23, and these heterotopia occur regardless whether there is pre or postnatal repair. Of course, in prenatal repair, as I already mentioned, there are higher rates of normal location of the fourth ventricle. You see an example that was treated prenatally on the right side. There are lower rates of hindbrain herniation, tactile beating, or brainstem distortion, or kinking at school age. And as I already said, the supratentorial abnormalities do not differ from each other so much. However, in prenatal repair, we might have a higher rate of postnatal thyroid cord release surgery. What does it mean? Look at the case on the right side, and what you see indicated by the yellow arrows, that the parts of the neural plateau are fixed on the posterior dura. And this problem occurs more often in prenatal repairs. But now let's look what can MRI do in spinal dysraphism. The big question is, do we need MRI preoperatively? And a questionnaire was done, including 38 centers from 16 countries. And 87.9% said, yes, we need a prenatal MRI. And 12.1% said, no, we are going along with ultrasound. If you look into the MOMS trial said, yes, you should do prenatal MRI before intrauterine surgery. Well, an old question that we were asked to answer using our MRI was, could we differentiate between open and closed defects? Because it was also said in the MOMS trial that closed defects will not be treated surgically intrauterinely. But the problem is about 40% of myelocystoceles, which are closed defects, have a posterior fossa that is small. There will be hindbrain herniation and there will be hydrocephalus. And these are clearly symptoms that can be improved by prenatal surgery. So in the meantime, 5% of the centers perform surgery in such cases. So the differential diagnosis by MRI is not that important anymore. Well, up to now, what were the questions asked to MRI before or also after surgery? Well, there should be a structured reporting of anomalies before therapy, the detection of contraindications, and afterwards, of course, we should have a look at post-therapeutic changes at the success of the treatment. This is out of the MUMS trial. The contraindications, among others, were there the fetal anomaly unrelated to myelomeningocele or a severe kyphosis, as you see in the case below of 30 degrees or more. Well, many centers use still the strict inclusion and exclusion criteria derived from the MUMS protocol that are now 15 years old. There have been already some recommendations to regularly review these criteria and also taking into consideration the experience of this respective center, also new literature and input and experiences from other centers. And there is a group in Switzerland, they adapted that indications and they did not consider in any case the contraindication suggested by the MUMS trial. For instance, they operated on mothers with high BMI or higher levels of the defects or no herniation, also in higher gestational weeks, also with associated anomalies. And if you look at the list, at the lower part of the list on the right side, also in connection with intracerebral hemorrhage, which was a clear contraindication from the MUMS trial. So what we ask ourselves is, do we have come up with a new description of this myelomeningocele and the associated brain changes? And so we tried to establish a phenome of the Chiari-2 malformation. What is a phenome? A phenome is the complete set of phenotypes resulting from genetic variation in populations of an organism. It is said that genotypes are embedded in genomes and individuality in phenotypes is embedded in components of the phenome. And the term phenotype can refer to any morphologic, biochemical, physiological, or behavioral characteristic of an organism. This is the common description of a phenome, but I want to show you an example that is not related to myelomeningocele. Just this is a phenome that was established for the description of chronic liver disease. What you see here are nodes, and these nodes reflect the occurrence frequency of a symptom, and the lines reflect the occurrence frequency. So if there are dense lines, this is a very frequent symptom, and the node size reflects the incidence. And so you see anything that may be related to chronic liver disease and the relative importance for causing chronic liver disease. So now, this was the question. Can the MRI-based Chiari-2 phenome help with indications for intrauterine MMC repair? And this is how the phenome looks like. But at first, I want you to have a look at the list on the right side, because this is where we are now, MRI structured reporting. It is just a list of symptoms. And if you look here, other intracranial abnormalities can just be answered with yes or no. But this is not enough, because if you look at the phenome on the left side, we want to relate that morphological symptoms to each other and to our Chiari malformation. And as you can see, there are many points that are very close to the red point in the middle. So, for instance, compare the size of these nodes: intracranial hemorrhage, venous sinus stenosis, venous congestion, and brain edema, and compare them with the symptoms that we know as, for instance, ventricular megaly, aqueduct stenosis, fourth ventricle stenosis, and protrusion of the atlanto-occipital membrane. And then you will see that symptoms, that morphological symptoms in green seem to be intrinsic parts of the Chiari-2 phenome and of the Chiari-2 malformation, and so probably they should not be contraindications for intrauterine treatment. Well, they are intrinsic features of the Chiari-2 brain and as important as the symptoms that we already know. Let's look at some images. What about brain edema and intraventricular hemorrhage? Well, you see in the upper row a case in gestation at week 23 with brain edema, and in the lower row a case without brain edema. So if you look at these brains, of course, both of them have vermis herniation. The bulging of the atlanto-occipital membrane is more pronounced in the fetus in the upper row with the brain edema. Then look at that orange arrows. There are congested periventricular veins that are not there in the case without brain edema. And there are hemorrhages with the green arrows also only in the case with brain edema, but not without. And in addition, in cases without brain edema, we might be able to recognize some normal structures at that age. For instance, with the blue arrows, the periventricular crossroads that are still present in gestation with 23, and the preserved lamination, as you see it especially with the purple arrows, indicated with the purple arrows on that image with the suppressed CSF signal. Well, of course, we can also do measurements, for instance, on the diffusion-weighted images, and we can distinguish brain edema from not brain edema also on diffusion-weighted images, but that measurements do not really distinguish these cases from each other. As all the assessments of the signals and the other morphological assessments are rather subjective impressions, and of course, if you have seen a lot, you will make the right diagnosis. We wanted to look whether it was really true what we were seeing, and so we applied radiomics, and the radiomics algorithm confirmed that there is a presence of brain edema in some Chiari brains, but not in others. So using this algorithm that includes a lot of more information than the human eye can see, we could confirm our impressions of the presence or absence of brain edema. Well, what is the reason? Look at the three cases in gestation 36, the first and the second, and gestation 33. The first column shows a Chiari-2 case with brain edema, and you see there is a very narrow clivus supraocciput angle in the upper row. Case B is a case without, and there this angle is not so narrow. And the case in the rightest column, this is a part of our second control group. We had a normal control group, and we had also a control group that was consisted of cases with aqueduct stenosis, because also aqueduct stenosis leads to ventricular enlargement, and sometimes the cerebellum is pushed downwards. So we wanted to know if this venous congestion is just a consequence of any hydrocephalus, or is it a specialty associated with the Chiari-2 brain? And as you can see here, now look at the lower row. The yellow stars indicate the congested and thickened veins, and they were present only in the Chiaris, especially in those with brain edema, but not, or to a much lesser extent, in the cases with aqueduct stenosis. So what we are dealing with is an elevated venous pressure due to congestion or occlusion of the draining veins because of that compression situation in the craniocervical junction. And here you have such an example prenatally in the upper row in gestation week 35 and postnatally, where you clearly can see sinus thrombosis and hemorrhage. And in the list on the right side, you see the parenchymal changes, the stages of sinus thrombosis associated changes in the brain. And as you can see here, most of them in the case that we looked at in gestation 35 and after birth, there is massive edema and hemorrhage. So it is a severe elevated venous pressure. Well, here we have two cases. Gestation week 21, you see that hyperintensity of the brain parenchyma that we can see visually, and the effacement of the outer spaces. And there is also IVH, intraventricular hemorrhage, as you can see in that image on the farthest right side. And you have another case in the lower row where we also have post-mortem images and very much congested periventricular veins. And this is a case that survived. Why? Because fetal surgery was done in spite of the findings of brain edema and in spite of the findings of intracerebral hemorrhage. And now look at that image, 31 and 4 days post-surgery. There is a regular signal of the brain parenchyma. There is an unfolding of the CSF spaces and no signs of venous congestion anymore after surgery. In this case, contraindications had been present according to the mom's criteria. So, what are the conclusions from our study? Fetal MRI in the presurgical workup of MMC may identify candidates that have so far widely been excluded from prenatal repair, but who will benefit from this procedure. And phenomes provide the most morphological information about the respective syndrome. And it is obviously the whole is larger than the sum of its parts. Thank you very much for your patience and for your kind attention.
Thank you, Daniela. Thank you, Daniela, again. It was a brilliant talk and made more detailed glimpses about open neural tube defect and before surgery what you can do or how you can predict. Now over to Mauricio. Mauricio, please go ahead and about your talk, please.
Thank you, Prashant. Because I need to open my presentation. Give me 2 seconds here. I have a small problem here now. Okay, I think that I am done. Okay, I'm going to share. Thank you, Prashant.
Please.
Okay, now I think that you can see my screen.
Yes, we can see.
Okay. Thank you for the introduction and thank you to all the Fetal Brain Society board for this invitation and for giving me the opportunity to share with you some data regarding to the fetal therapy and surgery in the fetal brain. It's amazing the data that Daniela showed before, because it's one of the most important points regarding to how to do the accurate evaluation before to offer to the patient the possibility to do any treatment in utero at the fetal brain. Okay, if we are going to talk about fetal therapy or surgery in fetal neurology actually around the world, we need to consider some procedures that we can do. And they are going to include, obviously, the open neural tube defects, especially speaking about the spina bifida and all the introduction that Daniela already did regarding to the MOMS study and the condition that we need to consider. The other possibilities and other abnormalities that we can consider is in the severe ventriculomegaly. We are working very hard regarding to introduce the ventriculostomy as one of the possibilities in the severe ventriculomegaly in some conditions, obviously without severe abnormalities, and always with the main objective to improve the prognosis of all these viruses. The other condition is the cephalocell, and all depends on the severity of the cephalocell. And the most recently one is regarding to how to improve the prognosis in the fetuses with some AV abnormalities. And in this kind of treatments, the embolizations, it's one of the possibilities in the fetal neurology. Okay, several papers maybe you can find in the literature regarding to the possibility to do some important evaluations and considerations in some cases. Obviously, the severity of the abnormalities in the fetal brain needs to be need to consider the accurate evaluation. Then we can consider the fetal therapy and surgery. Let's speak a little bit about the open neural tube defect, and for speak about the open neural tube defect, we need to consider several and important things. The most important one is to remember that the neural tube closing process include at least 5 regions, and that is very important because regarding to the severity and the combination of the regions, okay, reduce the possibility of the interventions in utero, and also depend on not only the severity, also depend of the secondary changes, as Daniela showed before. Regarding to the risk factors, you know that it is important to rule out the possibility of genetic conditions for the fetal therapy and surgery in spina bifida. And if you see the slide, it is important to consider the mutations that can be associated with some syndromic conditions. And that is because it is very important, the genetic approach and the complete evaluation, not only from the anatomic point of view to find the defect, also to rule out the possibility and other genetic conditions that could be in association. The next important point is regarding to evaluate the anatomy in the spina bifida and the defects that we need to identify that could be in association, the segments that is going to be involved. But it's very important, and I love the Daniela's approach, because we need to consider the hits that the fetal brain and the fetal CNS is having during the pregnancy with fetus with the diagnosis of spina bifida. If you see this, we need to consider that the brain impact, and for sure the brain has some changes that we need to take in account, the intraventricular hemorrhage and the not only the severe ventriculomegaly, also the brain edema and the venous edema. That is a very another important change that we need to consider. This is the typical approach, as you can see in the fetal MRI, as Daniela showed it before. As you can see here, You can see, obviously, the collapse of the suranectoid space, the severe ventriculomegaly, the brain edema, and the intraventricular hemorrhage, and the typical approach to the open spina bifida. But it's not only that. Remember that classically, until now, we describe 2 hits. That is because actually we consider in our approach, we need to consider at least 3 hits. And the 3rd hit is specifically at the brain. That is because it's very, very important to consider. I did this slide to show you the comparison. This is the MRI of one of our patients after more than 115 cases doing in utero repair or spina bifida. As you can see, these are the fetal MRI of one fetus with spina bifida before the fetal surgery. And you can see and you can compare the fetal MRI after the fetal surgery after 4 weeks. That is amazing to see that we change, obviously, the anatomic hole that the baby has in the spina, but you can see and you can do the comparison. This is the same fetus, and this is the fetus as the fetal surgery, and you can see the complete recovery of the suranectoid space. You see that the brain reduced the edema. That is an amazing, another important approach in the same way that Daniela mentioned before. And you can see that the improved mechanisms regarding to the cisternas, and you only not consider, look at the posterior fossa that is actually completely normal, and the 4th ventricle that also is completely normal. You can see the coronal, and you can compare that. It's evident that the 3rd hit in the spina bifida is the brain. And Daniela showed it before, and I'm trying to show you and compare the fetal MRIs, and I am doing this work, and I hope publish this in the White Journal this year regarding that you can see the changes that we are having after the fetal surgery, and we can compare that. Okay, regarding to let's say the objectives of the spina bifida surgery. Obviously, is reduce the incidence and severity of the neurological, motor, and sensory injuries in the lower limbs. But also, you need to take into account that we are reducing the mortality, because this kind of fetuses in the neonatal period and also in the childhood period increase the secondary effects regarding, for example, with the urinary infections, okay, the brain complications, and that increase the possibility of mortality. That is because during the surgery and in the prenatal, in the pre-surgical evaluation, sorry, we consider, including the classification, as you can see here, obviously the severity of the herniation of the lesion. The size of the lesion is very important to consider regarding to improve the possibility of the techniques. And the other important point is regarding to the herniation of the placoda and the cover of the lesion, about if it's included meninges or not. That is very, very important regarding to try to understand the possibilities for the fetus and improving the results in the surgery. These are some images from our cases, obviously with open and with fetoscopic surgery, and you can see the lesion, for example, in this case, myelomeningocele, and you can see the lesion after repair. That is very, very clear. The impact that the lesion has not only at the brain, also at the medulla, and obviously you can predict the possibilities for improve the prognosis. These kind of lesions are very typical, and we consider as a myelomeningocele. In our experience, another important point for improve the prognosis is the technique regarding to closing the defects in open or in fetoscopic fetal surgery in 3 layers. That is very, very important from the technique point of view. And these are the cases about the myelomeningocele with myeloschisis. You know, big defects, okay, that include at least more than 2 or 3 segments. And it's important to consider in the closing technique regarding for improve the possibilities and for do some recommendation to the neurosurgeon and obviously for the pediatric surgeon, because it's not only close the defect, it's the technique, because in many series they are having in the childhood period and in the follow-up the increasing sequela regarding to the treader cord, and that is an amazing an important point that you need to take in account for improve the prognosis in this kind of cases. That is because we consider, and we are doing also both techniques, the open fetal surgery and the fetoscopic surgery in our center here in Abu Dhabi and actually also in Colombia, that we are offering to the patient depends on the size of the defect, obviously the severity of the changes. We are offering both techniques, the open and fetoscopic fetal surgery. And in this case, it's very important to consider that all the centers need to be ready and need to have a complete team to offer the open and the fetoscopic fetal surgery, because not all the cases are the same. And the team members need to include the neurosurgeon and the pediatric surgeon, obviously, in order to improve the possibilities and obviously to make a great job as a team. The other important point for the consideration in fetal therapy and fetal neurology is from the embolization of the vein of Galen malformation. You know that this case from the French group and leading by Ipsville. And you know that it is possible to do it and consider also several cases from our group and also from Italian groups and in other countries in Latin America is having a good prognosis. But the good prognosis depends on the moment of the diagnosis and obviously the edema and the severity of the AV shunt. That is another important point to consider. Okay, let's move on with the cephalocell. When we speak about, and we need to speak about the cephalocell, we need to take in account some considerations. And some consideration is regarding to the severity of the amount of brain that is herniated in the whole. I mean, and obviously you need to take in account the many cases is going to be in correlation with syndromic condition. That is because not depends only if in your country you have the possibility to consider termination of pregnancy. It's not only that possibility, it's the possibility that you need to offer to the patient to rule out other genetic conditions to offer the fetal surgery and the cephalocell. One important thing in the fetal surgery and the cephalocell is the herniation of the brain through the hole, and it is important to consider that for improve the prognosis, the amount of brain that is herniated, it needs to be less than 20%. And the other important point, as you see in several papers, is that more than 85% of the cases of cephalocell has abnormal cortical development and obviously other chromosomal conditions. Let me share with you, this is my last slides regarding to improve the time that we are taking in during the Fetal Brain Congress and this amazing online session. And you can see this is the typical approach of cephalocell, sorry, and you can see there that this is a cephalocell without herniation of the brain, only meninges. And we did the fetal MRIs in this case, and you can see the huge herniation of the meninges and the compromise of the cephalocells with the posterior fossa. And you can see here the cerebellum, okay, obviously the hypoplastic cerebellum secondary to the lesion and the big cyst that the fetus has in the posterior fossa. Well, we can move to the fetal surgery, obviously with the open fetal surgery, because the mass is very, very big, as you can and you can saw it there. And this is part of our technique. I'm going to share with you the technique doing the open feeder surgery in these huge masses. And our technique regarding to the jumping technique is improving and reducing the manipulation of the baby and improving the prognosis in these kind of cases. And you can see we put the baby in the right position, and you can see there the lesion and the cephalocell there. And we did with the neurosurgeon, we did the reduction of the lesion, and this is the images and the video after the surgery of the cephalocell, and you can see the amazing result, and we close the defect and we reduce the herniation. Okay, my last point regarding to this important approach in fetal surgery and fetal therapy is some important consideration and conclusions. That the protocol in spina bifida surgery needs to consider the fetal MRI not only for complete evaluation. As you saw the Daniela's lecture, it is important to do the evaluation of the secondary changes about the intraventricular hemorrhage. We have the same experience in our cases, and regarding to the brain edema is very, very important. Another important point regarding that not all the cases are eligible for fetal surgery. And obviously, in all the cases, you need to have a complete approach with the multidisciplinary team for improve the prognosis. Thank you very much for your attention. I think that we are going to move on with our next session, no, Gustavo? And our next chairman. You need to put on the mic. Put on your mic, Gustavo, please. Okay, now. Speak, please.
Yeah.
No. Put on your mic.
Unmute yourself, Gustavo. Unmute yourself.
Unmute.
Still you need to unmute.
You need to unmute, Gustavo.
Okay, let me continue with the
same. Go on, Prashant.
Yeah. Now it's my privilege to introduce Dario, and Dario is going to chair the next session. Dario will, and is Dario there? Dario?
Yeah, Prashant, can you hear me?
Please. Yeah, we can hear you. So welcome, Dario, again our board member and international very renowned faculty. Please, Dario, go ahead, and the session is yours, and you please chair the session.
Thank you, Prashant. Thank you. Good. Hello, everybody who's online with us. Roughly 1,000 people online now. So it's glad to have all of you here with us today on this Saturday. And so without any delay, I would like to move on with this session on fetal ventriculomegaly. So it is my heartfelt pleasure to introduce Anastasia Rekvo from Fetal Medicine Foundation in King's College, and she's associate professor there, and she will speak about ventriculomegaly, definition, diagnosis, and association. Please, Anastasia.
Hello, everybody. Thank you very much for introduction. I'll just share my slides.
Let's open PowerPoint.
It's open.
Open your PowerPoint presentation first, then share. If you are opening in a presenter view, then click window, otherwise full screen.
Yes, but it takes me to the privacy settings somehow, and everything is working here.
Otherwise, I can try mine in the meantime.
Yes.
Okay.
If it is Mac, you'll have to check out your privacy settings.
Now, Dario.
Yeah.
Yes, you are in the.
Yeah,
okay.
Go ahead.
Meanwhile, Anastasia can fix the system. Okay.
But doesn't take the presentation.
Yes. No, you have to first share. First now then share. Share on the screen. Share on the screen.
Yeah, I try, but
no. We can see, Dario. We can see your presentation.
Make it full screen. Make it full screen. Make it full screen.
Yeah, and the issue is that it doesn't go full screen.
No, it is just go down. I think you cannot see your arrow. That's it. Yes, yeah. Go ahead. Click it.
Yeah, it doesn't work.
Okay, you need
Let's
to
try this way, but
reopen
it. Stop sharing and try again.
Anastasia, you have to stop sharing. And now you share, Dario.
Yeah, I will try again. And
now Anastasia's screen is already there. Please go ahead, Anastasia.
Okay, so Anastasia, please go ahead.
I'm very sorry for technical problems, not on purpose at all. Okay, so thank you very much for introduction. And my topic is on ventriculomegaly. I will speak about definition, diagnosis, and associations in relation to ventriculomegaly. Now, we all are aware that we define ventriculomegaly whenever we see lateral ventricles and we measure them 10 millimeters or more than that. And as Elisenda mentioned already before, it is very important to assess ventricular system in a very accurate plane. Whenever we have symmetrical hemispheres, we see straight midline, and at the level of parieto-occipital fissure, we measure lateral ventricles. Ventriculomegaly can be classified as mild, moderate, and severe depending on the measurement, and it is found in about 1% of fetuses at any gestation throughout the pregnancy. Why ventriculomegaly is very important is because it is a very strong marker of underlying pathology, including brain pathology, but also extracranial abnormalities, and very soon I will show you why. Now, is there any early sign of ventriculomegaly? And the answer is yes. We recently looked at almost 7,000 singleton pregnancies at 14 to 17 weeks of gestation, and we found that and we found that appearance of the core plexus being as dangling, meaning floating freely in the ventricular cavity, can be an early sign of ventriculomegaly, but also sign of major fetal abnormalities, chromosomal aberrations, and single gene mutations. In terms of etiology of ventriculomegaly, we can classify etiology in 4 big groups, and one of these groups is obstructive ventriculomegaly, obstruction of the cerebrospinal fluid circulation along the ventricular system. And this obstruction can happen at different level of ventricular system. It can be aqueductal stenosis, it can be Chiari malformation, or, for example, intraventricular hemorrhage, when the clots just obstruct the normal circulation of the fluid. It can be destructive ventriculomegaly when the damage of parenchyma due to the congenital infection, porencephaly, or ischemic injury, the parenchyma of the brain is disappearing, and cerebrospinal fluid is just taking over the missing parenchyma, hence we see ventriculomegaly. The ventriculomegaly can be developmental due to abnormally developing brain, and this can be due to chromosomal abnormalities or genetic conditions, and it can be due to hypersecretion, and this is of course more rare reason of ventriculomegaly. This can be seen in cases of cord plexus papilloma. Now, to come to the conclusion why we see ventriculomegaly, we need to perform several examinations, including detailed anatomy assessment of the entire fetus. We need to perform a proper scan of the brain, neurosonography, with MRI being a valuable tool in the assessment of the CNS pathology. We need to perform screening for infections and, of course, genetic evaluation. Now, when it comes to the neurosonography, we heard already this morning beautiful lectures about the tricks and tips how to perform neurosonography. And what is also very important is whenever we visualize the brain, we do a systematic assessment of the anatomy of the brain. We check midline anatomy, make sure that we don't miss agenesis of corpus callosum, there is no septo-optic dysplasia, and of course holoprosencephaly. We assess infratentorium, we make sure that there is no conditions such as then the Walker malformation, rhomboencephalosynapsis, or pontocerebellar hypoplasia. We check parenchyma to make sure that there is no hemorrhage, no ischemia, no infection. And of course, we assess cortex, making sure that we don't miss cases of lysencephaly, heterotopia, and polymicrogyria. Now, let me take you through some of the major abnormalities that are commonly presenting with ventriculomegaly, and of course the most common abnormality of the brain is agenesis of corpus callosum, which is commonly presenting with mild ventriculomegaly, and of course abnormal shape of the ventricles, so-called colpocephaly, and absent cavum septi pellucidum. On the coronal assessment of the brain, we see a classic presentation of anterior horns being very distal from the midline and each other. In the sagittal view, we clearly don't visualize corpus callosum, and we use Dopplers to just assess the course of pericallosal artery, and in this case, we usually see abnormal course of pericallosal artery. Now, in case of agenesis of septum pellucidum, it is important to make sure which condition is behind agenesis of septum pellucidum, because this can be several. And of course, holoprosencephaly and schizencephaly is quite easy to diagnose. Destructive processes, for example, cytomegalovirus, can affect development of the brain and affect and just destroy septi pellucidum. However, in all these first 3 cases, you will see many additional abnormalities. When it comes to the septo-optic dysplasia, it's more difficult. You clearly need to visualize beautiful corpus callosum to make sure that that's not the case of septo-optic dysplasia. And pituitary gland hypoplasia, optic nerves, is more difficult and challenging to visualize and assess the function of these structures. Hence, to differentiate between septo-optic dysplasia and isolated agenesis of septum pellucidum remains challenging throughout the pregnancy. Ventriculomegaly is one of the criteria for diagnosis of Dandy-Walker malformation. In Dandy-Walker, we usually have severe abnormality of posterior fossa and of course ventriculomegaly. We have cystic dilatation of the 4th ventricle, we have hypoplasia or agenesis of the vermis, enlarged posterior fossa, and displacement of the tentorium. Ventriculomegaly can be also presented in cases of rhomboencephalosynapsis, which is a condition of abnormally developing posterior fossa, where the cerebellar hemispheres are fused along the midline in the absence of vermis. And this condition was described by Professor Haraz and her team as early as 14 weeks of gestation. And you can see that fetus already at this stage presented with disproportional enlargement of the lateral ventricles, being an early sign of ventriculomegaly. Ventriculomegaly can also be a sign of pontocerebellar hypoplasia, again, abnormally developing hindbrain and midbrain, midbrain and hindbrain developing in an abnormal fashion. The ventriculomegaly is commonly present, and it can be severe ventriculomegaly from early stage of the pregnancy. Hence, whenever we see ventriculomegaly, we need to make sure that the midbrain and hindbrain are developing in a proper way. And as mentioned earlier this morning, pons should be very straight, and the midbrain should be straight after 14 weeks of gestation. And as you can see on the lower image, in the fetus of 26 weeks, pons is very dysplastic, it has abnormal shape and configuration. And in this case, pontocerebellar hypoplasia was diagnosed caused by a specific gene mutation. Ventriculomegaly can be a sign in case of intraventricular hemorrhage, again, because of the clots are obstructing normal circulation of the cerebrospinal fluid. And in this case, there was obvious changes in the ventricular cavity with lots of clots. However, ventriculomegaly can be seen in less severe hemorrhage as well. Usually, hemorrhage occurs at the level of germinal matrix, which is a highly vascular area in the brain, very sensitive to any changes, and it can be due to, for example, ischemic events or gene mutation or alloimmune thrombocytopenia. So whenever you suspect intraventricular hemorrhage, don't forget to test for these conditions, because this, of course, won't change the prognosis and management of ongoing pregnancy, but this will definitely affect the future of the family. So screen family for anti-HPA antibodies, and of course, exome sequencing for collagen gene mutation, because this can be the cause of intraventricular hemorrhage. Ventriculomegaly can be, again, a sign of congenital infection, because infection in case of cytomegalovirus, it affects parenchyma, it destroys parenchyma, and the fluid is taking over. In cases of cytomegalovirus, it is also important to assess the rest of the brain, of course, and make sure that, in cases of severe ventriculomegaly, there can be signs of polymicrogyria and calcifications, and of course, in these cases, prognosis will be much, much worse. Ventriculomegaly can be also a sign of malformations of cortical development. In these cases, fetus will present not only with mild or severe ventriculomegaly, but many other additional findings. As you can see in this case, at 24 weeks, very abnormal anterior complex, abnormal ciliary fissure, prominent head of caudate nuclei, lissencephaly, periventricular heterotopia, and dysplastic corpus callosum. Or, as in this case, at 27 weeks, again, interdigitation of midline, asymmetrical frontal horns, and very abnormal ciliary fissure. In this case, tubulinopathy was confirmed. So whenever we see a fetus with ventriculomegaly, irrespective of what is gestational age, it is very important to check the brain of the baby, but also to make a proper assessment of entire anatomy. The reason for that is that in many cases we first react on ventriculomegaly, and sometimes we even miss to check the properly anatomy of the fetus. And as in this case, fetus presented with severe ventriculomegaly, and the assessment of the skull, severe encephalocele was detected as well, and further genetic evaluation confirmed Walker-Warburg syndrome. It is important to check the face of the fetus, because some changes in the anatomy of the face can also navigate you towards the right diagnosis, as in this case, moderate ventriculomegaly and cleft palate, and further genetic testing confirmed Teacher-Collins syndrome. It is important to check even the ears of the baby, because abnormally developing ears in the presence of ventriculomegaly can guide geneticists towards the right diagnosis, and in this case, Pallister-Killian syndrome. It is important to check heart of the baby, because common is common. And for example, AVSD with mild ventriculomegaly is very pathognomic sign of trisomy 21. Of course, we don't forget to check spine properly, because in case of spina bifida, ventriculomegaly is one of the signs. And of course, extremities, especially, for example, as in this case, male fetus presented with severe ventriculomegaly, and on the assessment of the lower and upper extremities, adducted thumb was clearly visualized. And in this case, you don't even need to do further testing. The diagnosis is very clear. It's L1CAM mutation. When it comes to the ventriculomegaly, the very important question is whether we do MRI examination or not. And the answer is very simple. It is yes, we always do MRI, because both in mild and severe cases of ventriculomegaly, there might be additional finding not seen on ultrasound. In case of mild ventriculomegaly, it's up to 5% of additional findings, and in severe ventriculomegaly, up to 20%. And what are these additional findings? Well, the most commonly seen are cortical malformations, which are sometimes, it's not easy to see clearly on ultrasound unless you're very well trained and an expert in the field. Midline abnormalities, including corpus callosum, and of course, acquired lesions such as small bleeds can be missed on ultrasound and confirmed on MRI. Another question, whether we do fetal MRI only or we do only postnatal MRI. And in this case, it's always, I would say, combination of both, because prenatally it will guide you with more information towards the right diagnosis, while postnatally, as you can see, the numbers can slightly vary in terms of how reliable prenatal MRI can be, because in up to 20% of cases, there might be additional findings on postnatal MRI. So both are important. Even if you perform a very detailed assessment of fetal anatomy at 20 weeks, it doesn't mean that you rule out ventriculomegaly for the rest of the pregnancy. At King's, we performed a screening study of the ultrasound assessment at 36 weeks. It's over 100,000 pregnancies. And as you can see, in 76% of cases, ventriculomegaly for the first time was diagnosed at 36 weeks. So a proper scan at 20 weeks doesn't rule out ventriculomegaly. Always remember to bring women back, especially if there is a borderline or mild ventriculomegaly, to make sure that there are no further changes. In terms of prognosis, well, if ventriculomegaly is very mild and stable, there are no additional findings, genetic test is, let's say, fine and normal, all is good, the prognosis is good. Normal development in 90% of cases.
2 minutes.
Thank you. And in case of progressive ventriculomegaly, of course, it is more associated with delay in the development. And of course, if there are additional abnormalities, including Dandy Walker or abnormal genetics, of course, prognosis will be poor. And here's again about genetic evaluation. There are discussions whether genetic testing should be performed in all cases of ventriculomegaly, and the answer is yes, because up to 10% in these cases there might be chromosomal abnormalities. And in terms of exome sequencing, again, the access to exome sequencing can vary depending on the country you live. And in the UK, for example, in cases of isolated ventriculomegaly, we cannot perform exome sequencing, but you see the numbers that in cases of isolated ventriculomegaly, up to 6% of diagnostic yield of exome sequencing. So if you can, do exome sequencing. So I think I convinced you that ventriculomegaly is not just a measurement. It can be associated with many abnormalities, and proper evaluation of entire fetus is very important. Thank you very much for your attention.
Thank you, Anastasia. Thank you so much also for keeping to the allotted time. And then I will try my best to share my presentation. Is it okay?
Yeah, okay, perfect.
Okay, so let me try to get the the things going. It doesn't work.
You can see the presentation. Perfect, Dario.
Yeah, but I cannot manage it. I don't know why.
No, you
Okay.
we can see your cursor. We can see your cursor. I think.
Yeah, you can see my cursor, but I cannot move on the presentation, so I'm not sure how to move it.
Okay.
Okay, let's try this way. I have the laser, and can you see it?
Yes, we can see it.
Okay, perfect. So the important premise, of course, if you want to have a look at the key structure for looking at aqueductal stenosis and atresia, which is the aqueduct, you've seen the fantastic presentation by Anastasia telling you why you may have ventricular dilatation. And now we come to the actual primary lesion that may be associated and determine ventriculomegaly, which is aqueductal obstruction. So to look at the aqueduct, which is in the centralmost part of the brain, you need to go transvaginal with high resolution ultrasound, because the area we are concentrating on is this one in the central part of the brain, highlighted in orange. And this is a key area for looking in the third ventricle, which is here, the Sylvian aqueduct, which is here, and the whole of the encephalon, which will be involved in a series of complex malformation that may bring about aqueductal atresia, as we will see in the second part of my talk. Now, if we go back to Alexander's talk on the screening level, we can actually, if we look in detail at the midline, see these two tiny blebs, which corresponds to the third ventricle and the aqueduct, okay? 1 and 2. And these are you can familiarize with this aspect because this can be seen also with non-high resolution ultrasound, okay? 1 and 2. If we move a bit further along the oblique section towards the cerebellar and the fourth ventricle, you can see that these structures are in common. So you can trace a line in the lumen from the third ventricle to the fourth ventricle. Keeping in mind that the aqueduct is not always patent for the whole length of the aqueduct for all the time. It opens up, it's a virtual channel, it opens up to let the fluid pass and then will close again in part of the aqueduct, okay? And magnification, sometimes you may have also a mild dilatation of the two structures. You see the third ventricle and the aqueduct, and this is the fourth ventricle. So you have a patent aqueduct, but this, if not associated with ventriculomegaly, is not a problem per se. So let's have a look first at the third ventricle, which is the structure where the aqueduct starts from, as you see here. So this is the area, and we had the chance to study it in detail with Roy when he has been at my unit a few years ago now, and he did a brilliant work. You see that the key factor for getting a very nice view is a perpendicular approach to the structure that you want to assess. So in this case, it's the third ventricle, and this is how it looks on high resolution transvaginal ultrasound. You see here in all these structures and border that we will depict. If we want to have a look at the aqueduct, you should go at 90 degrees with the aqueduct. And again, this is the structure. You see the fourth ventricle, and this area here, which is a bit hidden, is the third ventricle. Now, we have been aware of the fact that you can have a look at the aqueduct since 20 years ago, when some radiologists from Turkey demonstrated and classified the normal aqueduct that can be apparent. You see very ill-defined imaging on transabdominal ultrasound by radiology at that time as a single line or a double parallel line or a converging lines, but all of them were considered as being normal if there is no ventriculomegaly associated. However, the correct way to assess in details the aqueduct is by transvaginal ultrasound, as I told you before. And if you look at the aqueduct, you can actually see all the, at the third ventricle, you can see all the components from the moral foramen here to the anterior part. Here is the hypothalamus, and here is the interthalamic adhesion, okay? And this is the recess at the level of the aqueduct. This is the paper I mentioned before, and we actually measured all the possible diameters and angles that can be reproducible at the level of the third ventricle with ROI. And we also highlighted with tridimensional ultrasound and power Doppler all the key factors: the intercerebral vein, which is here, the telachoroidea of the third ventricle, which is the roof of the third ventricle that you see here. So all these structures are visible if you go with the transvaginal ultrasound, and also doing some fancy reconstructions with 3D, you can actually pass through the moral foramen and reconstruct the conjunction of the two choric plexuses of the lateral ventricle into the telachoroidea of the third ventricle. This is an image cut from below, from the base of the brain, and this is the telachoroidea of the third ventricle. And you see the reconstructed image of the choric plexus of the two lateral ventricle meeting here, which corresponds to this structure here, across the moral foramina at the level of the telachoroidea of the third ventricle. The lowermost portion of the third ventricle points to the hypothalamus, which is here. We cannot see actually the hypophysis, the pituitary gland, as such in ultrasound, unlike the MRI, where it's a very bright white dot, so it's quite highlightable, but not for us. So it's difficult to see that. A very nice paper addressing the aqueduct, and again you see that the key factor is an insonation which should be at 90 degrees with the structure of interest. In this case, the aqueduct was published a few years ago by Fernando Viñals and this Chilean group, showing you that it can indeed be traced across gestation from the second trimester onwards, let alone in the first trimester. You've seen the brilliant talks by Roy and Brusilov before. So now we come to the pathology. The Sylvian aqueduct may be malformed, forking or atretic and so on, with segmental obstruction. And you may have a partial obstructions or a complete obstructions. Okay, these are the two features. Now, when we have, what are the signs that may point to an aqueductal stenosis? You have severe progressive ventriculomegaly, progressing from the second to the third trimester, as you see here on the actual view. Then you see a narrowing of the aqueduct at a certain point. You see the dilatation of the third ventricle. And if you bear that in mind, you can have this image also on transabdominal ultrasound with an oblique view connecting the third and the fourth ventricle. The key point, the key features telling you that there is indeed an aqueductal stenosis are two. The first one is the dilatation of the suprapineal recess of the third ventricle that you see here. And the second is the association with this a slight dilatation of the initial part of the aqueduct, which then ends abruptly, and you cannot raise the aqueduct further towards the fourth ventricle. And if you look at the brain from the coronal plane, you see the so-called Mickey Mouse appearance because of the dilatation of the two lateral ventricles. Sometimes the septum may be disrupted, and you have dilatation of the third ventricle as well. This is another case, again on transabdominal ultrasound, 30 gestational weeks, severe dilatation of the lateral ventricles and the third ventricle as well. And you see that usually in the fetus, the occipital portion of the lateral ventricles are more dilated than the frontal horns. And again, the typical features on the transvaginal neurosonography, dilatation of the suprapineal recess, and dilatation of the initial part of the aqueduct. We studied with Roy what happens with the interthalamic adhesion with progressive ventriculomegaly, and you see that according to the degree of pressure within the third ventricle, you may have compression, so it shrunk interthalamic adhesion. This is the normal counterpart for the same gestational age, and sometimes it may also detach because it's an adhesion, so the two hemi portion of the interthalamic adhesion may detach due to the compression of the due to the increased pressure in the third ventricle. There has been a paper by the French group telling that apparently in their experience, but it has not been confirmed by other groups, you have two different progression of the aqueductal stenosis. In one, the progression is very idle and linear, as you see, and it leads to moderate to moderately severe ventricular obstruction by the time of birth. And not all these may end up having need for a shunt or third ventriculostomy. On the other hand, conversely, you have the fast progression, which most of the cases were below the 10 millimeters cutoff until the late second trimester, that then only later they just boosted up in their degree of ventriculomegaly, and some of them needed earlier delivery to warrant that there were no secondary lesion from ischemic compressive changes of the white matter. Despite this, in this group, they found that in some of the cases, there were already some association with white matter lesion, also responsible for the progression of the obstruction of the aqueduct. If we come to the complete obstruction, in this case, ventriculomegaly is very early onset and very severe, usually from 3 and 15 weeks. And in most of the cases, you have an association with some obstruction or non-disjunction of the diencephalon and the mesencephalon. This may end up with cerebellar hypoplasia or rhomboencephalosynapsis. So whenever you see a very early onset ventriculomegaly, this was published by Laurent Guibault a few years ago, and we all have some cases which resemble this case. And you see here that we demonstrate there was some fusion at the level of the diencephalon and the mesencephalon in these very early onset ventriculomegaly cases. So if you have severe ventriculomegaly early in pregnancy, these are his cases, and these are our cases on multiplanar imaging. You see that there was cerebellar hypoplasia and very severe ventriculomegaly already at 17 weeks of gestation. These are always of aqueductal atresia in the context of the encephalorhomboencephalosynapsis. Then at the level of the posterior fossa, you may have cerebellar hypoplasia or you may have rhomboencephalosynapsis, doesn't matter, but the obstruction is very severe and very early onset in pregnancy. This is another case. Or you see the high degree of ventriculomegaly in this case. Another case, you see here, at 13 weeks there were already evidence of severe ventriculomegaly, and by 17 weeks there was the diagnosis done and confirmed of aqueductal atresia, nulling of the subarachnoid spaces, and a very, very small cerebellum. Two final considerations. The first one is that mild ventriculomegaly, as Anastasia brilliantly pointed out before, might be a sign of an underlying genetic condition. For example, in this case, there was a mild dilatation of the third ventricle and the aqueduct that you see here, a nuchal lymphangiectasia, an atrial width or initial atrial width of 9.3 millimeters at 20 gestational weeks. And you see the features. This is the aqueduct. Then by 25 weeks, there was mild ventriculomegaly, a thin brainstem, a distorted, slightly distorted anterior complex that Elisenda also pointed out to in her talk, and dilatation of the third ventricle. And by the third trimester, it ended up with additional cortical malformation that you see here, and this giric frontoparietal cortex. So mild ventriculomegaly may also be a strong marker for genetic condition. And to finish with a condition that may be associated with aqueductal atresia or aqueductal stenosis, we have difficulties in diagnosing it with ultrasound. It's challenging. We are working on that now, but it is a very easy diagnosis on MRI, as Gregor and Daniela may point out afterwards. Is a rare malformation characterized by poorly defined junction between the encephalon and mesencephalon, and may be variably associated with other malformations, including callosal abnormalities and ventricular dilatation. On the sagittal view, which is the most convenient for us to see because the cleft at this level, is the butterfly cleft at this level, is very difficult for us to pick up, is the assessment of the third ventricle, the massa interthalamic adhesion, and you see that there are three types of this type of DMJD dysplasia: either non-separation between the hypothalamus and the midbrain, or parenchymal bands between the interthalamic adhesion, or complete fusion of the interthalamic adhesion with the midbrain. And this was brilliantly characterized by our Severino and Andrea Rossi group a few years ago. As you see here, we worked with them until I was located in Genoa, now in Verona, northeast of Italy, university. And this is one of our case. You see, you can imagine the cleft, because this is just the two separation of the at the level of the midbrain. And then you go to the mid-sagittal plane, and you see indeed, if you remember the image of the third ventricle, there is no fluid component here, and there is complete fusion of the massa or interthalamic adhesion that you see here with the midbrain. So this was a confirmation of the, and this is a normal third ventricle. As you see, the massa interthalamica is completely detached from the midbrain. And in this case, it was associated with the ventricular, with aqueductal atresia, and it was the poor baby, 28 weeks of gestation, already white matter secondary changes there. You see the cleft on the axial views. If you know it, you can actually see it. Otherwise, you don't. This is the fusion of the interthalamic adhesion with the midbrain. This was the bulging forehead due to the extremely severe microcephaly, and this is the baby at birth with the transillumination of the severe ventriculomegaly. So in conclusion of my talk, the third ventricle and the aqueduct can be studied in detail on high-resolution transvaginal ultrasound, but you may have a nice view of them also on axial plane if you think about how to look at the midline, okay? The assessment of these structures allow to characterize both obstructive aqueductal lesions, and you have to keep in mind that you may have more complex conditions such as the encephalomesencephalon synapses as a primary lesion for leading to complete aqueductal obstruction, as well as the encephalomesencephalosynapses, as I pointed out before, together with rhomboencephalosynapses. Second, distortion or mild provenance of the centrally located structures may represent the only sign that you may pick up initially on ultrasound, because ventriculomegaly, severe ventriculomegaly may be absent of a very severe genetic condition, and that's why you have to focus on the anterior complex as much as you can, and on distortion of the midline as well. And with this neuroendoscopic imaging of the wonderful choriplex of the third ventricle in the neonate, I thank you all for your attention. Now, I will stop sharing the screen, and I will move to the next talk, which is Leo Pomar, and he will present very, very interesting and challenging cases. I've never seen that in my life. You always learn from what happens. Spontaneous ventriculocysternostomy in early obstructive hydrocephalus. Leo, are you online?
I'm online. Can you hear me?
Yeah, sure.
Yes.
Please share
And
the
can you see
screen.
my screen? Yeah.
Yes, yes. Please go ahead.
Perfect. So thank you for the invitation. I'm going to talk about this rare outcome of obstructive hydrocephalus. And as Dario just explained to us, obstructive hydrocephalus can be due to abductal stenosis with a dilatation of the third ventricle, supraoptic recess, suprapineal recess, and this funneling on the upper part of the adduct. It can be also due to more complex malformations with adduct atresia, and often we have other abnormalities such as this case of diencephalo-mesencephalosynapsis. It can be due to lower malformations, rhombocephalosynapsis, or Carey malformation. And we can also see obstructive hydrocephaly due to acquired abnormalities such as intraventricular hemorrhages with a clot blocking the adduct, or other infections. Sometimes toxoplasmosis, we can see a cyst blocking the adduct. Whatever is the cause, as Anastasia told us, the risk of associated malformations or underlying genetic etiologies are high, and severe neurological outcomes are also high, depending on the underlying etiology and of hydrocephaly progression. So now, regarding hydrocephaly progression, for conservative parents, in fact, there are different outcomes because they can wait the birth for postnatal shunting, and we have to monitor the head circumference, sometimes to induce the birth prematurely if the head circumference is too large. Or in some centers, they can opt for experimental in utero therapies like cephalocentesis, mainly to improve obstetrical outcomes for the mother, or ventriculoamniotic shunt, or even endoscopic third ventriculostomy at the level of the floor of the third ventricle. It's feasible, but we still lack the data, the evidence regarding the benefits of this intervention. And I wonder myself, is it possible to have a spontaneous opening of the third ventricle in case of obstructive hydrocephalus? Because if we look the postnatal literature, we can see some cases, some rare cases, where the third ventricle is opening on its floor or on the suprapineal recess posteriorly. And if we look now the prenatal literature, I also found one case. This is the only one case described to my knowledge. On the left figure, the red arrow indicates spontaneous ventriculostomy that happened before this postnatal endoscopic surgery at the floor of the third ventricle in a case undergoing prenatal surgery for myelomeningocele repair. And in fact, I had two recent cases, very similar cases, where we suspected this phenomenon. And when I reviewed all our cases of obstructive hydrocephalus due to abductal stenosis, atresia, or due to spina bifida or hemorrhage, I suspected another cases among the case terminated. So this is the first case I want to share with you. This patient was referred to us at 18 weeks of gestation due to severe ventriculomegaly. We diagnosed abductal stenosis. On the mid-sagittal plane, you can see enlarged third ventricle with an enlarged suprapineal recess and the abductal stenosis with the funneling on the upper part of the abduct. The amniocentesis was non-contributive as the IOS-AGH and NGS were normal. And look at the progression of the ventriculomegaly a month later. In fact, we observed a regression of the ventriculomegaly. And when you go to the mid-sagittal plane, look at the suprapineal recess at 22 weeks. We can still see the suprapineal recess, but what we observe here is an opening just above the pineal gland, indicated by the blue arrow. So is it a sign of spontaneous ventriculocystanostomy in this fetus? Let's move 1 week later. 1 week later, we confirmed unilateral rupture of the septum pellucidum. It's often the case in obstructive hydrocephalus. Normal size of the ventricles, no dilatation of the supraepineal recess, and normal aspect of the third ventricle. And if we look the coronal plane at this level, you can see an unusual opening above the pineal gland, indicates here by the blue arrow. And we think this is the opening leading to spontaneous ventriculocysternostomy between the third ventricle and the quadrigeminal cistern in this fetus. This fetus continues with normal brain development except the distal stenosis. He had an MRI at 32 weeks of gestation, and on the T2 seconds, we can see the adductal stenosis, and again, here a rupture in the posterior leaf of the third ventricle at the level where we suspect spontaneous ventriculocysternostomy. Here you can see the same opening on axial and coronal planes. And the outcome of this case was the birth of a full-term baby weighing 3.2 kilograms with a normal head circumference at 33 centimeters and no occurrence of hydrocephaly, no need of shunting, and normal neurological outcome at 1 month of life. As I said, it's a very recent case, so I don't have yet long-term outcome. And the postnatal MRI has not yet been performed due to the favorable outcome of this case. So now let's share a second case with you. This patient was referred to us at 25 weeks due to moderate ventriculomegaly. We also observed a thick interthalamic adhesion and adductal stenosis, as you can see here on the coronal plane. And we also diagnosed a cervicothoracic vertebral malformations. The name is Kippel-Feil syndrome with a C3 and C4 segmentation abnormalities and down to T5. Again, the amniocentesis was not contributive. In Kippel-Feil syndrome, we can expect a mutation on GDF6 or GDF3 genes, but here these genes were normal. And let's have a look on the progression of this case. In fact, in this case, the ventriculomegaly continues to progress up to the third trimester. At 31 weeks of gestation, we have still no fluid on the extracerebral spaces, still the thick interthalamic adhesion, a large dilatation of the supraepineal recess, indicated here by the red arrow. And on the MRI at 34 weeks of gestation, you can note fluid around the brain and fluid in the fourth ventricle. And if we move to the mid-sagittal view, we still have the adductal stenosis, but look at the supraepineal recess. The morphology of the supraepineal recess changed since the ultrasound 2 weeks before. And here we can note an opening in the posterior wall of the supraepineal recess. You can see the same opening on the axial plane here, indicated by the blue arrow. And the outcome was a term-born infant with normal clinical examination. He underwent postnatal MRI with complete regression of hydrocephaly, no need of shunting, and cerebrospinal fluid communication between the third ventricle and the quadrigeminal cistern. Here on postnatal T1 weighted sagittal brain MRI, we confirmed a spontaneous posterior ventriculostomy, the blue arrow. And here on the T2 weighted MRI, we suspected a flow artifact with low signal intensity between the third ventricle and the quadrigeminal cistern. Ideally, we should have fast contrast or SSFP seconds for the cerebral fluid, but unfortunately, these seconds were not performed during this examination. And despite the Kippel-Feil syndrome and the need for physical therapy to address neck, tone, and mobility, this infant shows normal development in his other motor and cognitive skills at 6 months of age. And the last case I would like to share with you, it's an older case. This patient was referred at 17 weeks of gestation for hydrocephaly. Again, we suspected an adductal stenosis, but here on the lower part of the adduct, because you can see fluid on the upper part of the adduct. The hydrocephaly continued to progress. At 22 weeks of gestation, we noted a large dilatation of the suprapineal recess and also a partial corpus callosum agenesis with the splenium missing. The parents opted for termination of pregnancy in this case. And what was our surprise when on this 24 weeks brain at autopsy, hydrocephalus no longer seemed to be present. In fact, it's usual for the ventricles to appear smaller after the brain is opened, but here our pathologist noted an unusual tear in the suprapineal recess, which could also correspond to another case of spontaneous ventriculostomy. So in conclusion, I think that spontaneous ventriculocysternostomy or ventriculostomy can occur through the suprapineal recess. Also, it has been rarely described up to now. If we look at the postnatal literature, it indicates that in case of primary or secondary obstructive hydrocephalus, around 5% of this case may regress due to spontaneous ventriculostomy. It may reduce the need for postnatal shunting. I don't know if it improves neurological outcome because, as I said, I only have a very short postnatal follow-up. So I need and we need long-term follow-up of this case and future cases to know the risk of recurrence and the risk of associated neurodevelopmental outcomes. And if you are interested in showing some similar cases, you can send me an email and I will be glad to a case series with you. Thank you very much for your attention, and I would like to thank my team for fetal neurology in Lausanne. Thank you very much.
Thank you, Leo. Thank you so much. Very interesting cases, and I wonder whether there is any of the delegates with similar cases. You may contact Leo for sharing their documentation. I think they would be more than happy to collate these cases if that's the case. So there are a few questions for each of us. I replied at one directed to me on the Q&A form on Teams platform, and I asked Elisenda to reply to one on the CSP and Mauricio to do likewise for one related to a long-term prognosis of the operated cases. So I think that we are managing not so bad with time, but we will keep on replying to questions. Please do submit them using the Q&A section chat on the platform, so we may keep on time. So I thank so much Anastasia and Leo for their availability in this session and for brilliant lectures and interesting cases. And we move on, and I leave the chair to Ritsuko. Ritsuko, are you here? Hello?
Hello, yes.
Okay, perfect. Hello, hi, good to see you. And I hand the mic to you for chairing the next session. Thank you all for your attention so far.
Go ahead, Ritsuko.
All right. So, just a moment. I'd like to proceed the session 4, acquired insults, and unfortunately, the first speaker, Moran Hausman, is unavailable. unable to join us today due to technical problems. So I would like to proceed the second speaker, Karina Credon-Harratz, from Tel Aviv. And Nina is going to talk about the intraventricular hemorrhage and including the role of NJS, right? Nina?
Hi, hello everyone. Hello, Ritsuko. Are you hearing me? Yes?
Yes, we can.
And can you see the slides?
Yeah,
Yes,
we can see
yes.
those.
Okay, perfect. Thank you, Ritsuko, for your introduction. And thank you everyone to be here with us. After all the adversity, I'm very happy that science thrives and we are gathering here together to discuss what we like the most. And I'll try also to cover a bit of the material from Moran, as we are from the same institution. And we are going to discuss the recent insights on fetal intraventricular hemorrhage from the diagnostic perspective to prognosis within the time that was given us. And let's start with the clear cut and with the basics. So whenever we see a fetus with ventriculomegaly and blood products inside the lateral ventricles, it's quite clear and easy to establish the diagnosis of the severe ventriculomegaly, to understand that this fetus underwent an insult, and whenever the lesions are severe as this, as well to understand that the risk of the abnormal neurodevelopmental outcome is quite significant. However, in many cases, it will be a little bit different whenever the findings are more subtle, whenever there is no clear hemorrhagic content within the ventricles, whenever we have hyperechogenic lesion affecting the brain parenchyma, then the differential diagnosis will widen up. And of course, the prognostication as well, according to the extent of the involvement and to the etiology that is found. So a little back to basics. I think whenever we scan a fetus, not necessarily with ventriculomegaly, but whenever we need to do the differential diagnosis or we suspect on a brain insult, there are some views that are important and specific regarding intraventricular hemorrhage. I want to address two images, which is the three-horn view. So whenever we check the ventricle in the parasagittal view, we can check the three-horn view, and the caudothalamic groove. Many times when I teach, I am asked to show in live scans where is the caudothalamic groove. So here we have, I don't know if you see my pointer. I will change to another one that surely you are going to see. So here we will have the area.
It works.
Thank you, Dario. The area of the caudate nucleus, the area of the thalamus, and this will be the caudothalamic groove. We have the choroid plexus and the germinal matrix that is surrounding the ventricle. We can see the whole area in one image, which does not substitute a swipe, but is a very informative view of the brain whenever we suspect on the presence of a lesion or an insult. And in this area of the caudothalamic groove, where the germinal matrix that covers the upper aspect of the caudate is one of the favorite spots for the beginning of the processes of the intraventricular hemorrhages that can be just focalized into this region or spread up into other regions. We need to understand, and I don't have time to really discuss the mechanism of disease, but the intraventricular hemorrhages, they will take origin mostly on the germinal matrix that surrounds these ventricles, and Roy is going to speak later more specifically on the involvement of a specific area of the germinal matrix, which are the ganglionic eminences. And in these cases also then gestational age will be an important factor for the consequences of the insult to these areas. But these epithel that surrounds the ventricles, and it's the birth of the neurons that are going to migrate, is very, very sensitive throughout the whole pregnancy, and insults into this area and in different spots may lead to different clinical consequences. It is also the area in which the neonate is prone to bleed, but we know that many times the fetal insults may have better prognosis dependent on the area than the neonate. And this is one of the reasons that lately we have a discussion trying to separate a little bit the classification and the prognostication from the fetus and from the neonates regarding the IVH. So we have spoken about the three-horn view, and also the anterior complex, or the extended anterior complex view, is another important ultrasound view that should be taken into consideration to analyze these areas, as we are going to see the ganglionic eminences and the periventricular areas, and we are going to see chronic abnormalities into these areas, and may be able to distinguish between subependymal cysts that will have better prognosis, and between porencephaly or periventricular leukomalacia that will affect normally motor areas and have other types of consequences. So we have the classical classification from Papil that classified into grade 1, 2, 3, 4 according to the area affected and to the mechanism of disease, which is a little bit passé, especially regarding the grade 4, but we still use our classification based on this previous concept. And here we see a case of grade 1. Most cases of intraventricular hemorrhage will appear later on in pregnancy, after the first half of pregnancy. The very early ones will be mostly related to insults like infection or some severe cases of NATE, but most cases will appear later on in pregnancy. And this is another important aspect of the third trimester ultrasound to be taken into consideration. So here we have the caudothalamic groove, in which we have the hyperechogenic, very focal lesion, not vacuolized yet. Here again, the same aspect of the lesion, and here we see it already evolved to vacuolization. Back then in 2002, Gustavo has already published, and there are many other publications discussing this aspect after that. Whenever we can call it a periventricular pseudocyst or differentiate it from a subependymal cyst, that is an evolution of a grade 1 bleeding. Sometimes it's quite difficult to differentiate between them. The good point is that as an isolated finding, they have a very, very good prognosis, and anatomically, whenever they are, these cystic lesions are above the line of the lateral ventricles, so these white matter affects motor neurons, and then may have motor consequences. Therefore, we will consider these lesions much worse prognosis. Proceeding to grade 2, we have intraventricular bleeding. Here we see the clots within the ventricles. Sometimes we have also intrachoroidal bleeding that may drip into the lateral ventricle and then stain the CSF, but no other extension. Important to understand that the lesions are not, the fetuses don't read the book. So many times we have also the caudothalamic groove involved, also intraventricular clots, also periventricular involvement, so parenchymal involvement. So we could say it is a grade 1 and 2 and PVHI. We need to understand that more important than giving the name is to describe the areas affected in order to try to prognosticate these lesions. So it's not that easy sometimes to give a name, but the name is not that important. Progressing whenever these ventricles dilatate, so we have post-hemorrhagic ventricular dilatation, PHVD, we have hydrocephalus or ventriculomegaly and hydrocephalus. If it obstructs the third ventricle, we will have bilateral, and if it drains to the fourth ventricle and then to extraaxial space, we will have the tetraventricular dilatation and its consequences. Here it's very easy to make the diagnosis. Sometimes it's not that easy. Sometimes we see a ventricular dilatation which is not that severe. We see signs of ventriculitis, which is the hyperechogenicity around the ventricular walls. And then we need to check very, very careful the ventricular walls in order to try to understand whether the reason of this ventriculomegaly is an IVH. This is an important, I won't enter MRI because it will be addressed later, but it's an important reason to do an early MRI so we are sure that we can differentiate in the susceptibility sequences the presence of remnants of blood that are not always clear in the T2 and for sure not in the T1 sequences. So for these cases, it's important to associate the MRI, and this is one of the main reasons that at least in our clinic we order an early MRI for the differential diagnosis, which is very, very important to prognosticate these cases. And when we speak about the parenchymatic compromise, then there is the acute and the chronic phase, which poses a diagnostic challenge to us, and we need to understand the mechanism of disease. The periventricular areas are mostly affected, not as we say an expansion of the bleeding, but what we call the PVI or the PVHI, which is the post-hemorrhagic venous infarction. And it may extend to different areas of the brain. So the stasis of the medullary veins that need to drain these periventricular areas will lead then to a periventricular hemorrhagic infarction. So the mechanism of disease is different from the original mechanism that led into the grade 1, 2, and 3. And it will, the extent of the affection of the periventricular areas will be related to prognosis. And then it takes us back to differential diagnosis of the periventricular hyperechogenic lesions. Then if they progress with time, and depending on the anatomical area that they involve, they will lead to different prognosis. So here we have a case in which we have grade 2 hemorrhage. The ventricles are not dilated, and also we have the impairment of the periventricular area in an extent that seems to be quite significant. And these cases, even if we don't have ventriculomegaly here, but it will be a very important prognostic factor. And note that we are not yet into the vacuolized phase. That would be the porencephaly phase or the periventricular leukomalacia phase, and these are easier to be detected. So here we have a stop in the ventricular wall, like a bite into the wall of the ventricle. Here is very easy. We see even the clot is sitting here. The first case I had when I established my neuroclinic in Albert Einstein in Brazil was a very interesting case because this is a 37-week fetus in breech position. This was the first patient of the first day of my clinic, a granddaughter of a previous president of the country. And they bring me this fetus at 37 weeks with sudden ventriculomegaly. So many times this is the reason of referral of these patients. And whenever we analyze the ventricular walls, then I saw a very small cyst in the caudothalamic groove, and we saw a porencephalic cyst in the occipital area of this brain. So we could already understand the mechanism of disease, even if we didn't see signs of ventriculitis and even if we didn't see the clots within the ventricle. And here is the postnatal imaging with the edema and the involvement of this occipital area. And this will help the neurologist to try to prognosticate these cases. Whenever the compromise of the periventricular area is more significant, then it vacuolizes with time, and we have what we call the periventricular leukomalacia. It can progress with time and also to do coalescent lesions with the ventricles, which is what we call the porencephaly. Back then in 2019, we have already discussed subtle findings in the periventricular area, trying to understand the mechanism of disease of these irregular ventricular walls and the differential diagnosis of these cases. And especially when associated to ventriculomegaly, we understood that these findings may have bad prognosis, but there is a differential diagnosis between them. In some cases, we have the PVHI, as we are discussing here, but sometimes we have other types of lesions and malformations of cortical development. So we need to be aware of the differential diagnosis, and MR is a very important auxiliary method. Sometimes these findings are very, very subtle. And the translation in prenatal life for the prognosis is much different than the translation that we have in the postnatal life. Sometimes the bleeding may be very, very catastrophic, as we see here, leading to tetraventricular hemorrhage, to subarachnoid hemorrhage as well, and may even drain into the eyes, which is called the Terson syndrome. So we have vitreous and a retroretinal hemorrhage, which is a very, very severe cause of a consequence of intracranial hemorrhage. And in the last minutes, I want to discuss a little bit the etiology and the prognosis of these cases. Earlier publications, of course, showed us that grade 3 and grade 4 carry a higher risk for a abnormal developmental outcome, which we already know. So as I told before, many cases are straightforward. But if we go to the literature that discuss the isolated ventriculomegaly, so we already take into consideration that we may be grade 3, many cases still become very not determined in the medical literature. And again, we need to use the aspects that we have discussed before into this lecture to try to prognosticate and try to understand these cases, remembering that every case of late ventriculomegaly, we should always try to rule out the possibility of bleeding that led into the dilatation of these ventricles. Another publication a little later, again with severe ventriculomegaly, showed at least 40% of a handicap, but again a very low detection rate of the cause of the severe ventriculomegaly. So we need to remember that there are many causes that may lead into an intraventricular bleeding and intracranial insult, genetic disorders, infection, And NATE, I think one of the things that we fear the most, especially because of the risk of recurrence, is NATE. And there are other associated factors that we need to take them into consideration. Some words about NATE. The important thing about recognizing NATE is that it will recur in further pregnancies and will require intervention. So it is very important. In our personal experience in our clinic, the rate of NATE in intracranial hemorrhage is very, very, very low. Maybe it differs according to the population, but the genetic causes, and here comes the work from Moran and the important contribution of her work to the medical literature. The genetic causes, at least in our experience, are much higher, much more prevalent than the NATE that we are always looking after and fearing about it. These many of these variants, and here we speak about the COL4A1 and 2, are autosomal dominant. They have different penetrance in the general population. We have many families with completely healthy people, and then there are some of the members of the family that are affected either with prenatal insults or postnatal insults. There is also compromise of other aspects as well. Other organs, the eyes may be affected as well. So we need to be aware of the variability of the the clinical phenotype of the COL4A1 and 2 mutations. And then Moran published this paper, which is a very interesting one, and discussing the monogenic causes of apparently idiopathic perinatal intracranial hemorrhage. Because we do coagulation tests, we do many tests, and in most cases we don't get to any answer. Important to say that if we're speaking about monogenic causes, so we need to do exome sequencing. And there are some cases of COL4A1 and 2, but there are also some rare genes that are involved as well. So an important clue is to genotype first. Not only look for panel with COL4A1 and 2, but if there is a possibility to do an exome sequencing. This is important because there are other genes that affect the vascular homeostasis, coagulation, and the walls of the vessels that may be related to these cases. And again, according to the inheritance, we will be able in many times to prevent. A recent publication has discussed then what we should check in order to try to prognosticate these cases, which is very important, and proposing a different classification, as the PVHI in the prenatal life not always correlates with a bad prognosis. So they try to locate the PVHI, so the location of the periventricular hemorrhage and the involvement of the periventricular areas, the progression, the dilatation of the ventricular walls, and also the presence of the associated findings. And they discuss that the outcome of the fetus may be different from the outcome of the newborn. And in order to end, a few words about prognostication. Still, we need to see larger series of fetuses in order to check the prognosis. This publication, also from our group, has a limitation that in the pool of the results, we didn't separate completely fetuses and neonates. We had 22 fetuses from 68 patients at a mean gestational age of 30 weeks. And in 50% of the cases, we had bad prognosis, but most cases were higher grades of IVH, and we have very, very few cases of grade 1 and 2. So this is an important bias that should be taken into consideration when reading the paper. But in higher grades, we have problems and frequent problems. And the most important factors will be the combination of intraventricular and PVHI, the presence of cerebellar hemorrhage is a very important bad prognostic factor that we need to take into consideration, affecting the posterior fossa, affecting the basal ganglia as well, or thalamic compromise are factors that need to be taken into consideration as bad prognosis. So the time of the insult did not affect prognosis in this publication, but here we did not include cases that Roy is going to speak about, the ganglionic eminence, so the very early insults. So I believe that depending on the type of the presentation, it do change the prognosis, and we need to be very, very aware of that. And they also stress the importance of the good imaging and the combination between ultrasound and the MRI for diagnosis, management, and timely intervention. And our take-home messages then show that our cases may have overlapping features with other abnormalities. Most cases of AVH still have unknown etiologies, but we need to search for preventable causes of recurrence, and the genetic causes are probably more common than innate. Be aware of evolving patterns for the differential diagnosis, so we need to check these patients serially and use early MR as a complementary method whenever we have this possibility. Remember that not always, whenever we have small PVHIs, we will have a bad prognosis, and it's different from the neonates, and a very, very important feature of working with a multidisciplinary team to establish prognosis. Thank you very much. We'll be open for questions later on.
Thank you very much, Nina. I would like to proceed the next presentation by Professor Gregor Kasparian from Vienna, Austria. And as you know, he is a pioneer of fetal MRI, and his talks are always very informative and accessible. So Gregor, in this session, his talk is on the role of MRI in the fetal brain hemorrhage. Gregor.
Thanks a lot, Rizuko, and thanks for the very kind introduction. I will try to do my best to a little bit explain the strength of MRI in detecting hemorrhages in this talk. When we think about what we are knowing about fetal brain hemorrhages and MRI, it's not so much actually. We only have like 52 overall publications on fetal brain hemorrhages. This was up to 2024. If you look at at neonatal brain hemorrhages, preterm neonatal brain hemorrhages, this is much more. So we have about 4 to 5 times more experience purely scientifically in talking about brain hemorrhages in children and neonates compared to fetuses. So we still are in the process of learning, and I think this is something for us important to recognize. I approached this talk by going from what we know from postnatal imaging to the fetal condition, because again, from postnatal imaging, postnatal IVH, which is not similar to fetal IVH, but still there are some similarities. We can say something, and we have learned something already, and I would like to start with that. Generally, all these papers are listed here, describe a higher sensitivity of MRI in detecting subtle hemorrhages. We will go into that and test that in the fetal scenario as well. There is a higher sensitivity in detecting the white matter and parenchymal involvement described in the postnatal literature on postnatal IVH, and it has been described that the accuracy of MRI in predicting motor and cognitive delay overall is somewhat better here compared postnatal MRI versus transfontanella neonatal sonography. So there might be advantages in detection, in the assessment of extent, and in the outcome prediction. Now, this is a study which has been published in the White Journal in 2020, where it was stated that neurosonography detected more IVH changes compared to MRI. So that is actually one of the main papers out there describing a higher sensitivity of ultrasound compared to MRI in detecting brain changes. Now, this is somewhat totally in contrary to what we know from the postnatal scenario and what I've shown from the literature before. Where is this coming from? And there is probably a very simple explanation to that. It's because in that comparison paper, which was done in very, very solid way, T2 and T1 weighted sequences have been compared to neurosonography, and T2 star sequences have not been used. Why is this important? Because we're talking about the difficult word of susceptibility. What does susceptibility mean? Our MRI can see more or less iron and iron particles, because if you put a magnet on something and magnetize something, as you can see here, the particles which are magnetized are positioned in a certain way in that magnetic field, and that's what we can pick up by MRI. And one particle which is particularly important is the iron particle in the blood, and that's particularly exposed to our magnetic field if we're looking at deoxyhemoglobin. Now, fetuses do have hemoglobin, of course, but it's fetal hemoglobin that's slightly different from the adult hemoglobin and has a higher efficiency in binding oxygen, and therefore also behaves a little different in the MRI, but again, grossly we can say that there are a lot of similarities between the deoxyhemoglobin, adult hemoglobin, and fetal hemoglobin. Both are causing susceptibility and are detectable by MRI. I give you this example, which we like to use in that context. You have a severe ventriculomegaly at 36 gestational weeks. You see that there is something going on within the choroid plexus in these late, let's say, hemorrhages. You know from the previous talks that the ganglionic eminence, and Roy is going to talk about that, is not really there anymore after 32, 33 gestational weeks, or at least there are only some remnants there. So the site of hemorrhage changes from early to late hemorrhages during fetal life, and is probably also a little bit moving towards to the choroid plexus as main origin point. Now, in this case, you see again this choroid plexus hemorrhage, and this is the sagittal T2. And as Dario mentioned, on MRI, we can assess the aqueduct, but be aware, this is not simple. You have to have a lot of experience in doing that. You have to hit the fetal head in a perfect mid-sagittal plane, and often this is not done properly or with dedication on MRI. So if you do it really with dedication on ultrasound again, you might find, and to say something about the aqueduct, easier on ultrasound compared to MRI. So I'm just mentioning it's also about the skill of the radiographer operating this MR machine. So in this case, we could see that there is a fine white line indicating that the aqueduct is open. Now, if we use T2 star sequences, we can realize that there is a lot of susceptibility, and susceptibility means these dark strands around the brain in the posterior fossa surrounding the entire brainstem and the cerebellum. And we also find strains of that within the aqueduct. which probably explains why we have an outlet problem of the ventricles here, slightly dilated, also fourth ventricle, so a tetraventricular hydrocephalus could be well explained by this finding. Now, what we did is we wanted to find out how more sensitive are we when we are using T2 star sequences. We looked at 108 cases here in Vienna, and this is just a selection of 2 cases, an early one at 21 gestational weeks and the other one at 34 gestational weeks, both T2 TSE sequences. If you look at these images with your typical T2 weighted standard fetal MRI sequences, you will not find any blood degradation product. Now, if you acquire a T2 star sequence or use the EPI or echoplanar acquisition mode, and be aware, this is not really rocket science. This is a 10-second sequence. Per se, the sequence is simpler than even a T2 weighted sequence. You can suddenly see that there are blood degradation products along the ventricles, particularly along the caudothalamic groove in both cases. Now, we found that we see 30% more brain hemorrhages or degradation products of blood compared to the conventional T2 weighted sequences, and still I'm seeing a lot of fetal MR protocols done internationally without this T2 star. Where does this impact most? It's not the grade 4 and the grade 3 bleedings, it's mainly the more subtle bleedings, the grades 1 and grades 2 you might miss if you're not doing T2 star. Another way to acquire information about hemorrhages is, in addition to these T2 star sequences, and here you can see those again, the SWI sequence. The SWI sequence has one advantage. It's a little bit less sensitive to the to blood than T2 star, but it has a higher specificity. As you see in those examples on the right side, you may have mistaken these slight dark lines along the ventricle as blood degradation, but in fact, this was more of they were the veins along the ventricles, and in the other case, we could prove that there is blood by using the SWI. I will not go into the details and technology of this technique, but that could be a nice use case how to use SWI for getting higher specificity, not only sensitivity to blood. This is something Daniela already mentioned today. By using T2 star in the setting of Chiari-2, you don't not only see the edema of the brain of these cases, but also the higher incidence of blood degradation products along the ventricles and in the choroid plexus in about up to 30% of cases. So hemorrhage, in fact, in Chiari-2, it's much more common than it's commonly believed. And maybe it's also something to consider when we're talking about surgery, as Daniela nicely demonstrated today. I also want to point out that not always the caudothalamic groove is the origin of a hemorrhage. The choroid plexus plays a certain role here. It's believed that, as mentioned, many hemorrhages after 30 gestational weeks are happening primarily in the choroid plexus and then are spilling out into the ventricles. This is a case at 24 weeks, so very early, and this was the only finding, this dark dot in the lateral ventricle. If you're now doing T2 star, you see how much profoundly different and darker this spot appears. We also call that blooming artifacts. This is susceptibility. This is related to a hemorrhage, as we could also prove by this SWI with the face image. This is an isolated choroid plexus hemorrhage, very, very subtle, and also compared to the other typical IVH locations, rather rare, but still this is a paper from Gupta in 2023. They found 16% In 16%, the choroid plexus is the main hemorrhage site. So I think we should also pay attention to the choroid plexus, even if the isolated choroid plexus hemorrhage has a very good prognosis. Now, this is a case where we were quite impressed that the normal T2 weighted sequence did not show any abnormality. If you look at the normal T2 TSE sequence comparing to the T2 star with where the arrow is pointing, this blood degradation products would not have been seen. This is a very subtle cerebellar hemorrhage, which we would have missed. Interestingly, in that case, ultrasound was more sensitive. Cerebellar hemorrhages are a very interesting field. You see here a defect of the cerebellum, and you also see that
the slider is for the delegates to submit their questions to the speakers.
Okay, because I'm not getting the
please
slide
close the
on-
microphone. Close the microphone.
Yes, so if you go into the Zoom chat and
so if you observe or look at the cerebellum in the case of hemorrhages and follow that process, you see that after some weeks, it's very hard to appreciate that there are blood degradation products. And that's maybe a strength of MRI, because on MRI, these hemorrhage residuals are able to be seen for a very long time. This is the same case at 21 and 30 gestational weeks. And now look at the T2 star and the T1 weighted sequence, and you see these blood degradation products there for a long time. So it's a good way to prove that the defect you are seeing there has been a hemorrhage, even if you have not seen it on the early exam. So MRI is a good way to look at the detection, improve detection, and also assess the extent. Here again, an example of a cerebellar hemorrhage, which are located typically in a subpial fashion, so they are sitting just below the pia mater. Of course, the entire cerebellum is below the pia, but this is in the outer granular layer, just adjacent to the meninges, and therefore they appear on imaging as if they would be attached to the cerebellum, and they do not typically spill out in the posterior fossa. What we found was also interesting is that these hemorrhages interfere with migration, which means that they block the migration of Bergmann glia and disrupt also neuronal migration processes. However, it's interesting to see that these cases do quite well. So the origin, this acquired origin of hemorrhages and destructive lesions seems to be a rather good prognostic factor opposed to malformative origins. One clue to differentiate malformative from acquired prognostic factors is to look at the fastigium of the cerebellum. If you have an intact vermis and you see a fastigium, it is most often an acquired origin and not malformative. The fastigium, as you know, is often obtuse in the condition of a Dandy Walker phenotype. And this was the case you just saw. Sophie is doing quite well. She has problems, not that to say she's totally asymptomatic, but still she has compensated for her cerebellar hemorrhage quite well. Finally, getting to the extent again, and Nina nicely pointed out the grading. I just want to stress again, we are talking about the grading system coming from 1978. And most of you probably will not remember, but if you look at the paper, this grading system is based not on ultrasound, not on MRI, it's based on neonatal CT. Neonatal CT is something we do not do anymore because of radiation issues. But again, if you look at these images, I think our ultrasound and MR images of today are much better. So again, all efforts currently happening to be better in the localization of these hemorrhages have really they are legit, because they are really needed, because we are currently referring to a very old morphological grading system. One change which occurred recently, and Nina referred to that, was that the grade 4 hemorrhage has been changed into the periventricular hemorrhagic infarction nomenclature, which is important because it points out that in addition to the hemorrhage, there is an infarction and ischemic component going with it. This is a very nice overview paper indicating how these periventricular veins are contributing to infarction, to a periventricular infarction and the destruction of the parenchyma there. Now, this is an essay on the need of a new classification system, considering also a better topologic characterization than only the distribution towards the frontal, temporal, and parietal lobe. And MRI can be helpful in that. We have done that in neonates, not in fetuses, and we looked at grade 4 hemorrhages. And you see all these cases, they have grade 4 hemorrhages, but as you can imagine, their outcome will be different because the amount of destruction you're seeing is tremendous. I want to show you this graph because I think it's important to understand also outcomes in intraventricular hemorrhages. This is based on preterm neonates with intraventricular brain hemorrhages. Now, what you see here in this score, and we assess different anatomical regions and scored them. What you see is if there is a case with a similar MRI score, born at 23 gestational weeks and getting the hemorrhage at that early time point, the outcome, the difference in outcome is already 30% difference than if the same case has the same extent of hemorrhage but is born at term. So preterm birth is absolutely interfering with neurodevelopmental outcomes in IVH, and this is the reason why we cannot automatically translate what we know from preterms to fetuses. So we really need to do the same with fetuses, and by just looking at those images on the first glance, they might be quite similar in outcome, but they are not. They had a different outcome score, and therefore also a different prediction, despite they were born at the same time point. And that's what we see in fetuses. This is a case of a severe periventricular hemorrhagic infarction. You see this huge hemorrhage also compressing the veins on a microstructural level and leading then ultimately to this porencephalic cyst. That's what you can observe on MRI when you look at the extremities of the right and the left side, and you see the right sided extremities here. They are moved not as actively as on the left side, where you see toe movements and hand movements, and on the right hemisphere or the right extremities are in a more clinched position, already indicating that there is some interference with the motor system at this early time point. Now, here again, different examples for the grading, and we can, in all these cases, also perform tractography or try to perform tractography, and that was the work which we did with Efrat Hadi from Tel Aviv, where Efrat looked at the outcomes and correlated it with our tractography results, and we found that if you have normal tractography results, your chance is quite low that this baby is going to show any motor signs. Whereas if the motor tracts, the corticospinal tracts are involved, you have a 6-time higher risk of having motor complications in the motor system. So it's an interesting add-on. That's how it looks like in one case with follow-up, and you see this partial involvement of the corticospinal tract of the left side due to this periventricular hemorrhagic infarction. And this is the final point of my talk, just 2 minutes more. Hemorrhages interfere with normal development. And I have pointed that out in the cerebellum, where we saw that the glia cells and the neurons are somehow, let's say, changed or affected by the hemorrhage. And the nomenclature foresees that an event interfering with the normal developmental trajectory is called a disruption, meaning that whenever you see a hemorrhage in a fetus, there is some kind of interference with the normal course of development. And sometimes we do not see the remnants of this hemorrhage because it was very, very early, for instance, or this hemorrhage has been resolved by the different cells there in a very fast way. So that you only see the malformative or disruptive consequences of this hemorrhage. And this was the case at 34 gestational weeks with, you see, ileal atresia, which is often believed to be an ischemic event. And here you see multiple sites of schizencephalic clefts. Here, not necessarily associated with blood degradation products, but with an ischemic event. And this is the brain of the mother of this fetus. So this is not the brain of a 30 years old mother. This is clearly a very, very sick brain with a lot of white matter changes because mom had antiphospholipid antibody syndrome, which of course affected the placenta, and through the placenta led to ischemic and hemodynamic changes to the brain, which can of course cause ischemic changes, but also hemorrhagic changes, as you all know that coagulation activation is also happening in these immune cascades. This is just with this I just wanted to sensitize you that whenever we are talking about hemorrhage, we are at the same time talking about the etiology of it, and the etiology appears to me more and more to be highly relevant for prognosis, sometimes even more relevant than location. And I think fetal MR is one of the puzzle pieces which can improve your detection, tell something about the extent, and maybe indirectly help you to figure out the etiology. And for that reason, I believe that combining ultrasound and MRI in this setting has its position in prenatal medicine. Thanks for your attention.
Thank you very much, Gregor. As always, excellent lecture. And maybe that we are talking, discussing later. So I would like to proceed, move on. The next presenter, Dr. Roy Birnbaum, again from Tel Aviv, Israel, and he is, as you know, he is a super expert in the fetal brain, and always he makes difficult things easy, unclear things clear. So, Roy.
Roy, unmute yourself, Roy.
Unmute, Roy.
You're right, guys.
Oh, okay, now.
You're absolutely right. So let me, now you hear me and see me.
Yes, yes, yes.
So as I was saying before, thank you, Ritsuko, for a very kind introduction, and my previous speakers, Nina and Gregor, for a fantastic talks. And I would like to address an issue which is, I would say, old and new, and to shed different light on it. And we're going to discuss ganglionic eminence cysts, cavitations, and you've heard today the two words ganglionic eminences. I will try to shed some light and to organize things a bit. So let's jump straight into anatomy and embryology, because we cannot discuss this kind of information without understanding how the brain works. So what are the ganglionic eminences? First of all, we are talking about an early structure. Ganglionic eminences, as I will show you, the highest importance of even thinking about this structure is during early pregnancy. Now, how do we see them? Where are they anatomic-wise? If you take a brain at 12 or 13 or 14 weeks and you perform a coronal section through the hemispheres, you will come up with this image. This image is from the atlas from Muller and O'Reilly. And if you look at this coronal image, what you immediately see is that there is a big difference between the dorsal brain, which is a very thin layer of proliferative cells. These are the ventricular and subventricular zones that will go with radial migration, and they will give rise to the cortical plate of the hemispheres. However, if you look at the same structure, the proliferative zone, but on the ventral area of the brain, it is a completely different structure. And this thick area here is composed of two areas. And they are also stained from the histological point of view. In this specimen, they are stained differently. So we have these bulgings or eminences or small hills protruding into the floor of the lateral ventricles. You can see that they are stained differently. And these are the ganglionic eminences. Actually, there are three ganglionic eminences, the medial, the lateral, and the caudal ones. And you need to understand that these are the most important proliferative areas of the brain. Now, when we are talking about proliferative, also Gregor mentioned it, we are talking about the factory, the place where the progenitor neural cells, they proliferate, and then they're starting to differentiate into the different subfamilies of neurons and supportive glial cells. And from this factory, once they are ready and you have the pool of neurons, they will go on their journey, their migrational journey, and the ganglionic eminences will contribute a lot of different subfamilies of neurons. Some of these neurons will migrate in a tangential migration to incorporate into the cortical plate as the GABAergic inhibitory neurons. However, some of these neurons will also migrate ventrally towards lower areas, which are the developing basal ganglia. Now, if you look at this lower area of the specimen, and we also see this area on the ultrasound, as I mentioned before, it is composed of the developing basal ganglia, as you can see here, but also bear in mind that many axonal tracts and actually the anterior horn of the internal capsule also crosses here. So all of these neuronal structures gives rise to this thick layer, but this is not the ganglionic. The ganglionic eminences are the proliferative zones that bulges into the still very wide ventricles. Now, coming from Gregor's group, just recently, this paper has been published where they showed very nicely that the peak volume of the ganglionic eminences is reached at around mid-pregnancy, and this is followed by a decrease in the volume. And so you take together the function of this structure, which is the pool of neurons to give rise to the big pool of neurons to build the brain, and the fact that their volume is reduced after mid-pregnancy tells you that the importance of this structure, and hence the importance of pathology that may disturb these structures, is earlier in pregnancy. It's not in the second half of pregnancy, but you should be thinking of these structures and give them the most importance from the clinical point of view early in pregnancy, where they're in their full capacity. So already bear in your mind the timing of the pathologies is critical if you are talking about ganglionic eminences. Now, this is taken from the atlases by Bayer and Altman, and these are coronal sections at two different places, one more anterior and one is a little bit behind, throughout pregnancy. And look at the dark stained areas. The dark stained are the proliferative areas, and the ganglionic eminences are the ones that bulges here through the through the floor of the lateral ventricles. You can see here very nicely the internal capsule and the developing basal ganglia. And as you go on along pregnancy, you can see that the volume is reduced, as the Gregor and his group showed us. And then eventually you are left with leftovers of of germinal matrix, which does not contain any progenitor cells or just very few remnants of progenitor cells, because this factory has ended its role. We don't use the factor anymore because the neurons have migrated, and these are the areas which are vulnerable for all the bleedings and the insults that Nina and Gregor showed you. But I think that from the terminological point of view, we should avoid calling these areas the ganglionic eminences. This is the germinal matrix. It does not contain any cells. So if we want to think about it in a more intuitive way, earlier in pregnancy, these proliferative areas are high capacity. They are super important to give rise to the brain, as opposed to the remnants of this germinal matrix, which does not contain any cells anymore, just fragile and disorganized vessels, which are prone to bleed later on in pregnancy. So again, it's not only a matter of terminology, it's a matter of understanding that if you have an insult early in the factory, you will not have any products of the factory. But if you have an insult of the late germinal matrix, you will have the focal consequences as a result of the insult, but they will not give rise to the consequence. They're not supposed to give rise to the consequences, the same as the one when you destroy the factory when it is at its full capacity. So I hope this point is clear to you. Now we are going to focus our mind and talk on the early events of pregnancy where the factory is working. So how does the ganglionic eminence look on transvaginal ultrasound? And these are the three corresponding orthogonal planes, and also corresponding correlating between the ultrasound images and the histological specimen. And again, put your eyes on the dark stained area. These are the proliferative areas in the specimen. So if you take a look at the sagittal and the parasagittal images, you can see here very nicely the bulgings of the ganglionic eminences. We will stop the clip and you should be able to recognize this grayish area bulging to the lateral ventricle. On the axial plane view, again, you see this grayish area. I would like to stop here and use this point to make another important anatomical point. You must differentiate between these hyperechoic choroid plexuses, which are very closely located to these more grayish hypoechoic bulges, which are the ganglionic eminences, because it's a completely different structure with different objectives. And the way for you to differentiate between these two important structures from the imaging point of view is to look for this choroidal fissure, because you know that from the embryological point of view, the way that the choroid plexus develop are like invagination of the manings of the pia that goes through the choroidal fissure, and then these cells differentiate into choroidal cells with the arterial supply, but with the sandwich, the place that the two pias are connected together going into the ventricle, gives rise to this very thin and echogenic line here. So whenever you're looking this area, look at the echogenic, then the echogenic line, and then the hypoechoic bulges, and these are the ganglionic eminences. And of course, if you look on the coronal images, it's quite intuitive. Through the anterior fontanelle at 15 weeks, you see them very, very nicely. Again, my advice to you is to reduce the contrast of the image, so you will have a wider spectrum of gray shades, and you scroll the image anteriorly and you can see these areas here very nicely. And there are also the echogenic lines here are vessels that run on both sides of them. So now you understand the properties of the ganglionic eminences from the developmental point of view. You know how to look for them in normal brains early in pregnancy, which is the time of interest for us. So we can continue to the next phase of our talk, next chapter, which are the pathologies of the ganglionic eminences. And actually, what do we know so far until this month, I would say? What do we know from the literature regarding fetal pathologies of the ganglionic eminences? So actually, we know everything we know comes from these 4 papers. And due to our limited time, I'm not going to dive into each of these papers, but I think we all share a big thank you to Professor Andrea Regini from Italy, from Milan. I think he's also here with us, and I will be happy to hear his inputs, because he was the one who raised the first flag and taught us regarding this entity of cavities of the ganglionic eminence. His first paper was in 2013, and you can see, although Professor Regini is working in a very big tertiary center, he had only 5 cases, which tells you that this is, first of all, a rare pathology, and I personally believe this is an underdiagnosed pathology, and I think it's more common than what we think, but it is missed on the ultrasound in various occasions. So he had 5 cases, and then the biggest series was 2021. It was a multi-center European study which collected together 60 cases, and I'm not going to go over all of these papers due to our limited time. But you do need to remember that all of this data is, first of all, is MRI based, because these are all MRI studies, and mostly these cases come from late 2nd and 3rd trimester of pregnancy. And as I mentioned before, you should think of the ganglionic eminences. Your objective is to visualize them earlier because of their properties. And another important point, which I'm going to touch in the remainder of later in my talk, is that in this paper with the 60 cases, the authors divided the pathology into 2 separate entities. One of them was cavitations, and the other one was enlargement. And I'm going to shed some new light on this separation. What does the ultrasound tell us about ganglionic eminence cavitations until now? Well, actually, almost nothing, not much. The first publication came from Italy, again from Profumo and his colleagues, when they described one family with 2 consecutive fetuses. It was a letter to the editor on the White Journal. The first case was diagnosed only at 22 weeks by ultrasound, but then they performed MRI, which further elaborated the full magnitude of the pathology. And then rightfully, the authors suspected that this might be a recurrent case, so they invited the patient to come back at 16 weeks, and not surprisingly, they were able to diagnose again the pathology at 16 weeks, and again they asked for an MRI, which gave them the full spectrum of the pathology. And the other ultrasound publication of ganglionic eminence pathologies comes from our group. This is another letter to the editor by my good friends, in which we had a series of cases of fetuses that would refer to us because of CPCs, apparently benign CPCs, which you all see every day in your clinics, but we found out that these are not CPCs, these are cavitations of the ganglionic eminence. We went back to Rigini's papers, and we saw that these are the same cases as Rigini described, so we published this paper, and I'm going to touch this point again. So the question is, can we diagnose ganglionic eminence pathologies, first of all, earlier in pregnancy, and can we do it by ultrasound, because all of the data is MR-based data? And to answer this question, I'm happy to share with you our new publication, which is just been accepted to publication in the White Journal. And as far as I know, it is going to be available on PubMed just in the 1 week or 2 from now. So you are all welcome to look for it. And this study is going through imaging, outcome, and the genetic associations, and we're going to talk a lot about mitochondrial dysfunction. And as far as we know, this is the first publication on the early diagnosis of these fetal pathologies. Now, it is so important for me to mention that this was a multi-center retrospective study, international one, from these 8 countries, 9 centers from 8 countries, 2 centers in India. And this is the list of our good friends and colleagues, which I cannot thank enough for sending all of the information and the data. So thank you again for your collaboration. Now, let's go straight to what we found. First of all, this study included 25 fetuses, which means that this is a rare pathology or an underdiagnosed pathology, but probably it's rare. And the mean gestational age was 15 weeks. You can see the spectrum. The cysts were bilateral in almost 2/3 of cases. The diagnosis was established at or before 13 plus 6 weeks in more than 1/3 of the cases, just because people were aware enough. In 7 fetuses, which is almost 30% of the cases, again, the diagnosis was made by us following a referral for a false suspicion of a choroid plexus cyst. People thought it's a choroid plexus cyst, and then the neurosonography elaborated for the full magnitude of the problem. And importantly, and this is in correlation with the data published by Rigini, additional brain findings, additional brain malformation in all of our cases with ganglionic eminence cavitations were present in more than 80% of the cases, which tells you, only this number tells you that you should be very afraid not to miss this finding, because in most cases, this is a sign of a very severe brain abnormality. Furthermore, in more than 2/3 of the cases, extracranial malformation of other systems besides the brain are affected, at least in one organ system, in addition to the brain anomaly. So again, it gives you the notion of how severe this malformation is. Now, what we did when we looked at all of the additional brain malformation which were associated with the ganglionic eminence cavitations, we divided them into 4 groups, and we divided them according to the groups, according to the ultrasound images, according to the structures that you are usually used to look for in the ultrasound in your mindset. So we had hemispheric abnormalities, which were the most important one was the periventricular hyperechogenicity, I'm going to show you, and thin parenchyma. Midline anomalies, which included, in most of the cases, corpus callosum is highly associated, and also the bulging of the suprapineal recess. This is what Dario mentioned in his talk. Midbrain, hindbrain abnormalities, and you see the percentage are very high. Midbrain, hindbrain anomalies, which so the cerebellum is affected in 50% of the cases, and also the vermis also almost 50%. The lateral ventricles were involved in half of cases with ventriculomegaly or irregularities of the ventricular wall in high rate of our percentage, and also sulcations anomalies. Some of them were already apparent early, and some of them were appeared later on in cases that were not terminated and they were followed up. So you can see microcephaly and the early sign that we all learned from Ritsuko of underdeveloped Sylvian fissures, and as a general sign from cortical anomalies, early cortical anomalies, microcephaly, PMG, etc., etc. So these are all the additional brain anomalies, and you can see the numbers are very high. Now, as I mentioned before, in addition to the brain anomalies, we had a lot of extracranial anomalies. Again, you divide them into 3 groups. So more than 35% of cases had growth restriction. So remember, IUGR, fetal growth restriction, should have a dedicated brain scan to look for these significant anomalies. And skeletal anomalies, usually the pattern is IUGR with short, long bones and ganglionic eminence cavitations. And around 29% orofacial cardiovascular anomalies and a single umbilical artery. And in addition, we had various kinds of edema, hydrops, or cystic hygroma, urogenital anomalies, and we had a case with omphalocele. Now, what about the genetics? And this is where things become even more interesting, I think. So genetic studies were performed in almost 74% of cases. So these are cases that you must send for genetics. And because the diagnostic yield of a genetic study is super high, 70%, this is much higher than most of the papers publishing general genetic yield for fetal malformation. So this is a specific malformation with a super high genetic detection yield. However, if you look at all of them underwent chromosomal array, and the detection yield of chromosomal arrays was around 10 to 11%, which is quite similar to previously published numbers regarding brain anomalies. However, when you perform exome sequencing, the diagnostic yield went up to 75% of your fetuses will have an abnormal exome sequencing, and we'll show you all of the examples. So it's a very high diagnostic yield in these kind of pathologies. Now, further on, we took all the genes that were found to be involved, and we tried to classify them into various molecular groups according to the cellular pathway which is involved. So we had one rasopathy, one channelopathy. SCN3A is a protein involved in the function of the sodium channel, so it is a channelopathy. We had 2 different tubulinopathies, both 2B, which we know today is considered a more milder gene, if I may say so, and the tube A1A, which is the more severe tubulinopathy. So we had both of them. But in addition to that, we have 5 different genes that are mitochondrial dysfunction causing genes. And all of these genes were nuclear genes. So these are nuclear genes. The protein is manufactured in the nucleus, and then it moves into the mitochondria, and it is involved in the respiratory chain of the mitochondria. Further, remember that we had one case of a pyruvate dehydrogenase alpha-1 deficiency that was not detected on the exome. The exome came normal, but our good friends from Australia were pushing for a genetic diagnosis. They performed whole genome sequencing, and they found that the variant was in one of the introns, and it was a pathogenic variant in the PDH-A1, which is, you know, is one of the most common prenatally diagnosed metabolic or mitochondrial conditions. So let's go into images, because eventually this is an ultrasound paper. So all of these images were taken between 15 to 19 gestational weeks, and this shows you a variety of brain anomalies. So you can see here, as I mentioned before, the hyperechogenicity and the lamination abnormalities. This is a very hyperechogenic lamination as opposed to the regular ones. And if I will show you just this image, you may think of even of a CMV, but this is not a CMV. You can see that at 15 weeks, we had a complete agenesis of the corpus callosum. If you go back to my talk earlier in this morning regarding the midline, so you see here that there is no patterning of the midline, there is no corpus callosum, together with the ventriculomegaly, which results in the bulging of the suprapineal recess that we saw nicely by Dario and by Leo. You can see here that in addition to the fact that this fluid is not the lateral ventricle, this is the cavity of the ganglionic eminence being pushed into the ventricle. You can see again the lamination is very abnormal, and how flat the Sylvian fissure here. You can see here that the Sylvian fissures are completely flat, together with, again, the hyperechogenicity, very thin brain parenchyma with the ganglionic eminence pushed up at 15 weeks. And you can see here again, thin parenchyma, a lot of extra axial space, a very wide interhemispheric fissure as a result of not of a lot of fluid, but very thin parenchyma, very diminished brain, and very abnormal lamination patterns you can see here. And this is the case with a Vermian, hypoplastic Vermias, and a very big cyst, which is probably due to Dandy Walker malformation. Now, let me show you some example of cases. This is a nice case from Poland, and the patient was referred at 13 weeks, again, just for a CPC. And I really hope that the next time you are going to look at such an image, you can see clearly this is the border of the choreoplexus. The choreoplexus are absolutely not involved in the pathology. The pathology is here. This is clearly, now I hope you all recognize that this is a ganglionic eminence cavitation and not a CPC. And they rightfully called the patient again earlier. They did not wait until 22 weeks. And look what they saw at 18 weeks of gestation, just 5 weeks later. And you can see here in this very demonstrative clip that practically there is no brain. The brain is completely white and atrophic, very thin lamina, a lot of fluid inside the skull. This is a completely maldeveloped, or I may even say a destroyed brain. You can see here also on the coronal images, these white echogenic patches with you cannot even distinguish a hemisphere here. With, of course, there's no corpus callosum. You can see here also that the tectum, the brainstem, and the vermis are completely abnormal. And you can see here again this suprapineal recess. And if you look at the midline here, as I mentioned in my first talk, you can see that nothing happened here. This is arrested like in 10 weeks, no commiseration, no massa commissuralis, etc. They performed a termination of pregnancy, that they performed exome sequencing, and they found the pathogenic variant in ERS2 genes, which is, again, a mitochondrial gene. This is another brilliant case from India. At 12 weeks, the person who performed the examination realized that there are bilateral ganglionic eminence cysts. You can see very nicely she's moving from one side to another, and then the coronal images, and you can see very nicely that these are not CPCs, but very big ganglionic eminence cysts. So again, they called the patient again at 15 or 16 weeks, and let me show you what they found. First of all, you can clearly see in this video clip again that the midline is not forming. It is arrested at something like 13 gestational weeks. There is no corpus callosum, no midline patterning. You can see that the ventriculomegaly with shrinked and dangling choroid plexus, wide ventricles, and very abnormal echogenicity surrounding the ventricles. But interestingly, if you go to the parasagittal image, at 12 weeks, these cysts were very large and cystic structure. What happened at 16 weeks is that the ganglionic eminences are bulky, they are echogenic, but you don't see a cyst. And this is for the first time taught us that probably some of those cases that were referred by Rigini as ganglionic eminence enlargements, some of them are probably early cysts that undergone regression or absorption, or they just collapsed inside and they became enlargements. So probably dividing these to two different entities probably does not work for all cases, and probably some of these cases are a continuum where the early pathology of the ganglionic eminence, where it was in full capacity, was cystic, and then it regressed or collapsed, and it gave rise to an enlargement of the ganglionic eminences. Another interesting finding here is you look at in addition to all the pathologies at 22 weeks, they continued the pregnancy to a certain point. You can see here this very unique Vermian cyst, but this is not Dandy Walker, this is not Blake's pouch. This cyst involves the vermis itself. You can see the lower border of the vermis. And actually, this takes you back also to Gregor's talk. This is the area of the germinal matrix of the cerebellum, the rhombic lip and the germinative areas of the cerebellum, which again, you need to remember that as the same as the ganglionic eminence are are proliferative areas, you also have the proliferative areas of the cerebellum. And you can see here the cyst involves the vermis in a very, very unique particular way. They wanted to perform genetic analysis, but in this case, at the time you write the paper, the genetic was not performed. However, after the study was accepted for publication, I received an email from these 4 fantastic ladies, doctors, Dr. Nandita, Dr. Shivani, Dr. Ratna, and Dr. Jamita. Sorry, these are the geneticists and the sonographers who performed the examination. And they told me that after a similar finding was found in a subsequent pregnancy, then they performed a genetic analysis to the entire family and both of these pregnancies. And they found a pathogenic variant, a gene called DLAT. And surprisingly enough, what is DLAT? DLAT, again, is another subunit of the pyruvate dehydrogenase complex. So we have another mitochondrial disease, which puts us in number 6, the 6th different mitochondrial gene in one small series of cases. So remember, I think this is the first publication that we have such a lot of mitochondrial disease diagnosed early in fetuses in the literature. Let me show you another interesting case, and to make up another point, this is a case that was referred to us because someone performed an examination. He decided, and this goes back to what Elisenda told us, he decided to perform a mid-sagittal section in order to add the corpus callosum, and he just found that the corpus callosum is short, and lucky enough, he referred her because of a short corpus callosum. But then, if you perform a complete neurosonographic examination, you see that, yes, it's true, the corpus callosum is completely dysgenetic and small for 22 weeks, but the problem is by far more extensive than just a short corpus callosum. And you can see here the ganglionic eminence cavitation bulging, but what is striking in this case is the lamination anomalies. And you can see here this very unique lamina, 3 lines, echogenic lines here. This is a very abnormal lamination, and 22 weeks is really the peak time of migration. So this is highly suggestive for migrational anomaly as a result of the ganglionic eminence cavitation. The patient went for a termination of pregnancy. Again, another mitochondrial gene. This is the pyruvate dehydrogenase deficiency, which you are all aware of this condition. And then we performed the post-mortem examination, which was performed by Professor Kidron. And surely enough, she were able to pick up, in addition to the disintegrating germinal matrix that we all know, she found white matter heterotopia, and she found areas of cortical thickening and disorganized cortex, which corresponds to what we suspected of the migration anomalies, probably represented by these abnormal echogenicity reflections from the hemispheres. This is another interesting case. At 16 gestational weeks, the patient was referred because of a huge interhemispheric cyst. You see this cyst here, but if you look closely, you see also there are cavitations of the ganglionic eminences. So of course, this is a very abnormal brain, but what was interesting in this case is what we found on the face, on the lips. And you see here also on the profile and in the inferior leg, you see these 2 small protrusions. At the beginning, you may think that you see both incised or teeth, but actually if you have a 3D multiplanar imaging, you see that this small tissue is not evolving from the teeth, it evolves from the soft tissue of the lip. And one of our thoughts was this is a double lip anomaly, which is a rare anomaly of the lips. However, unfortunately, the patient refused for any post-mortem examination, so we were not able to see a tissue. But anyway, this is quite a unique finding, and this is not an artifact. We looked at it at various angles, and this is a true finding protruding from the soft tissue of the lip. We performed a genetic analysis, and sure enough, it came back to be a top B mutation. So now we have a 2B, which is a quite today well-known gene, and we know and we learned from Gustavo and from Professor Garel the phenotype of the tubulinopathies. But this fetus presented 2 signs which are completely not part of the classic tubulinopathy pattern, the ganglionic eminence cavitation, and this double lip anomaly. However, Professor Higini, in one of his papers, did found the tubulinopathy also in one of their cases. This is a case 19 weeks. you see the protrusion of the ganglionic eminence. We performed the mid-sagittal section. You can see again there's no corpus callosum. I told you at the beginning of my previous talk, this is the small pericallosal artery. There is no corpus callosum. Don't look at these arteries, they are misleading. The true pericallosal artery is only this small one, and below it you may see remnants of a 12 or 13 weeks corpus callosum, but not more than that. And this family actually was published before because this is the third the third fetus of a family with recurrent cases. The two first ones were published by us together with Dr. Barbing, and we found again an NDUFAF5 mutation, which is another mitochondrial disease. But then the patient got pregnant again, and I told her, I want to see you early in pregnancy, so I invited her at 11 weeks. And sure enough, you can see that the ganglionic eminence cysts are already present there at 11 weeks. These are not CPCs, these are ganglionic eminence cysts. This fetus was also terminated, and we confirmed the homozygous for this mutation. And coming up to the end of my talk, we had, interestingly, 4 fetuses in our series that presented with a unilateral cyst, and they had no additional brain abnormalities or any subsequent examination. So it was apparently isolated ganglionic eminence cyst, which is quite an interesting and rare scenario. What happened with these 4? So 3 of them, all of them evolved. They collapsed into this ganglionic eminence enlargement later on in pregnancy. So bear in mind that enlargements might represent an early regression of a cyst. However, if you look at these 3 fetuses, their clinical outcome was quite severe. One of them developed a severe early IUGR and a very short long bones. The other one had additional extra CNS anomalies that not all of them were diagnosed in utero, macrognathia and single umbilical artery, and postnatal also they found a cleft palate, hypospadias, and a VSD, so it was absolutely not an isolated malformation. And one of them, which was a case from India, had, you can see here very nicely how at 15 weeks there was a clear cyst that regressed and became an enlargement and bulging of the ganglionic eminence. This is the same fetus, but this fetus had a normal developing brain. However, he did develop a severe IUGR and also a subaortic VSD. And the last case, and this is the case from Ritsuko from Japan. This case, as you can see, had a unilateral, very small cyst, which we can argue whether to call it a ganglionic eminence, but at 18 weeks, I do think it's a ganglionic eminence because at 18 weeks, this area is still proliferating. It's not 32 weeks germinal matrices, but this was the only finding intra or extra cranial, and this child was developing completely normal. So to conclude my talk, cysts of the fetal ganglionic eminence can be detected as early as the late first or early second trimesters. In most cases, ganglionic eminence cysts coexist with complex brain malformations, as I showed you, and in a high rate of extra CNS anomalies. GE cavitations and enlargement may represent a continuum, with GE enlargement sometimes reflecting a later stage of a cavitation regression. Please remember that these are not choreplexus cysts, and do all your efforts to distinguish between these two entities. Various genetic etiologies may result in ganglionic eminence cysts, but often those involved in the mitochondrial function. So consider a whole genome sequencing in those selected cases when you don't find anything, because this is highly suggestive. And in the large proportion of cases, the prognosis is poor, but as I showed you, not in all of them. Probably there's a small fraction of fetuses which carry better prognosis, but you should be very careful to rule out all the additional brain anomalies. And I thank again all of our collaborators and dear friends and colleagues from these countries. You are fantastically collaborative, and thank you again for your listening.
Thank you very much, Roy. The fantastic work, and congratulations on your new publication. And I'm very happy. Yeah, I'm very happy to be a part of your fantastic work.
Thank you for your contribution, Ritsuko.
Thank you very much. So I would like to move on. The next presentation by Professor Elisenda Ishak. She's from BC Natal, Barcelona, Spain, and she has extensive experience in fetal brain diagnosis, and her compassionate counseling for the patients is truly admirable. So, Elisenda, your talk is about the intrauterine infections affecting the brain. Elisenda.
Yeah. Thank you very much for the nice introduction, Ritsuto. And yes, I'm going to talk about intrauterine infections. And the first thing is, as I'm pretty sure that all of you know, which are the infections that are affecting the pregnancy, toxoplasmosis, also this torch group of infections. And I'm going to focus on these three ones: toxoplasmosis, parvovirus, and cytomegalovirus. And I think that it's important to bear in mind that these infections are a multi-organic, have a multi-organic effect, because they are not just affecting the brain, are affecting the whole baby. You can have effects on the brain, of course, but also in the heart, in the liver, or even in the growth. But just to bear this in mind, that we are not going to have only effect on the brain, but of course, in this presentation, we are going to focus on the effects on the brain of these babies. And I'm going to start with the parvovirus B19. And just a brief introduction. We know that the transmission of this virus is respiratory. It's so-called the fifth disease, and I'm pretty sure that all of you know these are the characteristics of this infection in children when they are affected, and when a pregnant woman is in contact with children with this clinic and has no previous immunization for that, we know that the vertical transmission is around 17 to 30%, more or less. And the most important thing is that the high risk is in the first half of the pregnancy, so between 9 to 20 weeks of gestation. Why? Is because parvovirus is associated to spontaneous abortion, especially before 20 weeks, around 15%, and also to non-immune hydrops due to anemia, especially in those infections that are occurring in the first trimester. I would like also to point out that in the last year, I think that almost all the world suffered this pandemic situation of parvovirus. And you can see here one of the publications regarding this issue. So this is from Germany, and they nicely show how in the 2024, the number of pregnant women with parvovirus like multiplied by 20 the number of normal infections, and of course also increase the number of chordosynthesis due to this reason, and also the intrauterine fetal demise. So hopefully this year is going to be better, because we know that parvovirus is going up and down, but it was really a huge problem in the last year, 2 years ago in around the world. Regarding the brain, parvovirus in theory, it's not teratogenic in humans, and I know from Karina's presentation that it's teratogenic in kittens, but not in humans. But we know that anemia and hydrops can have an effect on the brain, and I will show you a nice case on that. So here you will see an image. This is a fetus that has a fetal anemia 20 weeks. For parvovirus, we did a chordosynthesis at 22 weeks, and the diagnosis before doing the transfusion, the fetus was severely anemic with an hemoglobin of 1.1 and hematocrit rate of 3%. So we transformed the baby, and we followed this fetus around pregnancy. And at 32 weeks of pregnancy, we performed a neurosonography because it was severely anemic and hydropic. So it's a risk factor for having lesions. And as you will see here in the transvaginal, we will see here a porencephalic lesion in the insula. So I will go again back. You can see pretty well this lesion in a position that it's not it's not maybe usual. So we have to look in depth in the brain of these babies, and we confirm this lesion in the resonance. So it was a unilateral porencephalic and very localized lesion. This baby was born and has a completely normal development, but the lesion was there. And when you look at the literature about how often this happens, there are a few series, and this is one of the series that it is. So there is these babies that were transfused by parvovirus, around 27, and as you can see, most of them do not have any brain anomaly, but 7 do have. And interestingly, 6 of 7, so almost all, have a cerebral involvement. There were no severe malformations. There were a reduction in the size or a asymmetry between hemispheres, but it's interesting. And also, if we compare parvovirus with alloimmunization, that is like the pure control for this population because they are also anemic, we can see that there are different populations since parvovirus has the gestational age and where the transfusion occurs is earlier, have more eye drops and more severe anemic, and also prenatal brain anomaly is higher in parvovirus anemic fetuses with 27 compared with 4% in the alloimmunization. And again, most of the fetuses have a reduction in the transcerebral diameter. So I think that this data bring us to at least pay attention in both hypoischemic injury, but also in the cerebellum of the babies affected with parvovirus B19. If we move to toxoplasmosis, I would say that for us, at least in Spain, toxoplasmosis is really not a problem. I think I'm in most of 25 years of my career, I only have seen once that was a non-affected and was diagnosed by seroconversion in the third trimester. So for us, it's not a problem, but it's true that there is a problem in other countries. And toxoplasmosis has a vertical transmission only during acute infection, and the risk depends on the gestational age. So the earlier it occurs, the earlier that occurs, the later that occurs, the seroconversion is higher. However, the risk of severe lesions is higher when the infection occurs in the first trimester. So it's the other way around. So it's difficult to do a vertical transmission in the first trimester, but if you have a vertical transmission, the affectance is very high. And you can see here more or less the same idea. So if the infection is below 14 weeks, the vertical transmission is low, but the fetal affectation is very, very high with severe brain and ocular anomalies, and the other way around. And it's important that, differently from cytomegalovirus that we are going to talk later, there is no risk of vertical transmission in the periconceptional infection. So if the mother is infected before the pregnancy occurs. When we evaluate the infected newborns, most of them are asymptomatic at birth, and only 20 to 30% will have a long-term visual injury related with a chorioretinitis that is very difficult to diagnose. And on the contrary, 15 are symptomatic at birth, mainly from these infections that were occurring at the first trimester, and ocular injury also can occur before the third trimester infection, so mainly in the third ones. And this Savin's tetrad, that is the classical one, hydrocephalus, intracranial calcifications, chorioretinitis, and seizures, is very rare, probably because it's rare. The infection is difficult that occurs in the first trimester transmission, and because are these cases that has these severe anomalies. The ultrasound help us in the prognosis of these patients because is correlating a lot with the prognosis. So neurosonography can detect most of the severe anomalies except the retinal one is very difficult to identify, and what is important is that most of the cases that have retinal problems also have severe malformations in the brain. So normally we diagnose those because of that. And which are the findings that we are going to use? So I think that I mentioned before, but just to be in mind, we mostly will have ventriculomegaly and hydrocephaly. So the greater the ventriculomegaly, the worse the prognosis. Typically, we will find intraparenchymal refringent nodules, so like cerebral calcifications, and these are associated with increased risk of chorioretinitis, and then some other findings that can be found not only in the brain but also in extracranial. And I show you the images that were published in the paper that published the group of Professor Maringer published some years ago, a series with 8 cases of toxoplasmosis, and these are the typical images of toxoplasmosis with this mild ventriculomegaly. But these are the typical intraparenchymal hyperreferential nodules that appears in most of cases. Okay, so this is a typical image that also can be seen by MRI, that is even more evident, with these annular lesions in the white matter that are the typical one from the toxoplasmosis, and also a very evident white matter hyperintensity that can be seen in the toxoplasmosis. So I think that the diagnosis of toxoplasmosis should be done if we evaluate and do a neurosonography and we found these calcifications in the parenchyma, so we have to suspect and we have to do the amniocentesis to diagnose. And also we can suspect if the mother has in the case that in your country or in your city are doing serologies through the pregnancy, if there is a seroconversion along the pregnancy, and then look for the findings. So you can have both ways to diagnose this toxoplasmosis. So, but just bear in mind this typical image because it's the one that is going to lead you to the diagnosis if a toxoplasmosis is. And I leave the cytomegalovirus by the end because I think that the ones that took longer to explain, and I think that it's more interesting. CMV, typically the primary infection occurs in 1 to 2% more or less of the pregnancies in Europe and the United States. And it's important to bear in mind also that risk factors for this primary infection is that the mother is young and that has at least one child. And this is important because in these women especially, you have to do and you have to explain to her which are the things that have to do. So she has not to kiss in the mouth to the baby. So to do the primary prevention, because it's very important to primary prevent this cytomegalovirus. How we diagnose cytomegalovirus with the primary infection. So when we identify a seroconversion during pregnancy, when you have a previous serology that is negative and it converts in positive, and positive, it means that positive IgG and IgM both are positive, and then you can diagnose this primary infection. However, unfortunately, most of our population would be IgG positive. It means that they are immune to cytomegalovirus because, I mean, around in Europe is around 60% and in other countries it's reaching almost 90%. And diagnosis of reinfection is very, very difficult because IgM is rarely positive. So normally it goes with IgJ positive and IgA negative. And the presence of the virus in urine, blood, whatever, is very, very difficult to find because it has a short life. So the problem is that reinfection that is also associated with symptoms is very difficult to diagnose. What happens when you have a primary infection? So when a primary infection occurs, around 30% of patients will be symptomatic, will have symptoms, whereas around 87 will not have any symptom, will be maybe not severe sequelae and will have hearing loss. And this is during prenatal life. Those who are are symptomatic, they are more or less at risk of having one sequelae. And in total, if we consider the whole cytomegalovirus infections, around 17 to 19% will have some long-term sequelae. We will say around 20%. But interestingly, and this is something that was described some years ago, most of the cases, or half of the cases, will be following a first trimester infection. And this was one of the first steps when we, all the scientific community, but especially the group of Paris, focused the interest in the first trimester of cytomegalovirus. If we look at the data, pooled data in a table that sometimes is easier, we can see that those with severe lesions, risk of severe lesions, if there is vertical transmission, are those occurring perigestational or in the first trimester. So if you have a vertical transmission, the rate of severe lesions is around 30%. If it's perigestational, so even before pregnancy or in the first trimester, around 20%. Whereas if we look at the infections in the second, third trimester, the vertical transmission is higher, it's true, but the risk of severe lesions are very, very low, less than 1%. So we have to focus our interest in this period of the gestation, in the perigestational and first trimester, because these are the focus. And indeed, cytomegalovirus is an embryopathy. So the problem is when the brain is developing that is infected with the cytomegalovirus is what is going to bring the problems. And why is this important? Because after diagnosing that in Paris, they also in the Necker group they try the treatment with valacyclovir, and they found that when they treat cytomegalovirus infections, primary infection with valacyclovir, there was a reduction in the vertical transmission, is around 63%, but especially in those with first trimester. And the reduction in vertical transmission was very, very high, so it was a very important. And it's not just that the vertical transmission reduces, that it's important, but also reduces the infection in the neonates. So once you give valacyclovir to the patient, and reduce the vertical transmission, reduces the infection in the neonate, but also importantly reduces the severe abnormalities in the brain that are the thing that affects more the prognosis of these babies. So it's a very important issue. However, we have a problem. So despite this nice data on the valacyclovir and the effect on reducing the vertical transmission and reducing the effects on the brain, first trimester screening in cytomegalovirus is not universal. I mean, there are a lot of countries and a lot of regions that do not have this first trimester screening. Then prevention with prevention of vertical transmission, it's neither universal. So in some countries they do this first trimester screening, but they don't do this vertical transmission prevention. And what is more important, reinfection and reactivation, that in terms of number, I mean, because it's more frequent that your pregnant woman is immune, is almost impossible to diagnose. So we have these three factors that lead us to also again rely on neuroimaging, both for diagnosis, sometimes for suspect this cytomegalovirus, but also to predict the poor outcome in these babies. And we have two scenarios to believe, but it's just when we don't have first trimester screening, so it means we don't have the idea of what is happening with this baby related with the cytomegalovirus, and we base our screening in conventional ultrasound, is not very effective. We will only detect 30% of neonates with sequelae, but in the scenario with first trimester screening and no treatment, because I mean, if you do the treatment, you will reduce the appearance of brain malformations. Detection by neurosonography is reaching like 85%, and if you combine both neurosonography and MRI, detection rate will reach up to 95% of severe lesions. So it's a very important issue. How we counsel these patients once they have anomaly in the brain. So also the group of Paris, of Dr. Bill, proposed this classification of severe and mild brain anomalies in order to propose and to do the prognosis of these patients. And we can see that there is a severe ventriculomegaly or a cerebral hypoplasia. These are two of the signs that we can see in cytomegalovirus that are associated with poor prognosis. Also microcephaly, if the perimeter is smaller, or microencephaly. So sometimes you have a normal head circumference, but you have an increase in the subarachnoid space that is showing you that this is microencephaly. And also change abnormal cortical development, as we can see here, changes in the abnormal cortical development diagnosed as soon as in the 20-24 weeks. Also corpus callosum pathology, maybe this hypoplasia or thin corpus callosum, and that is showing us that there is a decrease in the white matter, or maybe a dysgenesis or short corpus callosum. And also there is this periventricular area, periventricular echogenicity that we can see sometimes in the axial plane, but is nicely seen in the transvaginal that we can see here in the sagittal plane. This really sometimes, I mean, we know that lamination can be seen at 20 weeks, but this is not lamination. This is a periventricular area, periventricular halo that is very, very evident, that we can see in the sagittal and both also in the coronal, that is following a whole ventricular system. And we look at that some years ago about what is happening here. And in most of cases, we have ventriculitis and microglial nodules, but we do not find anything else than that, what you see here. So it's a sign that when you identify in the early pregnancy, is telling you that something is happening here, because this ventriculitis is affecting as we say, the parenchyma. And all these things, of course, can be seen also by MRI and nicely see. So in cytomegalovirus, the combination of ultrasound and MRI is essential to give a nice prognosis. What about the mild abnormalities that we can see in the cytomegalovirus? The first is the mild ventriculomegaly. So again, when we are identifying a mild ventriculomegaly at 20, 28, 36 weeks, whenever it is, you have to do an amniocentesis, as we have seen for genetic study, of course, but please include PCR of cytomegalovirus because it can be one of the mild signs for diagnosing. Also, intraventricular adhesions. This is a typical image that we can see in the cytomegalovirus infection. Also, sometimes isolated calcifications in the parenchyma and subependymal cyst that are here we can see in the coronal, but nicely see here in the sagittal one. And finally, this lenticulostriate vessels calcification that it's not only seen in cytomegalovirus. Indeed, some normal cases can show that, but it's true that cytomegalovirus cases have an increased rate of this image. These mild signs can also be seen by MRI, and MRI, the typical signs are this ventricular white matter signal abnormality, as you can see here in the axial plane or in the coronal, and also we can identify the subependymal cyst and the adhesions in the posterior. So minor lesions can progress, so sometimes repeat MRI is essential, but most of them, when they have a good long-term outcome, as we see. And finally, also in MRI, there are some reports talking about these changes in ADC and ADC values and apparent diffusion coefficient, that the higher the ADC, the more the severe the disease, so can also be a marker to be used. So it seems clear that these severe ultrasound brain anomalies are associated with high risk of severity disability. So they are strong predictors for symptomatic newborn. So they are very useful for that. Mild abnormalities are poor predictors for symptomatic. So the positive predictive value is around 60%. So sometimes, but the really value is that they has a negative predictive value of 90%. So if you find mild abnormalities, you can tell to the patient that there is a low risk of severe disability. However, there is this increased risk of hearing loss. The question here is, we can add some more information to this cytomegalovirus infection apart from the severe or the mild abnormalies. So we did a study on cytomegalovirus, including CMV with any sign of infection, neither in the brain or in extracranially, and some with mild affected cytomegalovirus, and we compare with control. We perform MRI, and we compare the sulci depth and also the Sylvian fissure angle, and also the grading of these areas and sulci, just to see if there was something in this brain of this cytomegalovirus that maybe can help us in the further prognosis of development after birth. And the first that we found, and it's very easy to understand, that mildly affected cytomegalovirus have higher, bigger ventricles. So even though sometimes they do not reach ventriculomegaly, they have higher, bigger ventricles compared with controls and compared with non-affected. And when we look at the development of cortical development of the depth of the sulci, we saw that mildly affected and non-affected have less profound parieto-occipital sulci and calcarine sulci. So it was like a one step before they were less, and also the angle of the Sylvian fissure was wider, so there was less development of the percularization in these babies. That I remember that I just remind you that there were non-affected or mildly affected. And also when we look at the degree of development, not this cortical grading that Pistorius proposed some years ago, we also found that mild affected, they have a delay on the pattern of maturation. As you can see here, the darker it is, the more mature, and we saw that in the parieto-occipital sulcus, in the calcarine sulcus, in the parietal area and the temporal area. Just a few images to show. So it's not a huge damage, and I think that this is very important to explain that. So, but here you can see the control. In the upper is the cytomegalovirus, and down in the low line they are the control. And you can see here that it's not a lot, but the Sylvian fissure is less developed. If we look at the coronal plane, the calcarine is less developed, is in one step backward. The same with the the salt in the surface of the brain. So it is not a severe affectation. So it's something that is very subtle, but maybe can explain why some cases of mild or non-affected can have a problem afterwards. So for example, the hearing loss, and maybe we will explore if these findings can be associated with the neurodevelopment. We are working on that. So to conclude, I might say that parvovirus has its main effect in those babies that are severely anemic or hydropic. So once you have a baby with parvovirus infection, anemic or hydropic that requires photosynthesis, please follow the brain, because you will find some changes in the brain that probably they are not associated with poor prognosis, but it's important to identify them. And please focus also on the cerebellum. Toxoplasmosis has a more, especially those with severe effects, we will have to focus on this ventriculomegaly and intraparenchymal hyperpharyngeal nodules is what we are going to find. And related with cytomegalovirus, very important is an embryopathy, severe lesions only in those infections that occurs in the periconceptional or in the first trimester. This is why it's so important to do this first trimester screening. And if we identify this primary infection, do the prevention with valacyclovir, but remember that we have the reinfections and then neuroimaging still have its role as diagnosis, but also as predictor. Severe anomalies, high risk. Normal is very reassuring, and these mild anomalies that leave us in this position that having low risk of severe disability, but with high risk of hearing loss. Thank you very much for your attention.
Thank you very much. Thank you very much, Elisenda. As always, comprehensive lecture. And because of 6 hours, the long sessions without any break from 8 o'clock in the Tel Aviv time. So we would like to have the lunch or dinner break before today's highlighted keynote lecture by Professor Ilan Timotovich. But we would like to have the panelist group picture.
Yeah. Prashant.
Yeah, I'm here.
But we don't see you.
I'm here only, but I don't know why. Mauricio, can you add me from the screen?
Yes, we can hear you.
Mauricio, we can't hear you.
Mauricio, you are mute.
Yes. Wait a second, because I need to put in two groups, okay? I took the picture already with Elisenda. I'm gonna put out, okay? Then, obviously, I'm gonna put me out. Now Prashant, now the board members, okay?
Dario
is coming now.
Mauricio.
Yes. Wait a second. We're taking a lot of pictures.
We should do a reconstruction with all these pictures.
Yeah.
Okay, but to all the participants, we will be here in more or less 1 hour and 10 minutes.
Do you want that much of long break if you want to go on time for Ilan?
It's okay. We'll be in time because it should be 1 hour and 10 minutes.
Okay.
It's from let's say 00 to 10. 1 hour and 10 minutes.
1 hour 10 minutes or 1 hour 6 minutes? I think we will
1 hour and 10 minutes.
Okay.
Gregor and Daniela also here.
Yeah,
but
Daniela, I took Daniela has the camera off.
Yes.
Now it's
Elisenda.
on. No, I took Elisenda also. I took Elisenda.
Yeah,
I think that everyone.
A collage. We need to do a collage.
We need to do a collage. Ilan is here. He wants to appear. Come on, Ilan.
Come on
Yes.
stage. Hey, good.
Hey, Ilan.
You need
It
to
will
put
not
your
work.
mic on.
It will
You
not
need to
work.
put
It seems
your mic on. Unmute.
Unmute. Ilan, unmute.
Unmute.
right upright.
Okay, when is the lecture of Pilu?
In 1 hour and 10 minutes.
After
You need to put,
I give the presentation and then the lecture.
you give the presentation of Ila of Gianluigi. Okay, he gives his lecture, and after that issue will be your turn.
Okay.
So I think that it will be not possible to put all of us inside Mauricio.
I took the picture.
Mauricio, instead of
Took the pictures and Daniela, you wrote you are in Hebrew.
No, she's not in Hebrew.
The fetal brain is in Hebrew. It's from
reverse.
It's reverse.
Mirror. You have to make it a mirror image. Mirror on.
Hitus inversus.
Yes.
Okay,
Thank you,
confirm?
It was amazing.
Thank
it was
you.
fantastic.
Thank you to all of you. Gustavo, can you confirm to all the delegates the time that we need to come back, please?
We need to come back in 1 hour and 10 minutes.
Okay, perfect.
15
thank you.
and 10 minutes Israeli time. 1 hour and 10 minutes. Okay, don't disconnect yourself because if not, you will have a problem later on.
Okay.
Just
Remain connected, please.
Let's eat and drink. Bye.
The star on the screen. Bye-bye.
Bye. Mauricio, ¿me escuchás?
Llámame, sí, llámame.
No, yo quiero poner algo que me mandó Tidar, que quiere algo que hacen en junio. Lo voy a poner en la pantalla.
Okay.
Mauricio, would you please
Yes.
would you please tell Ilan to how to put the background?
Okay, I'm gonna call him. Okay, thank you.
Ilan, Mauricio is calling you. Okay.
Yes, Mauricio.
Yes, I'm gonna call you, Ilan.
Good.
Meanwhile, I'm gonna share, close the mix, and we are gonna share the information about the next session, okay?
No, quiero poner un minuto esto que la gente vea. ¿Me lo puedes poner?
Mauricio, no music?
Yes, of course. Go ahead.
No music?
Yes, music. I'm gonna add music right now.
Okay.
Mauricio, ¿ves esto?
Envíamelo y yo lo pongo ahora, ¿bueno?
Ahí está, ¿no está puesto?
No, envíamelo. Y yo lo pongo acá porque tengo que poner la música, ¿ok? Envíamelo. Bueno.
Dale. Ahí fue.
When I first saw you, I saw love. And the first time you touched me, I felt love. And after all this time, you're still the one I love. Yeah. Looks like we made it. Look how far we've come, my baby. We might have took the long way. We knew we'd get there someday. They said, I bet they'll never make it. But just look at us holding how far we've
I am in, but I don't want to. Here is when I turn on the camera. That's me. Okay. Now I turn it off, but I.
From this moment, life has begun.
Hi, Anna.
From this moment,
Hi, Anna.
you are the one. Right beside you is where I belong. From this moment on, from this moment, I have been blessed. I live only for your happiness and for your love. I give my last breath. From this moment on, I give my hand to you with all my heart. I can't wait to live my life with you hand in my hand, baby, don't ever look back. Let the world around us just fall apart. Baby, we can make it if we're heart to heart. And we can build this dream together, standing strong forever. Nothing's gonna stop us now. And if this world runs out of lovers, we'll still have each other.
Mauricio. Hola.
Dime.
¿Pusiste lo que te pedí? Un ratito.
Ya te lo pongo. Ya lo voy a poner.
¿Eh?
Ya lo voy a poner.
Gracias. Gracias.
flight. The moonlit wings reflect the stars that guide me towards salvation. I stopped an old man along the way, hoping to find some old forgotten words or ancient melodies. He turned to me as if to say, hurry boy, it's waiting there for you. Gotta take a lot to drag me away from you. There's nothing that 100 men or more could ever do. I bless the rains down in Africa. Gotta take some time to do the things we never dogs cry out in the night as they grow restless, longing for some solitary company. I know that I must do what's right, sure as Kilimanjaro rises like Olympus above the Serengeti. I seek to cure what's deep inside, frightened of this thing that I've become. Gonna take a lot to drag me away from you. There's nothing that 100 men or more could ever do. I guess the rains down in Africa. Gonna take some time to do the things we never
Mauricio,
Dime.
Bajalo lo que tenés puesto y poné el coso de la que está en mi presentación con lo que dice de la medalla de gold medal presente. Está en mi presentación, es el tercer o cuarto
¿Lo que dice
slide,
qué?
lo que yo te mandé de la opening ceremony.
La medalla. La placa. ¿Sí? Pongo la placa.
Baja la placa, sí, vos borra eso y ahora
Bueno,
ponemos la placa.
Ok.
Y faltando 5, los pones a Dari, a Ilan, a Gianluigi, a Prashant y a mí.
Ok.
Now I had the time of my life. No, I never felt like this before. Yes, I swear it's a truth, and I owe it all to you. 'Cause I had the time of my life, and I owe it all to you. I've been waiting for so long. Now I finally found someone to stand by me. We saw the writing on the wall as we felt this magical fantasy. Now with passion in our eyes. Time of my life. No, I never felt this way before. Yes, I swear it's the truth, and I owe it all to you. Time of my life. No, I never felt this way before. Yes, I swear it's the truth.
Puede poner que estén ellos también, que estén en grande, Mauricio. Estás en mudo.
¿Cómo?
Acá ahora la plaqueta.
No te oigo, tienes que hablar más duro. Dime.
Que aparezcamos, o sea, empezar así, en el momento de que yo empiece a hablar, leo lo que dice acá, después borrás esto y nos pones a nosotros cuatro, a mí, a Prashant, y,
Sí.
¿ok? A los cuatro que en grande.
A Gianluigi y a Ilan.
Sí, en grande.
Ok, dale.
Y después, entonces yo hablo, we will start with this one, Ilan. Afterwards, it will disappear and you will see the four of us, Prashant, you, Gianluigi, and myself, the four in the image, and I will tell you that you are invited to present the first gold medal to Ilan, to Gianluigi. Prashant is going to show you the medal, and we will let Gianluigi start with his conference.
Okay, guys. We start in 5 minutes, okay? Hi, Gianluigi. How are you?
Congratulations.
I am fine. Thank you so much.
Good to see you.
I'm very grateful for this.
Nina.
It's good to see you all, boys. I've been listening to the Congress, and
I know.
A very good one, very good presentation, lot of material. I'm impressed. It's a pity that you couldn't do it in Dubai. How is that?
I am in Abu Dhabi.
Mauricio, stop, everyone.
Me?
Everyone is hearing.
Do you hear me?
Yes. We can hear you.
But all the participants are hearing.
Oh, okay.
No, I'm fine. I think
Okay, we can start now, Gustavo. Go ahead.
No, it's another 4 minutes.
4 minutes. Yes. Okay.
Nice to
Hi,
see
Gianluigi.
you,
Nice to see
Gianluigi. Nice to hear you. Nice to see you. I didn't see you for a long time.
It's so good to see you, Ilan. Yes, it has been a long time. You haven't changed a bit, you know.
You
I'm
are
amazed.
lying. You are lying, and you will be prosecuted by the Trump administration.
No, it's true. You know, after a while, you stop changing at all. After a while, you reach a certain point, you don't change.
Trump is
Then there
okay
is a
with
certain
Italians. Trump is okay with Italians. Don't worry.
No, we have a very good prime minister. We like her very much.
Okay, very good.
She's, you know, navigating expertly in difficult waters. She's fantastic.
Yeah. As a matter of fact, just you should know, outside now is -4 degrees in New York, Celsius, -4 outside.
Well, Bologna is like 3, 4. Plus 3, 4, no more than that.
Plus. That's plus. I have minus.
But it is raining. It's very humid.
What is apparently bad is in Catalonia, they ask people to stay at home and don't go to the roads.
I won, guys. Here in Abu Dhabi, it's almost 20.
Yes, I know.
Yes. Also in Tel Aviv. In Tel Aviv, it's 18.
In Catalonia, it's snowing. That is not very usually here. So all the parts in Catalonia are snowing. Not in Barcelona, but yes, in the rest of Catalonia. So a little bit freezing. Not as in New York, but almost.
India is very
Okay.
hot.
In 1 minute.
Okay, Gustavo, whatever you want.
Yes, yes. We will wait exactly on 15 and 10 minutes. Participants are.
Okay, I am going to share now. Tell me.
No, no,
if-
no,
if
no,
it's-
no.
No,
Ilan.
wait.
No,
Wait.
no.
You
I'm
wait.
going to tell you when you can share, okay?
Good,
Please.
okay.
Nos pones a los 4, Mauricio.
Están los 4.
No,
más.
pero no los ven en chiquito. Tenés que
No,
sacar
pero
la.
cuando leas, ¿vas a leer primero la placa?
Y sacás la placa.
Exactamente. Eso es lo que voy a hacer.
Dale. Perfect. Okay. Hello, here we are back. And it's a big pleasure for me to present the true and unique Ilan Timor Trich. We have decided, the Fetal Brain Society has decided to honor him by letting making a gold medal in his honor for his pioneering contribution to the study of the fetal brain and his lasting impact on fetal medicine. Today, early in the morning, I present a short PowerPoint presentation showing what Ilan did, but he's going to tell to us later on much better what exactly he did for the fetal brain. So, Ilan, welcome.
Thank you for the presentation. And I would go, if you permit me, I will share my screen in order to be able to talk to Gianluigi a couple of words. Can I share?
Sí, déjalo.
Not yet. Let me, I'm gonna first stop sharing here.
In an instant.
Now
Wait.
you are there.
Okay. Now you are there. Go ahead, Ilan.
Now you can share.
Okay, do you see it?
No, you have to
We
share
see
it
you.
first.
Yes.
Yeah, now we see it. Make it full
Now
screen.
Okay, now you see it in big?
Yes.
Okay, very good. So basically, I'm looking at Gianluigi sitting quietly in his office, in his work scrubs, and preparing probably for another lecture. But let me tell you a little bit about this presentation. Well, I want to say to all my colleagues, friends, ladies, gentlemen, it is indeed a very special honor for me this day to present a gold medal for outstanding contribution of fetal brain research. And this is our field's highest recognition for lifetime contribution to the fetal brain imaging. And this goes to Professor Gianluigi Pilu, a scholar, clinician, teacher, whose work has profoundly shaped my, as well as our field's understanding of the human fetal brain. When we speak about progress in fetal neurosonography, we speak about an extraordinary journey, one that transformed a once mysterious organ, visible only as shadows on early sonograms that I will show in my lecture, into a living three-dimensional structure whose anatomy, growth, and pathology we can now follow week to week in utero. Few individuals have been as instrumental in this transformation as you, my friend Gianluigi. From Bologna to the international stage, you dedicated more than 3 decades to refining how we visualize, interpret, and understand the fetal brain, linking technological innovation with clinical insight and curiosity and compassion. Professor Pilu was about the earliest, if not the first, European leader to embrace transvaginal neurosonography in the early 1990s, demonstrating how high resolution and multiplanar imaging can reveal the dedicated architecture of the developing brain. Gianluigi, you helped define the median and coronal planes, which today are cornerstones of our fetal examination. Through your meticulous research, you taught us how to recognize the normal and abnormal appearance of the corpus callosum, the posterior fossa, the vermis, the brainstem, and others, whose evaluation once belonged only to postnatal or neuropathic studies. Your publications, many of them landmarks in ultrasound in obstetrics and gynecology prenatal diagnosis and the American Journal of Obstetrics and Gynecology, have all set the diagnostic standards that clinicians use across the world. You co-authored and co-chaired the ESOC practice guidelines on the sonographic examination of the fetal central nervous system, shaping what has become the global reference for performance of both the screening and the targeted fetal neurosonography. I had the privilege of working closely with you over the years, particularly through our joint efforts on the third edition of the Ultrasound of Freedom Bay. Your chapters in these books, with their illustrations, measurements, and nomograms, stand out for their clarity, anatomical precision, and deep clinical wisdom. But perhaps even more than your publication, it's your mentorship that defines your legacy. Generations of sonographers, obstetricians, and radiologists from Italy, Europe, and beyond have trained under your supervision at the University of Bologna. They describe you as demanding but generous teacher, rigorous in analysis, yet always ready to share credit and encourage discovery. For me personally, this recognition to present your award carries a profound meaning. Throughout my career, I believe that science is a collective effort. I have found not only a blind collaborator in you, but also a colleague whose dedication, integrity, and friendship have enriched this dialogue immensely. Our shared fascination with the fetal brain, its beauty, its fragility, its mysteries, has connected us through decades of research and discovery. Therefore, on behalf of our international community of fetal medicine specialists, neurosonographers, and perinatal scientists, it is my privilege to bestow the gold medal upon my friend and mentor, Professor Gianluigi Pilu. It honors not only your scientific achievement, but also the spirit of collaboration, curiosity, and clinical excellence that you have inspired all of us. Here is the medal. Gianluigi, add this new medal to the Iron Donald Gold Medal you received in 2007 by ISWAG, of which you were also a president. Dear Gianluigi, on behalf of our colleagues and students and around the world, congratulations, and thank you for helping us see, quite literally, the fetal brain in a new light.
Thank you very much, Ilan. You did it very well. Now we are going to show you the medal that you are going to receive, I think, by some kind of Federal Express in the near future. Prashant?
Yeah, this is the medal which reads like Second Fetal Brain World Congress Abu Dhabi 2026 Ilan Timor Trish Gold Medal. We have a photograph which is etched on a gold medal of Ilan Timor and Professor Ilan Timor, and this is what is written: Gianluigi Pilu, Ilan Timor Trish Gold Medal for outstanding contribution to the field of fetal brain research.
Congratulations.
Congratulations.
And this is what this is I think if you can read it, I need to stop the screen share. I don't think it'll be all visible. Okay, this is what which will be given sent to Professor Ilan Timor for installing the gold medal. This is a metal plaque which is going to be given to Professor Ilan Timor. If you can see, I think yes, I think you will see it now. This is what which is going to be shown to going to be given to Professor Ilan Timor Trish from Fetal Brain Society.
You can read now if you want. If you want, Prashant,
I will read it.
Okay.
I will read it. The Fetal Brain Society, the Ilan Timor Trish Gold Medal, instituted by the Fetal Brain Society to honor Professor Ilan Timor Trish for his pioneering contribution to the study of the fetal brain and his impact on fetal medicine. January 26, signed by Gustavo Malinger, founder president, and Prashant Acharya, founder secretary of the Fetal Brain Society. Thank you, sir. Thank you for honoring Fetal Brain Society also for the opportunity which you have given us. And again, thank you, Professor Pilu, for accepting the gold medal on his behalf. Thank you very much.
Thank you.
Now is your turn, Gianluigi.
Well, my dear friends and Ilan, I'm flattered and I'm extremely honored to receive this award. Honestly, I don't think I deserve it. I don't think I am worthy, but I am very pleased to accept it for two main reasons. Number one, because it is an award in the name of Ilan, and I always had the greatest respect for Ilan as a scientist, most of all as a friend and a human being. So having an award in his name is an excellent thing for me. Number two, I am very pleased because in a way it's a perfect closing act, because you may know that by the end of last year, I retired from my position into the hospital. I still have a few things to finish, but I plan to move out completely out of the field of medicine by the end of next year. And God willing, maybe do some other things. I was told that to have the award, I need to deliver a lecture, which I will be very glad to do. And I wondered, what should I tell you? I mean, this is a wonderful meeting and a lot of new interesting data. What can I tell you? Well, I thought that some of you at least may have some interest in my personal story and in the story of neurosonography, because they run parallel for a long period of time. Let me see if I can share my screen. Okay. I have to consent this. Share the screen.
Put his lecture, Mauricio.
Can you see this?
Okay, right now.
Yeah.
Wait a minute. Okay.
Can you see
now.
it?
Perfect.
Perfect.
Am I on? Can you hear me?
Yes.
Well, we may even call this "What is all about." Once upon a time, because it has been a long time, as you can see. This is me in the Bologna University in 1981. I had just graduated in medicine, and I entered into a residency in obstetrics and gynecology. You need to know that had not been my intention at first. I had been a very good student. I had very good remarks. And in that period of time, the brilliant students went to cardiology, because cardiology was really the cutting edge of medicine in that period of time. So I applied for an internship as a student into the Department of Cardiology and asked for preparing a medical thesis. And I attended the department for a couple of months, 2 or 3 months. And that was the most miserable time of my life, because there was not much technology in those years. Everything was done by auscultation. I had always been tone deaf, and I couldn't understand any of the murmurs, of the tones, of the sounds that the instructor was trying to make me understand. And I felt a complete moron. I was very depressed. And after a while, I decided that could not go on. And I started looking for something else. And a friend of mine suggested a probably position available in gynecology. And so I asked for the thesis in gynecology, and I started attending as a student, and I found that I enjoyed it enormously for many different reasons. Number one, we were all men in cardiology, and cardiologists to me have always been like the engineers of medicine, you know, very serious people, limited sense of humor, and they get bored very rapidly, very early. But in gynecology, there were a lot of girls, there were a lot of women, and that made the environment much more pleasing in many ways. Then there was surgery. I had never considered surgery before. I thought it was manual work. I was more the intellectual type. But I found that complex surgery, vaginal surgery, pelvic surgery, I enjoyed it, and I could perform it quite well. Then I was fascinated by labor and delivery. I mean, it has always been a fantastic experience for me to participate in that huge biological process. And I was thrilled by the complications, you know, the very severe complication, the need to make rapid decisions.
If you
Yes?
don't, it's okay.
Yes?
Because I can
Should I
then
go?
put it on because I'm listening it in my ears.
I wanted to see what the medal looks like because I tell you, the guy from India asked me to send him a picture. And I just want to see how he looks, if he used the picture that I gave him or not. That's all I
I'm not sure I understand. Yes?
Okay, go ahead.
You sure?
I'm sure. Ilan opened the mic, but now it's closed. Go ahead.
Okay, where was I? Well, I think I was at labor and delivery. And then, apart from that, I discovered that in the basement, they were keeping ultrasound machines. This brand new technology. There were two contact scanners, and I learned to use ultrasound by the contact scanner. And probably most of you have never seen one of those machines. It was a single crystal, and you had to sweep it over the belly of the patient, and you only produced static images. But then, when I arrived there, it was 1979. They had just bought two real-time machines, and you could see the features with the ultrasound machine. And I found that I enjoyed it very much, mostly because I was terrible with sounds, but I was very good with images. I had good eye-hand coordination, and I had pattern recognition. I could recognize patterns into the image. I could recognize the findings. And so, you know, all of a sudden, and unexpectedly, I had found my place in the universe. And I started to collaborate with the people who were there and producing papers. But the first papers that I produced, the first studies, in reality, were about gynecology, as you can see. And some of them were quite good. They were quite innovative. I'm very proud of this paper, using ultrasound to evaluate sexual maturations in premenarchal girls, which was a very important clinical tool for the pediatric endocrinologist. But then what happened was that in 1980 and 1981, a couple of papers came out, important papers, one from London, from Lindsay Allen, one from the United States, from New Haven, from Charlie Kleiman, papers demonstrating that you could see cardiac malformations with real-time ultrasound, which was very innovative. And it was very relevant because we had a huge pediatric cardiology department in our university hospital. But the problem was that probably, at least in those years, there was not a medical specialty that was more remote from cardiology than gynecology. You know, the attendings did not know a lot about the function and the anatomy of the heart. They could not read EKG. They were not even using a stethoscope. They were just a completely different world. But the director said, so my older colleagues were not very keen into going into fetal cardiac ultrasound. But the director said, we have the new guy here that was in cardiology before. Why don't we try for him to do this? He didn't know that I moved out of cardiology because of inability. But they gave me this assignment, and I started spending more and more times into the lab to figure out how you could study the fetal heart with ultrasound in the fetus, which was a very new thing at that period. And I started producing some papers, some of them, just to make an example. The one that you can see there, I think, was the first series that has been published about the use of the 4-chamber view for screening congenital heart disease. It was quite a new thing. Then what happened was that we were in the basement of the building, and in the top floor, in the 4th floor, there was neonatology. And people in neonatology that I was familiar with, they were friends, they came and said, there is a possibility to use ultrasound to see if there is bleeding in the head of preterms. Can you help us? Do you have the machine? You have the capability, and you can teach us how to operate the machine? I said, of course, I'm very interested in that. And we started performing the examination together. That was my approach to the fetal brain. And my approach to the brain was mostly that we were doing transfontanella ultrasound. I've been spending many days performing transfontanella ultrasound. So for me, the fetal brain has always been in the multiplanar approach. That was much before than vaginal sonography was introduced by Lan, much earlier than that. But you could do multiplanar scanning, even transabdominally, of course. And that's how I always felt that the brain should be evaluated. It was an unexplored field in that period of time. So I started producing papers about normative aspects of the fetal brain. The appearance of the brain, the appearance of the systems, how you could study the posterior fossa, and measurement, of course, measurement of the fetal cerebellum, measurement of the ventricular system, all these type of things. And as you can see, I've always been very proud about the drawings that I made personally to illustrate those papers. I've been very proud of that, and I'm sure that you have seen some of these images floating around, or reproduction of these in many different places. And then, of course, we started producing papers about the appearance of neural malformations, the agenesis of the corpus callosum, the holoprosencephaly, the dandiwork malformation, the closest spina bifida, septoptic dysplasia, these type of things. Again, it was an unexplored area, and so it was very easy to produce material. Just had to put on the ultrasound, and every day, every new day, you had something to write upon. I set up an operation that was mainly based upon this. I was lucky to work into a large hospital, one of the largest obstetric and pediatric hospitals in Italy, and so we got a lot of referrals of pregnancies in which there were abnormal ultrasound findings, and I started to scan these referrals, and of course, then I would have to match what I was seeing with the available knowledge, and in those years it was just the pediatric and the literature material. Come out the diagnosis, and of course then you had to counsel the couples, and that was one of the most important aspect of the work. And I did most of this by myself, because in a way it was difficult to find someone who has at the same time the patience to illustrate these findings to the people, to discuss with them, and then speak again. And also that counseling is not only about telling, but also is a lot about hearing. And it was very important for me for many ways, It was difficult because we had very limited information. Most of the times we only could say, the only thing that we can tell you is that the brain of your baby is different, but we don't really know what are the implications of this. There can be severe sequela or maybe not, and so, as you can imagine. But it was very important because having direct contact with these couples, having the possibility to remain in contact with them later on, gave perspective about the follow-up of these cases. Then, of course, you had to organize the follow-up because you were making the diagnosis and you need confirmation. I was very lucky about neurological assessment because the pediatricians already had a clinic going on in which they were periodically seeing and evaluating the preterm newborns, the growth restricted newborns, and they were assessing them very precisely with standard tests, quantitative analysis, and so that was very good. It was more difficult with anatomic confirmation. Number one, because particularly when you were dealing with termination of pregnancy, and there were many termination of pregnancy were dealing with cerebral malformation, that of course are scary for the couple. The brain of mid-trimester fetus is very fragile and it's very difficult to study it. And the pathologist took a lot of time to realize which were the best method to evaluate. In the end, they came out with the system, with the modality. But in the beginning, it was very difficult and very imprecise. Also, even diagnostic imaging in the beginning was not very helpful because it was mainly CAT scan that had limited resolution, and it was mainly done by adult neuroradiology that had limited experience with rare diseases, with pediatric diseases. So some mistakes were made, which I will deal on more in the following. Most of the papers that we have discussed before were produced in the 80s. Most of the material was collected 1981 through 1985, and production of the papers, they were published in 1987 through 1989. You have to remember that in those period of time, usually there was a lag, if you are lucky, of 1 year between the time that you were submitting a paper and the time that the paper was published, because everything was going on by mail, and then you had to be in the waiting list for the papers to be published. So it took quite a lot of time. In the 90s, we started to produce papers about the clinical significance of the findings that we had demonstrated in utero. The genesis of the corpus callosum, the ventriculomegaly, the intracranial hemorrhage, that were data that were produced by the pediatrician who were reviewing the infants with long-term follow-up. And I'm happy to say that most of these data have later been confirmed. In most of the cases, we were quite right. The experience has been confirmed in following publication, but not in all cases, because there were also failures. We made mistakes. And I think that many ways, there's always been my opinion. It is more interesting to discuss about failures than about success, because success, may be a matter of luck, but there is a lot of lessons to be learned from failures. And this, I think, was one of my greatest problems, a condition that I have struggled with for more than 40 years. I published my first paper on the Dandy Walker malformation in 1988, and I've been continuing publishing papers contradicting a bit the things that I was saying until very recently. Which was the problem? Well, of course, the first experience that we had was with this type of problem, very large posterior fossa fluid collection. And of course, if you have a very large posterior fossa fluid collection, then the worker is the first thing that comes to your mind. We also could demonstrate that with ultrasound, not only you were seeing that there was a cystic collection, but also that there was a cerebellar malformation. Of course, that is the type of resolution that we had in that period of time in the early 90s. But we could see that there was a malformation of the cerebellum in the axial plane with the two hemispheres separated and splayed apart and not a demonstrable vermis in between. That was an easy condition, of course, an easy thing to demonstrate. But the knowledge on the dandy worker was limited in that period of time. We mainly depend upon the classical papers on computer tomography, on the CAT scan produced by Harwood Nash and Fitz, that they recognized that they mainly relied upon actual views, and they recognized two entities. Now the terminology has completely changed, even the categorization has changed. But in those period of time, there was the dandy worker syndrome, which was cerebellar malformation with a very large posterior fossa cyst, and condition in which there was not a posterior fossa cyst, but there was a cerebellar malformation, is playing a part of the two cerebellar hemispheres with a seemingly communication between the fourth ventricle and the posterior, and that was called the dandy worker variant. And both condition and neurological implication. And we could replicate that finding, of course, with the machines that we had. A gap in the two hemisphere in the second trimester of the gestation, that in the sagittal plane corresponding to a cerebellar vermis that was displaced upward. And we consider this to represent a defect in the vermis, an incompletely formed vermis. And of course, we had some surprises later on. That was the first surprise that we got, because this was a case in which there were no other malformation, and we saw that there was the typical finding that suggestive of a dandy worker variant. And God forgive me, but I counseled this couple by telling them that the images were suggesting that there was a defect in the vermis, and we could not tell exactly what would be the implication, but there was the possibility that there were neurologic sequelae. Long discussion went on, and the couples were very uncertain, but in the end they decided to terminate the pregnancy. The pregnancy was terminated, and by this time our pathologist had developed a technique, a better technique to evaluate the fetal brain, and that is the pathologic specimen that they got, and we discussed that, and they said, you know, we don't think that this is a defect in the vermis. We can see the vermis, and it is perfect. It's completely intact. We can count each lobule, and the size looks normal to us. Most likely, there was a cyst in there that has been disrupted when we did the preparation, but this is not a defect in the vermis, and this could have been a completely normal boy. And just in that period of time, other people around the world wrote to me, because we had published the findings suggestive of dandy worker, and they reported a very similar experience, that they had thought that it was a dandy worker variant and the pregnancy had been terminated, or anyhow, after that, the diagnosis was not confirmed. So we started in the following to look more carefully at the brain of these fetuses, and we realized that when there was in the actual plane this gap in between the hemisphere, in reality, in the sagittal plane, what we could see was something that was looking very much like a normal vermis, only that it was mildly displaced upward. And that was confirmed after the baby was born, and these infants did quite well. We did not exactly know what it was this at that time. We thought it was some cystic collection in between the brainstem and the vermis. And the name to this condition was given later on by Dr. Robinson and Goldstein. This publication is from 2007, but they had reported preliminary material on this in a ISRO Congress much earlier than that. But the basis is that under normal condition, the posterior wall of the fourth ventricle, particularly the most distal portion, the portion that is distal to the choroid plexus, the posterior membranous area, that is the technical term, the one that is indicated with the red color in the slide. Under normal condition, this membrane forms an outpouch that is finger-like, just below the cerebellar vermis, which is a normal finding in second trimester in gestation. And for reasons that are unknown, sometimes this outpouch balloons out and dislocates superiorly the vermis. That is the term that is commonly used now to refer to this condition is either the Blake's pouch cyst or the upward rotation of the cerebellum. But if the cerebellar vermis is intact, then this is probably a normal variant. Now, telling the difference between a Blake's pouch cyst and the Dandy-Walker malformation is easy in many cases. You can compare these two images. In the second trimester of gestation, in the Dandy-Walker case, there is a huge posterior fossa collection, and the cerebellum has a vermis that is extraordinarily small. The brainstem is very thin, and there are additional malformation. There is hydrocephalus. So in this case, telling the difference is easy. But there are cases in which telling the difference can be quite difficult. You can see a comparison between one fetus that was confirmed to have a Blake's pouch cyst, that in fact underwent spontaneous remission, and a fetus that has a Dandy-Walker malformation at 20 weeks gestation. And telling the difference between the two is not that immediate. It's a bit of a problem. Now, if you have time, if you have the luxury that you live in a country where you have the possibility of terminating a pregnancy late in gestation, you can just wait. Just wait and see what happens. Because after the second trimester, usually the situation is much different. The Blake's pouch cyst will remain stable or will even undergo complete remission. In 40% of cases, there is complete remission with disappearance of the upward rotation of the cerebellum. While in the Walker malformation, usually the situation worsens. This is the same fetus. All images coming from the same fetus, ultrasound in the upper row and magnetic resonance image in the lower row. And as you can see, there is certainly significant progression between 21 weeks up to the time of birth, usually with a turning point around 25 to 26 weeks. The posterior fossa, the cystic collection increases in size, the posterior fossa becomes large, and the cerebellum becomes smaller and smaller relative to the size of the fetal head. But if you live in Italy, where the upper limit for termination of pregnancy is 20 weeks, you have to try the best that you can to make this diagnosis in early gestation. That is what we concentrated upon. Now, many papers have been written about this. I think that basically the differential diagnosis between those two entities is something that relies on subjective evaluation made by an expert. Using, whenever it is necessary, magnetic resonance. I'm not sure that magnetic resonance is necessarily better for diagnosing this condition, but certainly integrating the two is very important. I am adapted a neurological paper that has been published recently to sonology. If you try to make the differential diagnosis with sonography, I think that these are the findings that you should look for. Number one, whether the vermis is normal or not. Number two, the angle between the brainstem and the vermis. The aspect of the fastigium, the angle formed by the fastigium. And then probably, I believe, in my recent experience, the most objective and important finding of all, the position of the choroid plexus of the fourth ventricle. Let me review a little bit each of these. I've seen that you do not have the Dandy-Walker malformation in your program, so that may be an opportunity to review this condition. Now, verminal hypoplasia. At times, it is very obvious. The decrease in size of the vermis can even be established on a subjective basis. You can use a qualitative approach, identifying the different anatomic landmarks, such as the primary fissure, the fastigium of the fourth ventricle, and even measurement if you want. And again, at times it is obvious, at times the difference is not that clear. So this is just one of the findings. Again, diagnosing verminal hypoplasia at 20 weeks is complicated. Also because, as it has been reported recently, the choroid plexus of the fourth ventricle sticks close to the vermis, and differentiating them, separating them is not so easy. Now, what about the angle? We reported this a few years ago, and it was a very debated subject. Now, honestly, that was not my original idea. I have to give credit for this to Paolo Volpe, and I think he told me that the original suggestion came from Andrea Reghini, but I'm not sure of this. But even if we only collaborated bringing in our data, I think that this is a very brilliant concept. And as we used to say, when you bring a new concept into the field, usually the first thing that they tell you is that it is not true. Then, after a few years, they tell you, it is true, but it is not clinically useful. And then, after 10 years, they will tell you, it is true, it is clinically useful, but it is not new anymore. I'm happy to say that although this has been debated a lot, now most of the papers of the study that I see about the Dandy-Walker malformation include the measurement of the angle in the diagnosis of these cases. That has been our experience. It was a limited number of cases, but we could replicate even later on. And in general, what we could see is that the Blake's pouch cyst, despite the appearance that you may have in the actual plane, which is pretty much the same, Blake's pouch cyst generally is associated with a small angle, in most of the cases below 25 degrees, while the Dandy-Walker malformation usually associated with a much more relevant angle, more than 45 degrees. Now, I do not want to say, of course, that you can diagnose these two conditions just by measuring the angle, but I think it is very helpful, because if you have a degree which is less than 25, honestly, a Blake's pouch is a much more likely condition. While if you have a degree that is in excess of 35 or 45 degrees, you should be very cautious before saying that it is a Blake's pouch cyst, because it is a very unlikely condition. I have not found that the fastigium angle is particularly useful, because in general, even if the Blake's pouch cyst deresis is a bit difficult to visualize, and it tends to be quite flat. But of course, in cases in which you have, and those are the typical cases in which the vermin also looks small and there is significant rotation, in cases in which the angle is completely flat, of course, that is a strong argument in favor of a Dandy-Walker malformation. Let me elaborate a little bit on the choroid plexus of the fourth ventricle, which is a very interesting concept in this field. Of course, we are mostly familiar with the choroid plexus of the lateral ventricle, but there are choroid plexuses in each of the ventricles, into the third ventricle, and even in the fourth ventricle. Postnatally, in the adult, the choroid plexus of the fourth ventricle is found at the level of the membrane that is closing the fourth ventricle. But first of all, I would like to give credit to those people who brought this forward, because I think it's a very important concept. I think that Dario Palladini was the first one who described the choroid plexus of the fourth ventricle, particularly in the setting of Blake's pouch cyst. And Paolo Volpe more recently has demonstrated that the fourth ventricle has a different position in the Blake's pouch versus the Dandy-Walker malformation. We can see the choroid plexus of the fourth ventricle, of course, and the choroid plexus is a boundary, is a divide. It separates the posterior wall of the fourth ventricle into two areas. The anterior one, that is demarcated in blue right here, which is referred to as the anterior membranous area, and the posterior one. We have seen before that when you have the Blake's pouch cyst, you have an outpoaching of the posterior portion, the portion that is distal to the choroid plexus. Like in this case, you can see in the beginning, we can see the choroid plexus dangling down at the level of the posterior membrane of the fourth ventricle. Then the anterior membrane is incorporated into the expanding cerebellar vermis, and you can see the cerebellar vermis that is the choroid plexus is dangling down from the cerebellum, and in the end, around 20 weeks, usually the choroid plexus is squeezed in between the cerebellar vermis and the brainstem. And that is the appearance of the choroid plexus of the fourth ventricle. You can see that it forms sort of an incomplete circle. It's a semilunar shape around the neck of the Blake-Sporch cyst. In the axial plane, I hope you will recognize this echogenic area, which corresponds to the transverse bar of the choroid plexus. And at a slightly lower level, you can see the two pillars of the choroid plexus and the entrance to the Blake-Sporch. I will try to show you this clip. I hope it will work. This is a transvaginal scan in a normal fetus at 20-week gestation. And as you can see right here, we have the cerebellum with the vermis, the superior portion of the vermis. And as we go down, as we move caudally, we enter into the choroid plexus, that you can clearly recognize it because it is very bright, it is brightly echogenic. And then as you move more caudally, you can see that you're entering into the two pillars, the two lateral pillars of the choroid plexus, and you're entering into the Blake-Sporch right there. That is the normal appearance of the choroid plexus of the fourth ventricle. We have already seen that when you have a Blake-Sporch cyst, we have an expansion of the inferior portion, while the Dandy-Walker malformation, we know from classical study that is an expansion, is an outpoaching of the anterior portion, the portion of the membrane of the fourth ventricle that is found rostrally, superiorly to the choroid plexus. The problem is that this membrane is not only a membrane. In reality, it is a nursery of nerve cells that contribute to the formation of the inferior cerebellar vermis and also migrate into the brain to contribute to the formation of cortex and the basal ganglia. So the Dandy-Walker malformation is not simply an expansion of the posterior wall of the fourth ventricle, but it is a disruption of the originator of the inferior portion of the vermis and the formation also of the hemispheres. Now, when you have the Blake-Sporch cyst, you can see that there is expansion of the fourth ventricle below, caudally to the choroid plexus. While if you have a Dandy-Walker malformation, you have expansion of the superior portion, and as a consequence of that, the choroid plexus is displaced inferiorly. In the Blake-Sporch cyst, the choroid plexus is found at the entrance of the cyst. In the Dandy-Walker malformation, it is usually found in the floor of the cyst. A few images to demonstrate it. This is a Blake-Sporch cyst. That is the appearance transvaginally, the superior portion of the cerebellum. And then we enter into the Blake-Sporch cyst. And we can see the pillars of the choroid plexus that are around the neck of the Blake-Sporch. Again. What happens if you have the Dandy-Walker malformation? The choroid plexus is displaced downward and is found in the floor of the cyst. It is right there. Can you believe it? Well, you will believe it in the coronal view. You can see the two pillars of the choroid plexus that are stretched down in the floor of the cavity and meet, they come into close contact. And even in the axial view, you can have the same view. Honestly, I reviewed all the cases that I've seen recently of Dandy-Walker malformation. I reviewed the videos, I reviewed the volumes, And I could find this finding in all cases. I honestly doubt that there is one single ultrasound finding that is 100% accurate in diagnosing one condition. But in reality, in my experience, all cases that I reviewed had this finding very clear. This is true in late gestation, 30 weeks. We are moving down into the head. That is the cerebellum with the two hemispheres played apart. And I'm sure that you can see the choroid plexus, this bright line that is outlining the floor of the cyst. It's very obvious, sort of a Baroque appearance. This is the same case, 30-week gestation and after birth. And once again, as you can see, then the Walker malformation has a tendency to deteriorate with time going. Also very early in gestation. This is a fetus with trisomy 18, and there is clearly a fluid collection in the posterior fossa, and it is strange because you don't see the choroid plexus. You should see it in between, but you can see it very well if you scan. Actually, you see the bright outline of the cyst that is forming the floor. And this is a fetus with multiple anomalies at 14 weeks. And again, the bright contour of the cyst is very obvious. Even as early as 12 weeks gestation, as you can see. This 13 weeks of gestation, you have a fluid collection. You do not see in the axial plane the choroid plexus, but you can see it in the corona and in the axial view. Once again, a significant difference between these two entities, the Dandy Walker malformation with the bright pillars of the choroid plexus that are lining the floor of the cyst, and the Blake's pouch cyst, where the choroid plexus is close to the cerebellar vermis at the entrance of the Blake's pouch. Now, I think I may conclude this by saying that differentiating a Blake's pouch cyst from a Dandy Walker malformation in early gestation can be difficult. At times, it is extremely difficult. And an expert sonologist should consider a number of different findings, and everyone has his own formula. But these are the findings that are considered to be more valuable now. Of course, magnetic resonance is of help, but I think that for visualizing the choroid plexus, which I think is the most important clue that we have now, ultrasound may be better than the magnetic resonance. And with this, I would like to conclude this presentation. And thank you very much for giving me this opportunity and for awarding me with this prize. And for all of you that remain to the field, you have all my love. Thank you again.
Dear Gianluigi, first of all, congratulations. I am very happy that you are with us for the reasons you know. I am absolutely against your retirement. We are not going to let you, but I understand that you are more decided to do that. So I think that our chances to let you continue working are not very good. So enjoy your retirement, enjoy your family, and friends forever. Thank you very, very much. Now,
thank you.
Is it now is the turn to Ilan to give us his keynote lecture on his road to the fetal brain, but I think that his road to the fetal brain is probably the largest one. And Ilan, go ahead, and it's a pleasure for me to have you with us. I hope that your family also is there, best wishes and regards to Anna, and go ahead.
Do you see my lecture?
Yes, but you need to put in full presentation mode.
Yeah, I do.
Okay.
No.
Now we have
Okay,
it.
perfect.
Okay, go ahead.
So I'm deeply honored to give this lecture that I would point out that don't expect an academic lecture and not even part of it. And I loved Gianluigi's presentation, and I always learn a lot from his presentations, mainly also from juxtaposing his beautiful brain pictures by ultrasound to his own graphic art that explains well what is going to be seen. So he's a master teacher, and he always was, he always is. His chapters are full of his illustrations, and again, it's a pleasure to look at his work. So again, don't expect, here is mostly a different presentation that I will show out. It has two parts of it, and I will very clearly explain what I'm doing. First, I have to thank Gustavo and Mauricio, as well as the organizing committee, to honor me establishing a gold medal for outstanding contribution in the field of fetal brain disease in my name. And also, they let me to bestow this the first time at the Congress to my decades-long friend, Gianluigi Pilu. I'm also grateful to allow me to describe my eventful travel on the road of contributing even a small fragment to the field of ultrasound in the fetal brain. And my goal is also to encourage the new generation to perfect and further our beloved field. So my interest in ultrasound in general, in that of the fetal brain, was impacted by two major elements. First, my fellowship in Cleveland, Ohio, to study physiology of the fetal brain that we will be developing a little bit later in several slides. And second, introducing and popularizing transvaginal ultrasound, which was my tool in imaging the fetal brain and publishing about it. So let me talk about the first element, my fellowship in Cleveland, Ohio, since it's relevant to the fetal brain. First, I want to mention Ivan Zador, the biomedical engineer who was instrumental in shaping my interest in ultrasound and helped me very much to get a fellowship in the OBGYN department of Dr. Mortimer Rosen. This picture you see attached in Cleveland to study physiology of the fetal brain. I spent 2 years of my fellowship studying the physiology of the fetal brain, studying the role of fetal brain regulating fetal movement, fetal breathing, fetal sleep states. And I also mentioned here my good friend Leroy Dirker. He's retired by now, and that's a picture not when he was a fellow, but he was a co-field fellow and a co-author in the research. And he also introduced me in the way the United States is doing business in ultrasound and in general. My research project was the role of the fetal brain in coordinating fetal movements and heart activity, and this is pertinent to the non-stressed and the biophysical score as well as the fetal sleep states. And this was the first research into fetal movements regulated by the fetal brain. And I point out this and describe the kinds of fetal movement that I found. Then we provided that acceleration seen on the fetal heart rate monitors are indeed associated and coordinated fetal movements, one of the key elements of the biophysical score. We then realized the fetal breathing and analyzed it, another physiologic building block of the physiologic score, which also depends on the fetal brain integrity. And here you see an article on the regular and irregular human fetal-related movements in '79. We then put together the first ever article, fetal sleep tests, that Dr. Rosen was interested in. And this article made it into a book edited by Tom Eskes in the Netherlands about the classic articles in obstetrics and gynecology. Next was developing my major tool in my clinical research, namely the transvaginal ultrasound. After 3-year fellowship in Cleveland, I devoted almost 10 years practicing and applying and advancing transvaginal ultrasound in various aspects of OB and gynecology. Now you will see what I'm all about in this lecture. You will realize that a large part of this lecture is my soapbox talk, bragging, showing what I did. Many of you ask, what is a soapbox talk? Well, here is the explanation. It is picking up a box, in this case the soapbox, and standing on the corner of London's Hyde Park, in this called Orator's Corner, and give a speech, any kind of speech. These were mostly political speeches in London. I'm using it now for my medical reasons. You probably also realize that old folks talk a lot, and they talk a lot about their past career. This soapbox talk is part of my old fox syndrome. I did not want to acknowledge that I'm getting old, but then I got some reminders, and they were from the cemetery business right there, you see them. Well, I will try to delay the use of their services as much as I can. I will now start by talking on 2 journeys. The first one is how the bumps on my road were in trying to convince the OBGYN community that the transvaginal ultrasound is an extension your examining hand. The second one will be my path of the ultrasound of fetal brain. To prevent you from falling asleep, as you will see, I laced it with some humor. Yes, I think I had a bumpy load. And here is my disclaimer. I do not claim that I invented transvaginal ultrasound, neither that I used it first. I claim a small credit of working relentlessly to promote it and reach its rightful place in OBGYN ultrasound imaging. To tell the story of transvaginal ultrasound, I used the work of Joseph Wu, and that was a short history of the development of ultrasound in gynecology. Dr. Wu wrote that the roots of transvaginal ultrasound started with Alfred Kratochwil of Austria, who in the late 60s reported on fetal heart pulsation at 6 weeks using an A-mode vaginal scanner that you see here. A very interesting device. Although introduced in 65, the endovaginal transducer was forgotten for 20 years. And Dr. Joseph wrote, Moshe Bronstein in Haifa described in the 1990s, the use of transvaginal sonography in the first trimester. He also mentioned me there and said that in New York University, I published the first trimester on the first trimester, opening up a convincingly new area in fetal ultrasound, that of sonoembryology. He also credited me for organizing the first transvaginal courses, 3 of them, in the United States. But first and foremost, I acknowledge Moshe Bronstein, my collaborator. We picked up the vaginal probe, ran it with it, creating a whole new imaging category before anybody else became aware of it. There are no portraits of Moshe on the internet, but it is full with his images. And that was from 1984 and on. So here is a little story about my part in transvaginal sonography, and Rambam really was where I worked, the birthplace of the modern version of transvaginal ultrasound. How did I get my first transvaginal transducer? Returning from my fellowship, I was interested in ultrasound imaging. Elsint, which basically was a company that dedicated itself to hardware of the war, but also on imaging. And this was an Israeli electronics company. They started to manufacture ultrasound equipment and had a very small, thin, 5 to 6.5 megahertz pediatric cardiology transducer. Its high-resolution pictures had amazing clarity. I knew because its small size, it would be the right vaginal transducer for gynecologic and first trimester obstetric imaging. If it would have a handle, no handle, I said, no problem. I got one of those transducers and got creative. What do I need? I need the pediatrics transducer. I also need a couple of tongue depressors, some tape, a glove. I created the handle, I put tape around the handle, I took some gel, and I inserted the probe in a glove, and here was my first transducer probe. Then I asked the engineer of the Elsint, who was Zoran Barya, my good friend, for a commercially available probe to be assembled for me. In 2 months, in 1984, transvaginal Elsint probe was in my hands. I even got a transvaginal picture, a puncture attachment for oocyte retrieval and injection of ectopic pregnancies. The pictures were amazing, much better than those in the transabdominal transducer on my Elsint machine. Elsint gave me a t-shirt to go with the probe. My sonographers and my residents wore proudly them. In return, I provided Elsint with free advertising at my first marathon. Lately, if I run only with an ambulance in attendance. It is true. There were also other endovaginal transducers available at that time in 85, 86. 3 different endocavitary systems were the GE, the ATL, and the Philips. I give also credit where credit is due. The first articles were published in the USA by radiologist Schwimmer. There were not too many followers, and the radiologists embraced the transvaginal ultrasound much later because this was only for radiology use. Our first transvaginal article was submitted in 86, published in 87, and Gianluigi explained that it took a year to publish it because we used mail in order to get the conversation with journals. This was on the fallopian tube and also was the first mention of a tubal ring that is now a common term used. I also used the beads on a string term at that time. In 87, we submitted the light poster You remember them, I hope, and those who are old, you do remember. And this was on the use of the new transvaginal transducer, and that was at one of the AIUM annual meetings. Fleischer was at that time the person who then awarded the prizes, and I got the second prize for the poster. In August of '87, we submitted the article, The Technique of Transvaginal Sonography with the use of 6.5 megahertz transducer to JUM. The editor was George Leopold at that time. There was a fast reply in '87. It was rejected. No data, they said. It's only a descriptive article. This was my first bump in my publications. We were discouraged, but we aimed higher. And when we went to the American Journal of OBGYN, and the editor was Fred Zaspan, and submitted it in '87, it accepted in '88, but it still was only an opinion. And you see on the left lower side, the first sonographer in Israel, who I encircled with yellow, who was Sarit, and she was instrumental in helping me do this. We started to explore the use of transvaginal sonography in very early pregnancy in '86. And here is the first trimester anatomy pictures generated by transvaginal ultrasound. Then in '88, a close look at embryonic development with a high-frequency transducer, and here we used Dan Farine, who was our fellow at that time. Here is a story. Not many remember that even the facts about the setup, the double setup procedure in case of a suspected placenta previa. It consisted of digital palpatory examination through the cervix, feeling for placenta in a patient fully prepped for surgery in the operating room, ready to do the cesarean section if bleeding was encountered. It was an organized chaos in the operating room. 3 anesthesiologists, neonatologists, 2-3 units of blood, everybody full of tension. But at that time, I was wondering, is there a non-invasive way to diagnose placenta previa? How can we use the vaginal probe without causing bleeding? We modeled the use of the transvaginal probe after how porcupines mate without hurting each other. We speculated that they do it very, very carefully. So under direct vision, very carefully, we inserted the vaginal probe to see the cervix and the placenta, short of touching it. Then we evaluated the picture. It worked. There was no bleeding. Then we tested the waters floating the concept at an AIO meeting with a poster presentation. There were many, many skeptics. We submitted the article to the British Journal of OBGYN and in '88, and they answered immediately. This report appears to be the first on the use of transvaginal scanning in placenta previa. But it is not a substantial report, but it would stimulate coffee-rude discussion. How British. So we decided to expand and submit it to the AJOG. And here is the first article, Vaginal ultrasound for diagnosis of placenta previa. And we said, on the basis of the safety and advantages of this procedure as shown in this study, we encourage obstetricians to add transvaginal sonography to the transabdominal ultrasound for diagnosis of placenta previa. But there were still many skeptics. Then, to convince the skeptics, we did a study, and this was done with one of my medical students. And we said the angle between the cervix and the vaginal probe is sufficient to prevent a probe from inadvertently slipping it into the cervix. So let's go along. I was always believed when it comes to gynecology that transvaginal probe like an iron on your palpating fingers. Therefore, it was the right time to migrate the placing the transvaginal probe into the hands of the practitioners at large. So in 1990, with Steve Goldstein, we wrote 2 back-to-back articles in the American Journal of OBGYN on the office ultrasound of the transvaginal probe. I'm still not sure today if I'm convinced that practicing in the USA to have an ultrasound machine with a TV probe at the side of their examining table. Can this be considered a bump? I think it did. We summarized all in the first book on transvaginal ultrasound. But interesting, Europe adopted the use of the transvaginal probe well after Israel and the USA. Here is a little story to illustrate the European bumps. It was in 1990 at a conference that Kypros had. There was a debate about OBGYN imaging, Kypros versus Ilam. So here is me at the end of the debate. I hope I proved today that the TV probe can beat transabdominal probes in most cases of pelvic and first trimester imaging. Kypros said, Timur did not prove anything. We see everything with transabdominal ultrasound. Then I said, Kypros, please level with me. Give me one single reason for not using the transvaginal probe. There was a big silence and a long pause. And he said, because we do not have one. I rest my case, I said. The audience rewarded me with loud applause and things, but the ceiling collapsed on me. The case in point, in 1990, even a world leader such as Kypros does not yet believe in operated transvaginal ultrasound probe. This was a small European. After scores of articles, four books, I was hopeful that transvaginal ultrasound probe will be used increasingly in OB. And you see here all the books and the many editions. But then in 2002, I had a pleasant surprise. ISROG awarded me its highest honor, recognizing my work dedicated to transvaginal ultrasound. And John Hobbins gave me that medal. So in Europe and the world now, I traveled on a flat road. Now let's turn really to the fetal brain, which is today's conference. And this is the second part of the prize of perseverance. But first and foremost, credit to the pioneers. First out, the Fry brothers, who 56 years ago, published the first ultrasound visualization of the human brain. Then George Kossoff wrote his article in 72, and then a Czech article in 73, and finally Yuri Vladimirov in 75 published his physics article on the human brain. And then, of course, Stuart Campbell, who stepped on the platform and published a book in an article in 77. So the first published fetal brain malformation and anencephaly by transvaginal ultrasound was in 50 years ago by Campbell using a transabdominal transducer at 20 weeks. Then Shraga Rotem in Israel used the transvaginal transducer and did it after that, in 16 years after, in order to say the same. Both were published in the Lancet. Then a selection of our articles on ultrasound of the fetal brain came. We mentioned even to the smallest structures with a TV probe, and that was the appearance of embryonic structures with my fellow Wendy Warren. And you can see there that these embryonic structures were seen on the lower left side. Up to 20 weeks, we saw quite a lot of structures. We then introduced the term sonoembryology, an organ-oriented approach using a frequency of the vaginal probe in 1990, and explored the use of transvaginal ultrasound in the first trimester. And here are some of the pictures at 8 weeks and 3 days. And again, that you see that many of the pictures already pertain to the fetal brain. Then a transvaginal ultrasonic definition of the central nervous system in the first and early second trimester was published. And again, co-authors were my first MFM fellows that we had in Cleveland. And you see the pictures that we had, and you see even the imaging of the ventricular system from the third ventricle, the aqueduct into the posterior fossa on the middle picture. Then I really had to compare the imaging of the midbrain ventricular system with ultrasound technology 20 years apart. And you see on the left side, it is not shabby at all in 1991. Then in 2011, Nicolaides and Chowi showed a beautiful picture of the ventricular system. But I think that you can see that even the first one, many years before, was not that bad. We extended the transvaginal use to the second and third trimesters, and that was a first use. And you see some pictures of this article. And then several articles on the fetal brain were included also in our second edition transvaginal sonography. Already in 1990s, we started to evaluate the use of transvaginal sonography in the first trimester, well before everybody else that started to do that in the first trimester. And then in the early 1993, Gustavo Malinger stepped out to the arena of imaging the fetal brain with his meteoritic appearance and never looked back. His first article was about the corpus callosum, normal fetal development as shown by transvaginal sonography. And of course, Dr. Gianluigi Pilu already showed that he was an instrumental part at this time in fetal brain imaging. Now, this article alerted that the presence of echogenic amniotic fluid supports the diagnosis of exencephaly, anencephaly, and that was published in 1993. Probably the most important article on standardizing the scanning planes was in 1996, and it was entitled Transvaginal Fetal Neurosonography, Standardization of the Planes by Sections and Anatomic Landmark. This was our precursor of the 3D technique to scan the brain. Relying about previous experience of scanning embryos and fetuses, a series of publications on fetal neuroscan followed. Some of them were based upon applying the use of three-dimensional ultrasound, as you can see it right here. The new transducer technology was able to produce clear images in 3 planes, enabling the use of 3D in fetal brain scanning. Here is another article also by 3-dimensional transvaginal neurosonography, navigating in the volume scan. And another interesting teaching comparative article that we used, we described the transvaginal 3D in the normal brain by inversion rendering, and also showed the holoprosencephaly fetuses. You can see the anterior part of the brain that was a hallmark of the 3-dimensional of the diagnosis of holoprosencephaly. Here is also another article of the sonographic development of the the central nervous system using 2D and 3D transvaginal sonography. Our interest in fetal neurosonography culminated in publishing the first textbook with subsequent translations. One was in Italian and one was in Spanish, and you can see them right there. In 2001, there was a pleasant surprise. I was honored by the AIM to deliver the prestigious Fry lecture for my fetal brain research. And that was from fetal sleep states to transvaginal sonography. For the third edition, Gustavo Malinger and Gianluigi Pilu joined in. And you see the third edition of the book right there. The third edition was then translated by Mauricio Herrera in Spanish, and then there was a Chinese translation which Gustavo Malinger, traveling to China, popularized and showed right there in the middle picture that I present here. Finally, for the fourth edition, we asked Dario Palladini to contribute. He was generously accepted it, and his important articles and chapters appeared in this edition. Returning to my two goals in my career and summarizing them in the last slides. Despite all, after 39 years, it is clear that in the USA, as well as outside it, the transvaginal ultrasound probe is firmly in the hands of obstetricians and gynecologists, maternal fetal medicine specialists, and radiologists. As for my interest in the fetal brain, I hope that with the tremendous help and support of my close friends, I contributed to the understanding of the evaluation of the fetal brain. When I look back at my professional life, it dawned on me that my road was not so much bumpy as it was tortuous. However, in a tortuous fashion, it slowly brought me to increasingly high levels of achievement. I end with my homage and my thank you to those who taught me. I will not keep on these pictures for too long, but there you have all my friends on the shoulders of whom I am standing, and I was standing over the many years. They are there, and a heartfelt thank you to everybody. Finally, I thank my entire family for their undivided support throughout my career. So let me end and say that here are my two most important tools, transvaginal sonography and the fetal brain. Thank you very much for listening.
Wow. Thank you, Ilan. I am quite emotional from your lecture. Fantastic one. I think that we are going to keep this lecture forever. It will be part of the history of the development of ultrasound and ultrasound of the fetal brain. Over the years, it was a pleasure to be with you. Our relationship starts not very easily, but eventually we reach a very nice point of understanding. Please, if there is someone else that want to say a few words, do it now.
Dr. Gianluigi, please, you want to say something?
Well, Ilan has always been an inspiration for me since the very beginning. And I honestly think that the work that he has done introducing clinically vaginal ultrasound has been the greatest development that we have had in the field of imaging of ultrasound since the original of the story. I mean, vaginal ultrasound has become, so great, so important, and not only for fetal neurosonography, but for any part. And Ilan has been the one who heralded this. So we must all be very grateful for it, and also we must be grateful for the great passion that he has been able to use in his work. I think that was a source of inspiration for any of us. Ilan, thank you so much for everything.
Karina?
I just want to say that as part of the new generation that has been inspired by you, it is we got emotional hearing you guys, and it is a great honor to follow your first steps, and I hope we honor everything that you have constructed, discovered, proposed, and so passionately proposed to every one of us. So thank you so much. We cannot be more honored than being part. It's a pity that we cannot hug you on site, but thank you so much for your presentation, Gianluigi. If you do not regret in the end of the year, so we wish you lots of happiness and good health, and everything you choose to do next that you do with the same passion that you have done until now.
Professor Timur, Ilan Timur, I would put it across as any obstetrician who is working right now, any emergencies, anything in obstetric and gynecology without transvaginal probe, obstetrics or fetal ultrasound is impossible now. So that's, I think, because of you now world and the entire population is getting credit to it. Adding many new dimensions, Dr. Pilu, thank you again for adding such a new dimension to fetal ultrasound that you have added in the recent times. Thank you, sir, and thank you, Professor Ilan Timur.
So we have finished our first day, and we are going to rejoin tomorrow, 8 a.m. Israel time, and you have also the times in other countries. Will be a very interesting day. We will start with fetal, with migration disorders, with new and different speakers, also from the field of pediatric neurology. And I hope you will be here and will be able to enjoy the conference as we enjoy the conference today. Thank you very much. Thank you, Ilan. Thank you, Gianluigi. Thank you to all the board members, and special thank you to Mauricio that went through all this day having a lot of stress regarding the transmission, that eventually it went perfectly. Thank you to all of you.
Thank you.
And see you tomorrow.
See you tomorrow. I have both your addresses, Professor Ilan Timur Trish and Professor Gianluigi Pilu. I'm going to send it across the medal as well as the plaque, metal plaque to both of you. I think I'll curate it by tomorrow. You'll get it by next week. Thank you very much. Thank you, sir.
Thank you, everybody. Love you.
Thank you to the more than 1,000 people being online during the whole day, which is amazing. And we hope to see everyone tomorrow.
Unbelievable.
Thank you.
Bye.